السلام عليكم، صباح الخير.
وعليكم
هلا
السلام
أسأل.
ورحمة الله صباح النور. وعليكم
هلا
السلام
أسأل.
ورحمة الله صباح النور. مرحبا دكتور مختار.
السلام عليكم، صبحكم الله بالخير، جمعة مباركة إن شاء الله على الجميع. حياكم الله.
مبارك علينا وعليك إن شاء الله.
أهلا.
بس محاضرتك جاهزة دكتور؟
إي نعم، إن شاء الله أنا جاهز وجاهز
أوكي،
لمشاركة
خلاص أون تايم إن شاء
البرزنتيشن.
الله 9 إن شاء الله.
على خير إن شاء الله، شكرا.
على خير. مشكور.
Distinguished faculty, esteemed colleagues, and dear friends, good morning and welcome back. Yesterday set a high standard of scientific excellence and meaningful dialogue. Today, we build upon that foundation with a program designed to explore the latest advances in gene therapy, iron metabolism, coagulation, and transfusion medicine. This conference brings together some of the most respected minds in our field. Your presence here reflects a shared commitment to advancing care for patients with complex hematological disorders. I encourage you to engage actively, challenge perspectives, and draw inspirations from the expertise gathered in this virtual room. Welcome to day 2, and let us make it a day of insight and impact. Thank you. And we'll start with the first speaker, Dr. Mukhtar Bouhlega, Medical Director, Transfusion Service and Blood Bank, Maternity and Children's Hospital, Dammam. A steadfast leader in transfusion medicine, ensuring operational excellence and the highest safety standards in blood banking and therapeutic transfusion services. اتفضل دكتور مختار. دكتور مختار.
Assalamu alaikum. Good morning. So I will just share my slides.
Please.
Okay, Dr. Najat, are my slides clear to see?
Yes, clear.
Yes, yes.
Okay, good. Good morning, everyone. Assalamu alaikum jami'an. It is an honor and a pleasure to present before you, dear colleagues, on this day. My gratitude and thanks to the organizing committee, as well as the respected speakers and attendants as well. In my talk, I named it Beyond the NTD and Modern HDFN in the Era of Molecular Immunohematology. And I wanted to speak on this matter with a point of view of transfusion medicine as a colleague, because I am an MD, a physician MD, and we are the connection between our colleagues in the medical field and our colleagues in the laboratory as well. In my opinion, it's an important topic because NTD prevention nowadays reduced the classical RHD, hemolytic disease of the fetus and newborn. But still, clinically, it is, sorry, are we still on? Or have I? Okay, the slides are still clear, right? Yeah, because the clinically still the severe autoimmune disease persists. Nowadays, the modern risk is concentrated not in the NTD itself, but the NTD failure to diagnose complex Rh antibodies and multiple antibody mixtures. The molecular fetal antigen testing and the Doppler surveillance have changed the workflow and how to deal and manage these kind of cases and patients. Now, according to the WHO, the ABO incompatibility occurs in approximately 20% of pregnancies, but only about 1% develop clinically significant hemolytic disease of the fetus and newborn. Overall, the HDFN prevalence is estimated to be around 1,700 per 100,000 live births, which is 1.7%. The antibody distribution as a cause of the HDFN cases, the ABO antibodies account for 78%, which is the majority. The RH antibody, this means the D antigen, as well as the big C, small c, big E, and small e, account for 4%, and 18% are due to the other antibodies, like the KEL antibody, Duffy, and KID, and others. According to the WHO, the severe neonatal jaundice causes a disproportionate morbidity and mortality in low and middle income countries. Among the hospitalized neonates, the severe neonatal jaundice prevalence ranges from around 0.7% to 3.3%. The highest burdens are reported in Africa, Southeast Asia, and the East Mediterranean region, which is our region. The jaundice-related mortality is remaining highest in the Eastern Mediterranean region, as well as the African and South Asian as well. It has a big burden. So around 60% of the term neonates and 80% of preterm neonates develop jaundice during the first week of life. The neonatal jaundice actually remains one of the most common causes of neonatal readmission as well, on a worldwide scale. It has a global burden of around 2 million prevalent cases of hemolytic disease and neonatal jaundice that occurred according to some statistics in 2021. These conditions accounted for approximately 3.7 million disability-adjusted life years worldwide. Now, why I think that our colleagues in the hematology field should care. The severe HDFN nowadays is increasing, but it's not associated to the NTD, as we said before. It's actually due to the anti-KEL, anti-small c, anti-big E, and multiple alloantibodies as well. These pregnancies may require fetal genotyping, some of the diagnostic or the new diagnostic modalities, MCA Doppler surveillance, intrauterine transfusion, and neonatal exchange transfusion as well. Historically speaking, before the NTD prophylaxis, the RH-related HDFN was a major cause of fetal and neonatal mortality. But after the introduction of the RH immunoglobulin prophylaxis, it has decreased dramatically worldwide. In the United States alone, the prevalence fell from around 106 per 100,000 births in the 80s to much lower rates, which is around 44 per 100,000 live births. And if we compare those 44 per 100,000 to us, it's around 1657 per 100 live births, which is quite high in the Eastern Mediterranean region. So my key message here is that, yes, we have largely controlled the NTD disease in some parts of the world, but still it's a challenge, and there's a future challenge as well, which is the non-dealuminization. And if we can see here from the table that in the 60s, in the era of the 60s, yes, we've had the NTD as a dominant problem, but in the 80s, it had started declining after the introduction of the RH prophylaxis. And from the 2000s onwards, we have been dealing with the mixed alloantibodies and the other antibodies as well. The disease model is quite known for us. It starts with the maternal IgG, the maternal immunoglobulin of the G type, in which it crosses the placenta and causes the fetal RBC destruction, or goes into the erythroid as a target for it. further on, it causes the anemia and the heart drops as well. From the picture here, you can see that the problem starts at the first pregnancy, in which there is a contamination between the fetal blood with the maternal blood. The mother gets sensitized, and by the second pregnancy, the effects of the aluminization occur on the fetus. But these changes, starting from the first pregnancy, are for some group of antibodies. Yeah, but let's say the mother is a blood group O, in which she has isoagglutinins of the anti-A and anti-B sort. This means that the sensitization could occur from the first pregnancy, and the effects of HDFN occur at the same pregnancy as well. That's why we have to have a good communication between us clinicians and our colleagues in the labs of the blood banks. In some cases, the HDFN is not only hemolysis that occurs by the fetus. Some antibodies produce anemia through erythroid suppression as well. There are many antibodies that matter, and as we all know, the anti-D is one of the most important, yes. The anti-small c can cause a severe HDFN, which is very clinically significant. The anti-KEL as well. And what's so special about anti-KEL is that it causes an erythropoietic suppression. And we'll speak on that a bit later on. The anti-big E, the anti-big C can cause moderate to severe HDFN, and the risk actually increases in combination between these two antibodies. There are some other antibodies that have their own challenges as well, like the anti-Duffy A, anti-KID A, and anti-M as well. The anti-K, we have to be aware of it. So anti-K is not, does have a behavior, but not similar to the anti-D. The anti-D primarily causes immune destruction of the circulating fetal RBCs, but the anti-K can suppress the erythroid progenitors, so the anemia will be disproportionate to the bilirubin or the hemolysis, the bilirubin level or the hemolysis after birth by the fetus. The tighter correlation as well can help in some antibodies like the anti-D, anti-small c, anti-big E, but it doesn't help that much with the anti-KEL. That's why in some centers, once the anti-KEL is detected, there's gonna be an early fetal medicine involvement, and they will follow up on the patient and the fetus wellness as soon as possible. Anti-small c and some antibody combinations are among the very important antibodies, like we said before, that could cause severe fetal anemia. There are multiple antibodies as well we have to keep in mind, especially if we're gonna deal with intrauterine transfusion and neonatal exchange afterwards. Anti-G is one of the most important antibodies as well, and it's rarely spoken about. What's so special about anti-G is that the G antigen is expressed by an individual when they have the D antigen or the big C antigen on the surface of their own RBCs, or both. There is a serum pattern that we can see by the lab, and we have to make sure to detect this antigen once we suspect it. Why? Because it has to do with the RH immunoglobulin eligibility of prophylaxis eligibility in the pregnancy. Because the presence of this antibody might mask if the patient has an anti-D or not. The diagnostic tool that we use at the blood bank is called the differential adsorption elution test. and in which we differentiate by this technique whether the patient, first of all, is a D antigen positive or negative, if they are big C positive or negative, and consequently if the antibody is an anti-D, anti-big C, or an anti-G as well. The maternal investigation algorithm that we work with is that we book the patient for the AB1 RHD, or in other words, the basic workup at the blood bank. When we do the antibody screening and detect any antibody, it will be identified and differentiated. And once we know which antibody, then we check if the titer plays a role here or not. We will quantify it and inform the physicians as well. A next step is, depending on the centers, of course, they might ask for the paternal partner for the testing, or they would go for fetal antigen status. And so there is some sort of a shift in from antibody detection alone to all the way to risk stratification and antigen in an antigen positive fetus. If the corresponding antigen was detected, for example, in the fetal blood, then as we said before, the patient will be taken care of, and with another diagnostic tool, for example, like the MCA surveillance, and afterwards with the intrauterine transfusion if needed, and exchange as well. As for the titers, they can be useful, yes, according to the antibody. So there are critical thresholds that vary by the antibody itself and the method that's used at the blood bank. The titer is only a serial change that's often more informative than a single value. So you need a sequential titer tests. Some centers ask for a bi-weekly or every 3 weeks to do the titer, depending on the cases. The antical, as we said before, is a major exception of that rule, because the severe anemia could occur at the fetus even with low titers. Prior affected pregnancies sometimes play a role as well. The paternal and the fetal antigen assessment, like we said, if the fetus lacks the corresponding antigen, the HDFN, or hemolytic disease of fetus and newborn risk, from that antibody is effectively removed. But if they have it, then we have a strong suspicion that yes, this is the case. The paternal phenotype or genotype might help, but fetal genotyping is way much better. It's more accurate, and some centers don't like to involve the paternal side during the testings, but it's according to their policies. Of course, these kind of tests can avoid unnecessary high-risk surveillance, and some major PBM and fetal medicine. There is a major patient blood management benefits that can be gained as well through using these kind of tests. Just as a reminder for our colleagues, because during the blood grouping and the testing of the patients, sometimes you end up with having two parents which are RHD positive, but still you can have an RH negative fetus. That's why some clinicians might have a misunderstanding that how could have this happened. but it actually does, according to the hereditary rules that we all know about. So it's a possibility, yeah, and to make sure the fetal genotyping is the best accurate way to diagnose. Now, the non-invasive fetal genotyping is the newest modality, as we said before. So it's the maternal plasma has a cell-free DNA, which is the fetal DNA. It can determine the RH positive of the fetus and some selected non-D antigens. It's mostly useful for the RHD, the RH big C, small c big E, small e as well, and the kill. There are newer assays that include some broader antigen panels depending on the centers that are around. The implementation, of course, differs between some of these countries in Europe or in North America and some other parts of the world. But the direction is always the same, in which just like what's seen here by the picture here, that the cell-free DNA can be detected. It can be differentiated from the maternal and from the fetal. The fetal then will be tested, and the typing will be done for the rhesus antigens. It's recommended by the American Society of Hematology as a part of the diagnostic tools as well, and it's important to mention that the cell-free fetal DNA can be detected as early as 11 weeks of gestation. Afterwards, the fetus can be monitored using the ultrasound by detecting the middle cerebral artery, and the peak systolic velocity is the major non-invasive screening for the fetal anemia. Once the MCA is detected at higher than 1.5 multiples of the median, then there is a strong association that this fetus could be anemic, and then the more specialized care can be taken place. This kind of modality has replaced much of the older invasive serial amniocentesis approaches in detecting the anemia in the fetus. Now, when the fetal anemia is suspected and escalated by the MCA PSV surveillance, and the moderate or severe anemia or the hydrops was developed, the chordocentesis can confirm the fetal hemoglobin, yes, but it should be reserved only if intrauterine transfusion was indicated. There are, of course, the question of risk versus benefit, depending on the gestational age, the technical expertise, and some prior disease severities as well. The intrauterine transfusion, of course, the blood product must be antigen negative for the maternal antibody and compatible with the maternal plasma as well. The blood should be cytomegalovirus safe, which is mostly the case around the region, in which all of the blood products nowadays are filtered during collection from the donors. And the filters are very effective in removing more than 99.9% of the WBCs. They should be irradiated hemoglobin S negative with high hematocrit according to the local guidelines, of course. The blood bank should be informed and must prepare for cellular procedures as well, not one isolated transfusion. The blood, as we said, should be antigen negative to avoid the immediate destruction of the RBCs. Should be irradiated to prevent the transfusion associated graft versus host disease. It should be a CMV safe to reduce the CMV transmission risk, and HBS negative, of course, to optimize the oxygen delivery and avoid sickling. As for the delivery planning, we should always keep in mind avoiding a neonatal blood emergency, in which we plan the delivery at the center within neonatology, transfusion medicine, and fetal medicine coverage as well. We should pre-notify the blood bank when the severe antibody is detected, if there's a recent intrauterine transfusion high drops or likely exchange that is present. The blood banks should prepare phenotype compatible exchange blood, of course, before the delivery is planned. The neonates are evaluated with the basic tests like ABORH, direct antiglobulin test, hemoglobin and hematocrit, a bilirubin trend as well, the retics, and the smear as needed. The direct antiglobulin test strength does not always reliably predict the clinical severity, and the bilirubin trajectory and anemia, yes, matter, but in the anti-K disease, anti-Kel disease, there might be some severe anemia, but less of a bilirubin trajectory than expected. Now, for the exchange transfusion nowadays in 2026, it's, yes, less common than historically before, but still is a life-saving competency. There are indications which the hyperbilirubinemia is one of them. And in my opinion, that every blood bank should have the capacity to perform a reconstituted blood to be used for the exchange if needed. There are modern practices with precise blood selection and coordinated neonatal monitoring. At least the basics should be present as well. Now, there's a question on how can I do the reconstitution of the blood that can be used for the exchange. So there are many centers in which they do like a back of the envelope calculation on how much plasma to be added to the packed RBC, but actually, if we're speaking about standardization and working by policies and recommendations, there are some formulas and step-by-step procedures to make sure that the reconstituted blood is according or to the highest standard, in which what we do in our blood bank, we take the blood bag. Some blood banks write how much ml inside the bag, but to make sure you should do it on your own, in which you will weigh in the bag and then subtract the weight of the plastic bag. You convert the whole weight into ml. Then you do some simple math to calculate how much plasma to be added, and then can be prepared for the manual exchange. Of course, there are many indications, and this procedure has been documented even since the 70s. For example, it was used for poisoning, drug poisoning like digoxin poisoning, paracetamol poisoning, vancomycin overdose as well with good results. It was used for lead poisoning, malaria as well. And it was successful in neonatal hemochromatosis as well as gestational alloimmune liver disease, severe hypertriglyceridemia as well. But unfortunately, it wasn't as good in managing neonatal sepsis, and here are some documented cases as well. Now, for the blood to be selected for neonatal exchange, you should be aware of the maternal anti-D. It has to be D negative RBCs and compatible with the maternal plasma, like we said before. If the antibody was anti-K, it should be K negative RBCs. If there are multiple antibodies by the mother that can be causing the HDFN by the fetus, they all should be taken care of, especially the clinically relevant ones. And yeah, so even if there was a recent intrauterine transfusion, this should be accounted for, even if it's possible, going all the way to knowing the phenotype of the donor. As for the anemia, the HDFN does not end at the discharge. The late anemia can occur after intrauterine transfusion or an ongoing antibody-mediated RBC destruction as well. We should follow up on the hemoglobin, the retics, and the bilirubin as clinically indicated. And long-term outcomes after the severe HDFN are generally improving, but still require some structured follow-up. The neonates and children, this is as a reminder, are not small adults. They have their own thresholds, they have their own component modification and adverse event profile as well. Yes, the restrictive pediatric RBC transfusion is nowadays the standard, as recommended by patient blood management recommendations by many national and international bodies, but mainly in stable critically ill children. But the HDFN, the exchange, and the intrauterine transfusion are separate high-risk scenarios. They have their own rules. Of course, the blood bank information systems, health information systems can help by forcing indications, component modification, and antibody history for all physicians and lab scientists as well, to help in guiding the management and treatment. As a take-home message, I would love to say that NTD prevention, yes, changed the HDFN, but it didn't eliminate the severe alloimmune fetal anemia. There are antibodies like NTK have their own behavior. There are antibodies like anti-small c and some other Rh antibodies. They require deliberate stratification. The new modalities like fetal antigen genotyping and MCA doubler should be easy access for the physicians. And yes, they define who truly needs the intensive monitoring later on. The correct blood selection with the correct preparation for either the intrauterine transfusion or the fetal exchange is where transfusion medicine can directly change some of the outcomes. Thank you for listening, and it was a pleasure. Thank you very much.
Thank you so much, Dr. Mukhtar, for the excellent presentation. We move to the, there is no questions for you. So we'll move to the next speaker. So the next speaker is Dr. Zainab Khan. She's a consultant clinical anatomical pathologist, Salmania Medical Complex, Bahrain, American board certified in blood banking and transfusion medicine, an active leader in the global pathology community, serving as Eastern Mediterranean representative and secretary of the ISBT Young Professional Council. Dr. Harb is dedicated to advancing standards in transfusion medicine. Welcome, Dr. Harb.
Thank you so much, Dr. Najat, for the welcoming me into this conference. Can you hear me well?
Yes.
Okay, so let me share my presentation. Can you see my presentation? No, just a minute. Can you see it on the screen?
Yeah.
All right, perfect. Thank you so much, Dr. Najat, for the invitation to participate in this conference. And it's my pleasure to present in front of my clinical colleagues, especially as a physician in blood banking, transfusion medicine. I would like to take it as an opportunity to share my point of view in transfusion and sickle cell disease with my clinical colleagues in hematology. So let's start. In my presentation, I will cover 6 main areas. One is the importance of transfusion in sickle cell disease and why we need it and what types of transfusions we have. And then second will be, since we are talking about transfusion-associated alloimmunization, why alloimmunization happens in the sickle cell disease settings, and what are the incidence and the prevalence and the risk factors in general, as well as in pediatric patients. And then we'll talk about the clinical consequences of alloimmunization and the strategy of antigen matching, and last about the prevention and management. So we all know that transfusion is a central intervention, or it's a cornerstone therapy in sickle cell disease, and honestly, it will continue to be. So most of the sickle cell disease patients have already received one, or they will receive blood transfusion by the time they reach adulthood. But when we look into the evidence that supports the transfusion in sickle cell disease, the evidence is kind of variable. There is a strong evidence that supports the transfusion in some settings, like primary and secondary stroke prevention. But in the rest of indications, majority are dependent on expert consensus. And generally, that is all because that we have some kind of limited guidance or shortage of well-designed studies that helps put clear management guidelines for all complications of sickle cell disease that might require transfusion or transfusion can be helpful in. And as we know, part of giving a blood transfusion to sickle cell disease patient is to kind of reduce the morbidity and the mortality associated with complications. But we have always to be a little bit careful, because transfusion comes with itself by complications, and those will include alloimmunization, which is number one complication, and then hemolytic reactions, and of course iron overload. So what are the goals of a transfusion in sickle cell disease? There are 2 main goals. One is to improve the oxygenation and to raise the oxygen carrying capacity, and that will help relieve the symptoms of anemia in patients with symptomatic anemia and sickle cell disease. And the other one is to reduce the hemoglobin S production by increasing the hematocrit or suppress the endogenous or hematopoietic cells that contains hemoglobin S. And the transfusion can occur for patient used either as an acute setting or episodic. So we use it for when we try to prepare patients for preoperatively for some surgeries or to treat acute complications. Or it can be part of their chronic therapy if we would like to maintain a lower hemoglobin S level, for instance, in the case of the prevention of a primary or secondary stroke prevention. Usually we look into the guidelines support we target maintaining hemoglobin S to be below than 30%, or hemoglobin levels to be between 10 to 12 maximum, depending on the indication. But we also have to be careful not to raise the hemoglobin above that level, because we will increase the risk of hyperviscosity and more complications. In sickle cell disease, transfusion can be either simple transfusion, or we have the other modality of transfusion, which is in the procedure of red cell exchange. Simple transfusion is basically we are just giving single units to the patient. And in pediatrics, we are talking about, we don't use units. We quantify the blood transfusion by we dose it at 10 to 15 ml per kg. So simple transfusion, it just doesn't require any special equipment. It's easy to do. We just have like a peripheral access. We use like fewer units. But then if we give blood to the sickle cell disease patients, the patient will be at risk of volume overload, iron overload with time, and increased risk of hyperviscosity. On the other side, if we do red cell exchange, which can be either automated or manual, we will have a better control of the hemoglobin S. We will reduce the hemoglobin S while maintaining the hematocrit. We will limit the iron overload. But the main draw is that we need like kind of two peripheral line access or like central access, especially in pediatric patients. There is some evidence that it might not increase the alloimmunization risk versus the simple transfusion. And since we decrease the hemoglobin S levels in the patient, it will reduce the number of hospitalizations. Coming to the isovolemic hemodilution, it's kind of a special customization of the red cell exchange procedure where we do a saline or albumin replacement initially at the initial stage of RBC exchange. By that, we kind of reduce the units that we use per exchange. Like we have to avoid it in certain situations, like a recent or severe cerebrovascular or cardiopulmonary disease. And the evidence that supports that is kind of like not controversial versus like the standard red cell exchange. But it's one of the like customization that we can use it to at least reduce the number of units that we use per exchange. In sickle cell disease for transfusion, we have some established absolute indications that are agreed upon. It's either for acute anemia in cases of like parvovirus aplasia, splenic or hepatic sequestration, or to rapidly reduce the hemoglobin S, and that we need it in the cases of stroke, acute chest syndrome, multi-organ failure. So generally, we have to base the transfusion on the symptoms. If we have symptomatic anemia rather than the number or the value of the hemoglobin, so it's whether we have symptomatic anemia or hemodynamic compromise. A transfusion, generally, it's not indicated in uncomplicated vaso-occlusive episodes, and its benefit, it's kind of uncertain in like patients with pulmonary hypertension or priapism or leg ulcers, I mean, in the sickle cell disease setting. This is a table that kind of lists all the complications in sickle cell disease where transfusion can be indicated or considered by clinical teams, and what is the best transfusion method. As we see here, like some will only require like simple transfusion, while others exchange can be better than simple, or it should be only be like exchange like in severe, like acute chest. And some indications or like some complication doesn't, a transfusion is quite but not recommended. So coming to understand why RBC alloimmunization happen in sickle cell disease setting and patients. So how does it happen? To just give you an idea like why it happens. So when any new patient or a sickle cell disease patient require blood, we give them donor red blood cells. And those donor red blood cells will have like some foreign antigens that are different than the patient's antigens. And that in the setting of the sickle cell disease, the chronic inflammatory state of sickle cell disease or they call the inflammatory milia, there will be, because of the exposure to these foreign antigens, they will activate the antigen-presenting cells. That will cause priming of T cells, and then the P cells will start to produce alloantibodies to these foreign antigens, red blood cell antigens. So why this? Why alloimmunization is more frequent in the setting of sickle cell disease? Basically because, of course, they require more blood transfusion compared to other patients. But by itself, sickle cell disease by itself make the patient itself, himself or herself, like prone to alloimmunization because of the chronic inflammatory state, as I explained earlier, that either because of the vaso-occlusive crisis that will cause the release of more pro-inflammatory cytokines, or the hemolysis, the active hemolysis that is going on, which cause the release of heme in the blood, and that will by itself acts as a DAMP, which is like a damage-associated molecular patterns or molecule that will cause activation of the immune system. And by nature, also those patients have kind of enhanced macrophage and dendritic cell priming. So as I said, all of these damage-associated or like molecules that signals as if there's like some damage happening in the body will cause activation of the complement system and will promote like more of a pro-immunogenic like antigen presentation, and that will make the body more prone to develop antibodies towards the foreign antigens. And as I said, because those patients frequently receive blood, so definitely there will be some high chance of donor-recipient mismatch. In some settings, for instance, in the United States, where like majority of sickle cell disease patients are of African origin, while the donors are majority of them are of Caucasian origin. So there's this kind of mismatch, especially in the Rh and KIL, so that leads to the development of the alloantibodies. And when we look into, but definitely not every sickle cell disease patient that will receive a blood will form antibodies. They found that there are some personal or individualized risk factors that are unique for every patient that can make them more prone to develop alloantibodies. And those are mostly like related to like some genetic modifiers, like the class 2 HLA alleles. So they found that some alleles are associated with the lower alloimmunization risk, while other alleles are associated with higher risk of alloimmunization. And as I said, also the patients themselves have kind of differences in their regulation of the T and B cells. So that will all explain why some patients develop alloantibodies while others don't. But none of these factors per se is kind of a strong predictive marker that will tell us from the beginning of this if this patient will develop alloantibodies or not. This is like a figure that a little bit explain it, make it maybe simpler to explain to my colleagues, is that as I see here, we have like, for instance, as we said, that we have like a mismatch between the recipient and the donor in the red cell antigens. So let's say if we have like a KIL negative patient receiving a KIL positive donor unit, definitely the patient, like not definitely, like he is at risk of developing antibodies for the KIL antigen, which is the anti-KIL antibody. Another thing that plays a role also, like is that patients, particularly with sickle cell disease, also of like African origin, they have this kind of rhesus group genetic diversity. So many of them, they might serologically type like D positive, but they might have like a weak D or a deleted D antigen or a mutated D antigen. The same thing, or a partial antigen, or like there are missing epitopes of the antigen itself. So all of these kind of diversity in the rhesus group leads to sometimes the development of antibodies, although the patient serologically his phenotype is positive. And as I said earlier about the chronic inflammation and the immune system dysregulation that happens in the sickle cell settings because of the chronic hemolysis and the release of all the pro-inflammatory cytokines. Coming to talk about the numbers, the percentages of like alloimmunization in sickle cell populations. As we can see from the graph, it varies between regions. In some regions where there's like matching, antigen matching, like in Europe, it's low at like 8%. In other regions, like in sub-Saharan Africa, it can be up to 45%. It's not 100%, as you know, as you can see, maybe because of the lack of the antigen matching protocols. So it varies as we can see from like 5% to like 50%. There are like they notice like based on the study, there are also other independent risk factors. One is the genotype of the sickle cell disease. It's like if it is only sickle disease, alloimmunization risk is more than if it is like sickle cell and hemoglobin C disease or sickle cell thalassemia, beta thalassemia disease. And they notice that the risk is increased if there's more than 10 lifetime blood units received, and if the patient received the first transfusion at a younger age, and if that happens in an acute setting, and if the patient is of female gender, and as we say, the blood supply it's not matched for RH and KIL, and those patients with splenectomy have more altered immune surveillance, so they are more at risk of developing alloantibodies. When antibody, of course, with the patient develop alloantibodies, we notice that the antibody screening is positive, and then we do in the blood bank, we do antibody identification to know what is the antibody that is present. Based on the studies, the most common, as you see, are mostly the rhesus and the KIL antigens, mainly the big E and the big C, because these are usually missing in the African American populations, and the KIL antigen because it's like 90% of the people are negative for KIL. And then as we can see, like the rhesus group is the one that is predominating. Here, like we have the little e or also the little c. Those ones, generally they occur when the patient have a partial antigens, like partial little e or partial little c. And those will actually complicate the matching because majority of the people are positive for these antigens. So it's very difficult to find a donor that is negative. The next group also, or the other groups include the KID group, the JKA and JKB. And these are known to cause like a delayed hemolytic reactions. And the MNS group, mainly the big S and the little s. So as we saw from the numbers, the rhesus and the KIL antigens mainly cause like 2/3 of the sickle cell disease antibodies. They are by themselves are like very immunogenic. That's why they trigger alloantibodies, the development of alloantibodies. And that's why like the prevalence of alloimmunization is much higher in sickle cell disease patients compared to the general population. So what happens and what are the clinical consequences of alloimmunization? So what if a patient have alloantibodies in their blood? So they are going to be prone or at risk for three main complications. One is the delayed hemolytic transfusion reaction. Second is the hyperhemolysis syndrome. And the third is the chronic transfusion failure or future incompatibility. Regarding the delayed hemolytic transfusion reaction, it usually occurs a few days or like around like 5 or 7 to 14 days post the transfusion. Usually like the antibody will be undetectable pre-transfusion because those antibodies don't stay in the bloodstream. They disappear with time. The titers will reduce with time. So once the patient is again exposed to the foreign antigen, the antibody will research again, or we call it the an immunistic antibody response. Once that happen, the antibody response happen, then there will be like a rapid destruction of both the transfused as well as the autologous red blood cells. Again, hemoglobin will drop. Again, we'll see like signs of like active hemolysis, like dark urine. The patient might feel back pain, fever, and jaundice. The mortality risk in this group is estimated at like 5%, 5 to 6%. It can be still life-threatening if not recognized. So sometimes the clinicians they overlook this kind of complications and they think that the patient is just presenting with vaso-occlusive crisis after like days of receiving transfusion. The more severe complication is the hyperhemolysis syndrome, where we noticed that the patient, despite receiving blood, the hemoglobin is falling significantly below the pre-transfusion baseline even. So here what's happening actually is that we have like activation of the complement system, and there's like destruction of also again the transfused as well as severe destruction of the autologous red blood cells, as well as like there will be reticulocytopenia. So we will have severe worsening of the hemoglobin that is not kind of expected after transfusion, and that will carry a higher risk of mortality compared to just the delayed hemolytic transfusion reaction. So here, like the patient, if receive more transfusion, the situation might get worse. So in such situations, we have to be very careful with transfusion, or we have to minimize and stop. The other consequence of alloimmunization, as I said, is chronic transfusion failure and incompatibility, future incompatibility. That's kind of a long-term complication. The more alloantibodies developing, it will make it more difficult for us to find cross-match compatible blood for the patients. That means delay in care in cases of emergency. Even when we give the blood, the patient, of course, will be at risk of hemolysis. If the patient is considered for future like bone marrow transplant, that will limit their eligibility. And in female patients, those alloantibodies will increase the risk of a neonatal hemolytic disease in case they got pregnant. And of course, will increase the risk of iron overload with time. So that's why it's better to make sure that the patient receives compatible blood from the beginning. We mentioned about how we like somehow recognize those consequences. As we said, generally, whenever the patient present with hemolysis, we will repeat the DAT, repeat the antibody screen, and we see if there's any like antibodies that they were undetectable, now they are detectable. As we said, like also the hemoglobin will drop in both cases in the delayed hemolytic transfusion reaction and the hyperhemolysis. how we manage and prevent, and I'll talk about that also later, is, as I said, to avoid transfusion unless it's critical to transfuse, and to do extended matching. In some of those, like the first line will be to give steroids, IVIG, erythropoietin, and IV iron. In the hyperhemolysis, there might be a role for eculizumab, which is like a complement inhibitor, or other like immune modifiers like rituximab. And of course, we have always to prevent it, which I will come to talk about it also, which is like the antigen matching, and to minimize the exposure. So what do we do in the blood bank when we get to know that this patient is a sickle cell disease patient? What is our general transfusion considerations? First of all, we'll do full phenotyping for the patient's RBC antigens. We type for the RH antigen, which are the big C, little c, big E, little e, the kill antigens, the Duffy and the KID group, and the MNS system in all sickle cell disease patients. If genotyping is available, that is preferred. If not, then serological phenotyping, but that is going to be unreliable if there was transfusion within the last 3 months. Then we, every time the patient is about to receive transfusion, we do antibody screening, and from that, of course, we save all of these records in our blood bank system. So if the patient is known to have any antibodies, because like with time they can, as I said, become undetectable. So a previous history of antibody is crucial. We can sometimes check with other hospitals if that is easy. And that is kind of, as I said, essential to avoid re-exposure to the same antigens, trying to prevent hemolytic reactions. In general, leukoreduction is advised to be done for sickle cell disease patient. Some hospitals, like in Bahrain, we do universal leukoreduction. That will cut the risk of CMV, HLA aluminization, and the febrile reactions. Irradiation, some patients, especially those that are going for hematopoietic stem cell transplant, might require irradiation to prevent transfusion-associated graft versus host disease. And of course, for the sickle cell patients, we try to avoid any sickle traits units. So it should be sickle negative units in order to optimize the transfusion we are giving to them. So what are the the antigen matching strategies that we have in place? Of course, I know most of the people, whether clinicians, especially the ones that are not in close contact with the blood bank, they just know ABO and RHD matching. This is the minimum that is not adequate for the sickle cell patients. They make them at a very high risk of aluminization. Some places, they take it further. They match the RH and kill groups. So that's kind of the standard, should be the minimum standard for sickle cell patients. In other setting, which is we are lucky here in Bahrain, we do extended matching. We include the KID as well as the Duffy and the MNS group. That will reduce the risk of aluminization. And in better settings where they have good number of donors, they are also promoting for RH genotyping, matching to bring the risk to the lowest level. As I said, there's we can do genotype phenotyping either by genotyping or traditionally by serology. And genotyping will be much better because it will detect any partial antigens, any variants, and will not be affected by recent transfusions compared to the traditional serological typing. So here, we can see how the more we match, the lower the antibodies that can be developed in patients in general. So regarding the Rh genotyping, genotype matching, it might not be that easy to implement everywhere. Because of course, like we have to put in mind the cost as well as the requirement to recruit many donors in order to find a matched donor for the patient. So as we said, like how can we prevent alloimmunization, and like at the same time, like how can we manage? For the prevention, we talked about the extended antigen matching. The minimum should be the Rh and kill. If we can match for more, that will be better. And that should happen pre-transfusion. We should always try to catch the patient the first time they present to us. And here, like, I'll take the opportunity to just like ask our clinical colleagues in any setting that if the patient has sickle cell disease history, to mention it on the request they send to the blood bank. Because once we see that, we do the full phenotyping for the patient and try to prevent any alloimmunization or future incompatibility by doing it pre-transfusion. And of course, by doing like leukoreduction and limiting the unnecessary transfusions, we can use some medications like hydroxyurea, the clinicians, to kind of try to reduce the transfusion frequency when it is feasible in patients. And of course, to recruit more donors in order to match the recipients. And we talked earlier a little bit about the management of alloimmunization when it's already established. In this, like if we have any complications in the form of delayed hemolytic transfusion reaction or hyperhemolysis. So this is how we generally, as I said earlier, once there is a new sickle cell disease diagnosis, that we do extended RBC phenotyping, RBC genotyping if available, and we keep that in our registry in the blood bank. We do, whenever the patient asks for transfusion, we do antibody screening. We provide them a matched, at minimum, Rh and kill matching. And it's the clinical team's duty to monitor the post-transfusion hemoglobin to look for any delayed hemolytic transfusion reactions. And we continue, like we update the antibody history if there's any resurgence of antibodies. For pediatric population, as we said, the same principles will apply. We will perform the extended phenotype or the genotype before the first transfusion. In the neonatal, like that's like for neonates, we have to be careful that the maternal antibodies we're gonna confound the results. And it's very important, essential to establish the transfusion record very early in the patient's history for lifetime management. We try, like one thing is that for like the stroke prevention program is to kind of minimize transfusion, maybe considering hydroxyurea or other medications to go for a transfusion sparing strategy. And for those patients that go for like hematopoietic stem cell transplant or gene therapy in the future, or like some countries already have established pathways for that, we have to know that the multiple alloantibodies will complicate the eligibility. And even if the patient did gene therapy or hematopoietic stem cell therapy, still those antibodies will persist in their blood. So that is kind of mainly the main points, the considerations. So taking it to the future, as we said, I believe that transfusion will continue to be part of the sickle cell disease care. But it's very important to take, like, to use it carefully, only like for the evidence-based indications. From our side as a blood bank, to do like matching in the most cost-effective way, and to recruit more donors to match our recipients, and to to ensure like there's like a reliable and safe
Zainab,
approach.
you've exceeded your time. Still, you have a lot to say,
Yeah.
or
No, just that's it. I finished my presentation. So
Please,
these were
yes.
like the key messages, and these were my references. Thank you so much, Dr. Najat. Sorry for
Thank you
the...
so much, Dr. Zainab, for this extensive review of alamionization and sickle cell disease. There is one question, actually, it's not for you, but you might. The question is fetal transfusion, is it done in Bahrain? Not that I know of.
Do you mean intrauterine or
Intrauterine, fetal transfusion, yeah, intrauterine.
I'm not
Really, I've
aware.
not heard of it. We're not, I don't
Yeah.
think it's done in Bahrain.
Yes, I don't think so. I haven't also encountered any case, but we do only like the exchange transfusion for
For
the
neonatal, not, yes,
yes,
for
not
neonatal, but not for
yes,
fetal.
yes.
Okay, thank you so much, Dr. Zainab. We move to the next speaker, Professor Gonzalo Hernandez, Professor, University International de Catalonia, Spain, a distinguished academic specializing in the regulation of iron metabolism and related pathologies. Professor Hernandez contributes vital research to the understanding of molecular mechanisms underlying iron-related hematological diseases. Please, Professor Gonzalo.
Hi, good morning, everyone. Thank you, Dr. Najat, for your kind invitation. Let me show you. Can you see my presentation?
Yes.
Okay. So first, let me start by saying that I'm not a medical doctor, and my field of expertise is genetics. So I've tried to make this presentation about the importance of genetics for both diagnosis and treatment of rare congenital anemias like CSA or CDA, and more because, as you know, there are a lot of rare anemias that are caused by gene defects. So first, what is erythropoiesis? No, you know that red blood cells after 120 days they are going to die and then they're going to repeat the cycle. So the body needs to produce more cells through erythropoiesis. That is a complex process that involves the morphological changes of progenitor cells that are going to change the gene expression to eventually form the shape that we all know for the red blood cells. This process consists of two different events. No, the first one is this differentiation process where we have the morphological and gene expression changes in the cells to support these morphological changes and to produce the hemoglobin. And the second part is the genes, the pathways involved in iron metabolism. As you know, most of the iron that we have in our bodies is located on red blood cells because we need iron to produce the heme group that forms the hemoglobin. If we have some kind of genetic defects in these both elements, the cell differentiation and the iron metabolism, then we are going to have different forms of anemia. Right now, I'm going to start with some forms of anemias that are due to defects on these iron metabolisms. I'm going to focus in this presentation with the congenital sideroblastic anemias. These are a very huge group of different heterogeneous diseases. All of them, they have in common that the iron gets stuck on the mitochondria of the cells. And this means that this iron cannot be properly used to form heme, to form other processes that are important for the erythroblast differentiation and for the production of hemoglobin. Since the cells are unable to use this iron, the body senses that it doesn't have enough iron. And this, in turn, induces an increase in the absorption of iron from the food. This leads to an iron accumulation in certain tissues like liver, heart, etc. And this accumulation with time is going to cause organ damage, and we have to prevent that. As I was saying, this congenital sideroblastic anemia, sorry, I forgot to mention that one thing that all of them they have in common is that the bone marrow of these individuals were going to have sideroblasts that are erythroblasts with these mitochondria that are filled with iron that are surrounding the nuclei. As I was saying before, congenital sideroblastic anemias, there are an heterogeneous group of diseases where the most common form of this disease is the acquired one, meaning that it's not genetic in origin. This acquired form of CSA usually arises from exposure to different components, drugs, zinc, and other components that are on the ambient. Different treatments, for example, when you are being treated with certain drugs, this can lead to an acquired form of CSA. Another form of acquired CSA is myelodysplastic syndrome due to somatic mutations in the gene SF3B1. And the second group of CSA are the congenital ones, meaning that they arise from a genetic inherited defect in some of the pathways. I'll explain you in the next slides. This group of congenital CSA are rare, meaning that we have a very few patients in the world. So this is going to complicate how we can treat them and study them. These congenital CSA forms, they all have in common that they affect different pathways that all converge on the mitochondria. These mitochondria, we have different processes that are very important for erythroblast biology. Well, for one hand, in one example is the synthesis of heme, that is important, is required for hemoglobin synthesis. Then we have another routes involve also iron, that is iron sulfur cluster biogenesis, protein expression in the mitochondria, oxidative phosphorylation for the production of energy, etc. What we know so far about the genetics of CSA is that around 40% of the cases that are clinically diagnosed with CSA, they don't have a genetic cause, meaning that we have tested all the known genes and we have found no mutations on these known genes. When we have found some mutation in the known genes, we know that 40% of the CSA cases arise due to mutations in a gene that's called ALAS2 that gives rise to a form of X-linked sideroblastic anemia. Then we have, for example, Rogers syndrome that is caused in mutations in this SLC19A2 gene that is involved in multiple pathways, all of them, again, affecting the mitochondria of the erythroblast. So why it's important, genetics? Because then here we have 40% of cases that we don't know the gene. So for example, if we want to apply gene therapy in these patients, if we don't know the gene involved in the disease in that patient, we cannot apply gene therapy, for example, or we cannot try to apply more focused therapies for that kind of gene. Now I want to focus on the most prevalent one, that is this X-linked sideroblastic anemia due to mutations in the ALAS2 gene. This ALAS2 gene codes a protein that is called ALAS, that it's the first step in the synthesis pathway of heme. If we don't have heme, we don't have hemoglobin. Therefore, we're going to have an anemia. ALAS, the ALAS enzyme, it's the rate limiting step in this pathway, so meaning that it controls the rest of the pathway. And importantly, this protein needs a cofactor that is called vitamin 6. And this is going to be important later for the treatment options. What we know about this disease is that, well, since it's an X-linked sideroblastic anemia, most of the individuals affected, they are going to be males, okay? And these males are going to have microcytic erythrocytes. They're going to have hypochromia, meaning that the amount of hemoglobin that these red blood cells contain is lower than normal. Okay, but what happens in females? There's been reports of heterozygous females that are carriers for mutations in this gene that have the disease, that present some degree of anemia. The important thing is that while in males they are microcytic, in females they are microcytic, meaning that the size of the erythrocytes in females tend to be higher than normal. And also, importantly, they can have a population that's going to be microcytic. And also, a clear difference between males and females with X-linked sideroblastic anemia is that usually males are diagnosed at a very young age, while in females they tend to be older. And why we have these differences? Well, again, it's genetics. In females, we have the inactivation of one of the X chromosomes. Okay, ideally or usually this inactivation is said to be 50-50, meaning that the probability of one of the chromosomes being inactivated is 50%. If this is the case, we're going to have a mix of two populations in the bone marrow, one with cells that have inactivated the chromosome that contains the mutation, meaning that they are wild type, fully wild type, and we have another population of cells that have inactivated the chromosome that contains the wild type, meaning that they are expressing the mutation. When we have a 50-50% inactivation of both chromosomes, these females are going to be either asymptomatic or they are going to show very mild symptoms. Sometimes in some individuals, this inactivation is not 50-50, but it's skewed towards inactivating, for example, the wild type chromosome. That means that most of the cells in this female carrier, they are going to be expressing only the mutated form of ALAS2. That means that these cells, they are going to be unable to produce enough heme, and these females, they are going to be symptomatic. And here I wanted to remark the importance of genetics, not only in this X-linked form of CSA, but in general. For example, the cost and time that it takes to sequence the genome of an individual, it's very low, has been going down with time. So it's pretty easy to have access to this kind of information. And it's important to know about the genetics of the disease. For example, we can find a mutation in ALAS2. Okay, that's perfect. We can think that this mutation is going to, it's telling us that this individual is going to have a CSA. But it's important for the disease, for a disease, to know where this mutation is happening or which type of mutation it's being affected in the gene. For example, if we have gain of function mutations in ALAS2, we're not going to have X-linked sideroblastic anemia. We're going to have a form of porphyria that is called erythropoietic protoporphyria. So it's another disease. If it's another disease, it's going to have a different treatment. If we have loss of function mutations, we're going to have the X-linked sideroblastic anemia that I was telling you before. What happens? And why it's important to know the exact mutation that my patient has? Because, for example, in some examples, in some diseases, this type of mutation can affect the responsiveness to a certain treatment. Regarding the treatment, one of the treatments that can be used for X-linked sideroblastic anemia is giving the patient vitamin B6. That is the cofactor of the protein. Some of these mutations are going to make that this treatment is going to be ineffective in our patient. Therefore, we're going to be losing time giving the patient vitamin B6 that is going to do nothing. So it's important for the doctors to know about the genetics of your patient so you can adapt your treatment options to be able to give the treatment that are going to work and avoid losing time or avoid having problems later in time. So I'm going to move now to the other part of the erythropoiesis, this process of differentiation of the progenitors. This kind of disease, they are called congenital dyserythropoietic anemias because on the bone marrow of these patients, we're going to find signs of dyserythropoiesis that are changes, aberrant changes in the morphology of the progenitors of the cells. This CDA, it's a group of rare diseases, okay, that sometimes present with iron overload. And all of them, they have morphological abnormalities in the bone marrow that are quite important to detect. There are multiple types of CDA. All of them, they are rare. Being the type 2, the most common type that we know, we have about a bit more than 200 patients on the world. Probably there's going to be more. And it's caused by mutations in a gene called C23B. Each type, the type 1, 2, 3, and 4, they have specific abnormalities on the bone marrow that are quite easy to detect, and they are going to determine which type of disease they have. For example, the type 1, we have erythroblasts with these internuclear bridges. Type 2, we have binucleated erythroblasts. Type 3, we have giant multinucleated erythroblasts with more than 2, even up to 12. There have been some reports with cells with up to 12 nuclei in the same cell. And then we have CDA variants that are due to different genes. Every type of CDA has its own inheritance pattern. So I'm going to focus for this presentation on type 3 because it's the one that I'm working right now. This disease is not a new disease. No, it was described in the decade of the 1950s. So it's an old disease, but it's been quite recently where we have found the genetic origin of this disease. We can subdivide the type 3 in two different subtypes. The type 3A, that it's a dominant form, meaning that the parents and the child is going to be affected. And this dominant form is due to mutations in a gene that's called KIF23 that was described in 2013. The second type, it's a recessive form, and it's caused by mutations in BRCA1, and we described mutations in this gene 2 years ago. This type 3 disease, or the form of CDA, have signs of intravascular hemolysis, macrocytosis, and in the bone marrow we have this very striking multinucleated erythroblasts. Interestingly, the two forms of the disease are caused by mutations in two proteins that work together. Okay, we have BRCA1 responsive for the recessive form, and we have MKLP1 responsible for the dominant form, that they work together forming a complex that is called central spindle, that is required for the division of the cells. If this division is not done properly, then we're going to have a multinucleation of the cell. How does it work? This complex controls the activation or inactivation state of a group of proteins that are called GTPases. When we have the right combination of GTPases that are active or inactive, then this cell is going to be able to complete the cell division. What we know so far about the disease, this is an ultra rare disease. So far, we only have 4 patients described worldwide with mutations in BRCA1. We described 3 patients, and there's another publication that describes a 4th patient with missense mutations in BRCA1. All of the patients, they had signs of hemolysis, macrocytosis, and as you can see here on the images, in the bone marrow, they all present with multinucleated erythroblast. Recently, we have found, and this is an unpublished data, we have found 9 more families, all of them with in total with a total of 11 new patients with mutation, with confirmed mutations in the gene RAGAM1. So we can say for sure that these 11 new individuals, they are affected by CDA type 3B. What is interesting is that all of these patients, they have the exact same mutation. This mutation here, a proline that changes to a serine, that is the same mutation that we describe in the original paper. So this suggests, at least to us, that we are facing a founder effect, because all of these patients are from Argentina and are from the more or less the same region in the north of Argentina. So we suspect that we are facing a founder effect for this mutation in this region of Argentina. So we have changed the picture of this disease. We have, for the dominant form, that it's the form we have more information because it's the first one that was established. We have 4 families. We have more than 45 patients, but I have to make a mention that most of these patients come from the same family. A Swedish family was very big, so most of these individuals come from the same family. And we have 3 different mutations that are affecting this gene. Regarding the recessive one, we had 4 published families. Now we have 9 more, so we have 13 families. Regarding the number of patients, we had 4 patients published. Now we have 11 more, so we have a total of 15 patients, and we have 3 different mutations. But regarding of the form of the disease, we have this problem where we are affecting the ability of the cell to correctly divide, and that's why we have this striking multinucleation defect that we see in the bone marrow of the patients. And now, and this is going to be more interesting for you because I wanted to compare the clinical picture of the 2 forms of the type 3, the dominant and the recessive one. And now that we have increased the number of patients from the recessive one, we can make this comparison and we can make some numbers, some statistics. And we can see, and we can say that in general, the anemia in type 3B is going to be more severe. We see a decrease in the amount of hemoglobin. We see also a decrease in the amount of red blood cells that are circulating. And we see an increase in the LDH, probably a marker of an increased hemolysis in these CDA3B patients. In parallel, we see that, for example, most of the patients affected by the recessive form, they are going to need transfusions at some point. Splenomegaly is always going to be present, while on the dominant form, it's extremely rare. And hepatomegaly, we think or we suspect that it's going to be a differentiating event between the dominant and the recessive one, because so far we have found no hepatomegaly in dominant patients, while on the recessive ones, it's extremely common. And as expected, we don't see differences between sexes because the 2 genes are located in autosomic chromosomes. So we tried also to pinpoint a bit more what was actually happening inside the cell to support this defect of differentiation. So we thought, okay, we need this complex to be properly formed to be able to control the cell division. So we analyze what happens with this complex when we have these mutations. And we found that all of the mutations, they are affecting some part of the formation of this complex. So we can say that the mutations are affecting the formation of this complex. That means that explains or partially explains why we have a problem with cell division. We have less complex, and then we're going to have a problem with this cell division. But we wanted to go a bit further. So this complex, it doesn't act alone to regulate these GTPases. It needs at least two important proteins that are called ECT2 and PRC1 that interact with, for example, RAGNA1 protein. And these proteins are going to allow the control of this GTPase activation status. What we saw is that all of the mutations are affecting more or less the interaction with these two key proteins. So we suspect or model is that what is happening here is that all the mutations are affecting the ability of the cell to control these GTPases, and that's why we have this problem. No, we have this is our simplified model. We have RAGA1. When you have the normal form of the gene, you can properly control these GTPases. You can activate and deactivate the GTPases in the way you need to properly complete the cell division. So you are going to divide properly and you are not going to have multinucleated cells. On the other hand, when you have either of the mutations that we have identified so far in the patients, this balance of activations and disactivations are is unbalanced. It's the wrong one. So this cell is going to it's going to have problems completing this division, and that's why some of the cells they are going to multinucleate. And this goes with this model that we have. This goes in line with what we observe in lymphoblastoid cell lines from the patient, the original patients, where what we see is that in these patients, they have less activation of the GTPases that are important for the cytokinesis, and we have increased activation of the GTPases that we need them to be inactive to properly divide. So this is telling us that we have this imbalance in the GTPase activation, and the cell is in a state where it's a bit more complicated to successfully complete the cell division. This is not a black or white situation. Obviously, if all the cells fail to divide, the patients will be dead. In this situation, we have a part of the cells that they are going to fail cell division and they are going to multinucleate. And these multinucleated cells, they are going to generate these macrocytic erythroblast, these macrocytic red blood cells, and therefore we're going to have a source of anemia. And just to finish my presentation, since my field of expertise is genetics, we perform a lot of gene sequencing here with different patients where we have discarded all the known genes. And this means that we tend to find some patients where we have new genes involved in different forms of anemia where we don't have a known cause. So we have so far identified at least 5 new genes involved in different forms of anemia. For example, and this is more to try to find new possible patients with your collaboration. We have, for example, 2 different new genes involved in forms of hypochromic microcytic anemia without iron overload. We have a new gene involved in an hypochromic microcytic anemia with iron overload, similar to the GMT1 cases. We have a form of IRIDA that is dominant, where we have discarded mutation in the gene that is called the MPR66. And we have a new gene involved in CSA. So with this slide, I wanted to ask if you have patients that match these diseases, and you have discarded that they have thalassemia or sickle cell disease, and you want to collaborate, feel free to write to my mail so we can collaborate and do some research. Well, just to finish, thank you again for the invitation, and this is the group where I work. And thank you very much for your time. Any question?
Thank you so much, Professor Hernandez, for the excellent and very impressive work. And I don't see questions for you, but let me just check which type of. There's one question for you. Which type of sideroblastic anemia that is seen with Majid syndrome is the what is it? Is it a thick syndrome? Professor Gonzalo?
Yeah, sorry, I don't understand the question.
The question is, which type of sideroblastic anemia that is seen with Majid syndrome?
So now I don't know exactly the but it's the Majid syndrome. It's this erythropoietic anemia, not CSCA. If I understand correctly, the Majid syndrome is associated with CDA, not the sideroblastic.
Okay. Okay, thank you so much, Professor Gonzalo.
Thank
Now
you
we
again for
move
your
to.
invitation.
Thank you so much. We move now to the next speaker, Professor Domenico Giurilli, Professor of Internal Medicine and head of department, University, Professor of Internal Medicine and head of department, University of Verona, Italy, Director, Internal and Emergency Medicine Unit, University Hospital of Verona. Award Authority on Iron Metabolism. Professor Giurilli's foundational discoveries include the molecular basis of hereditary hyperferritinemia, cataract syndrome, and hepcidin mutation. He coordinates the Euro BloodNet Center of Excellence for Rare Hematological Disorders. So this is a recorded presentation by Professor Giurilli.
Hello to everyone. It's a great pleasure for me to be here, although virtually. I would like to thank the organizer for inviting me to do this lecture about IRIDA. And this is my disclosures. And this is the agenda of my talk. I will start by discussing the general principles of the regulation of iron metabolism. Then I will focus on the regulation of hepcidin by TMPRSS6, which is the gene that encodes for matriptase and the genes that is mutated in iron refractory iron deficiency anemia. Then I will discuss the clinical features of IRIDA, and finally some diagnostic and therapeutic caveats that we encounter whenever we suspect IRIDA in clinical practice. First of all, I would like to remind you that both iron deficiency and iron overload are common conditions that are detrimental, and iron deficiency is characterized not only by anemia, but also is characterized by neurocognitive dysfunction, immunological dysfunction, heart dysfunction, muscle weakness, and possibly also by the so-called restless leg syndrome. So iron is both indispensable, but at the same time possibly dangerous, and this translates in the need of a very strict control of body iron content, and in order to avoid both iron deficiency and iron overload. And the regulation of iron metabolism is maintained by the hepcidin ferroportin axis, where hepcidin is a small 25 amino acids peptide synthesized by the liver, and which is able to bind and block its receptor, that is ferroportin. Ferroportin is an ubiquitous iron export channel expressed on the cell membrane of many different cells, especially duodenal enterocytes and splenic macrophages. And hepcidin binding to ferroportin leads to block of the channel and internalization and degradation of the ferroportin. Here you see the iron balance that we can consider that the regulation of iron quantity in the body is due to hepcidin, and the majority of body iron, that in total is about 3.5 to 4 grams. The majority is 2.5 grams is within the red blood cells in hemoglobin, and at the end of the lifespan of erythrocytes, they are captured by splenic macrophages. Hemoglobin is degraded, iron is released in the circulation through ferroportin, binds to transferrin, which is saturated physiologically from 20 to 45%, and transferrin vehicles iron back to the bone marrow erythroid precursors for the reuse of recycling of iron. We only have a few obligate losses of iron, 1 or 2 milligrams per day, with mucosal exfoliation and menses in fertile women. And these losses have to be exactly matched with the same amount of absorption of dietary iron, and this regulation is due by hepcidin that negatively modulate ferroportin in duodenal enterocytes and in splenic macrophages. And like every hormone, hepcidin is regulated by many different factors. Iron is the most important regulator of hepcidin. There is a feedback regulation, so that when iron is increased, hepcidin is also increased. On the other hand, when iron status is low, hepcidin is generally suppressed in order to favor iron absorption by duodenal enterocytes. And as you can see here, hepcidin is also regulated by genetic factors, and the most important one is due to variation in the TMPRSS6 genes. TMPRSS6 encodes for matriptase 2, that is a membrane protein that negatively regulates the BMP-SMAD pathway that leads to hepcidin production. So whenever we have loss of function mutation in TMPRSS6, we have the loss of the physiological brake to hepcidin production. There is an increase in the production of hepcidin that leads to iron malabsorption, and the phenotype is characterized by iron refractory iron deficiency anemia, or IRIDA, which is a rare autosomal recessive disorder characterized by microcytic hyperchromic anemia with low transferrin saturation, a certain degree of refractoriness to oral iron, slow response to intravenous iron, and typically characterized by increased hepcidin levels in the circulation at variance with classical iron deficiency anemia, in which hepcidin levels in the circulation are typically suppressed. And this is the pathophysiology of IRIDA due to TMPRSS6 mutation with increased hepcidin production with inhibition of ferroportin in duodenal enterocytes, but also in splenic macrophages that reduces iron recycling into the circulation. And the net effect is typically reduction of transferrin saturation lower than 5 to 10%, and resulting in anemia due to iron-restricted erythropoiesis. So iron refractory iron deficiency anemia is a rare hereditary condition due to mutation, loss of function mutation in TMPRSS6, with an increased BMP-SMAD signaling, excess hepcidin production, decreased iron absorption, decreased iron release from macrophages, and decreases iron availability for erythropoiesis, leading to microcytic anemia. From a clinical point of view, the biochemical hallmark of IRIDA is represented by very low transferrin saturation, generally lower than 10%, in the absence of inflammation. And as you can see here, we have to consider genetically determined IRIDA like a disorder of iron distribution, since there is in many cases no absolute iron deficiency, but rather there is a sequestration of iron within the reticuloendothelial macrophages. And typically in iron refractory iron deficiency anemia, there is a minimal or even absent response to oral iron supplementation, and we can also observe an incomplete response to intravenous iron therapy with persistently low transferrin saturation. Here you see the differences between genetically determined IRIDA and absolute iron deficiency. In absolute iron deficiency, we have a suppressed hepcidin. On the contrary, in IRIDA, we observe that iron stores are generally not depleted, but iron is entrapped in reticuloendothelial macrophages, so that at variance with the absolute iron deficiency, in which typically ferritin levels are generally low, in IRIDA, ferritin levels are normal or even increased, since circulating ferritin reflects iron sequestration into reticuloendothelial macrophages. So here you see the comparisons between the biochemical parameters in classical iron deficiency anemia as compared to anemia of inflammation and to IRIDA. And the most important difference is due to the levels of hepcidin, which are typically suppressed in iron deficiency anemia. Hepcidin can be increased in anemia of inflammation. It is typically increased in IRIDA, where there is no inflammatory condition, and typically the inflammatory biomarkers like C-reactive protein are normal. So we can think about genetically determined IRIDA like similar in the pathogenesis to the anemia of inflammation, because there is an increase of hepcidin, but without inflammation in IRIDA, and the increase of hepcidin leads to impaired iron absorption from the duodenal enterocytes and iron sequestration in storage sites, especially in splenic macrophages, leading to functional iron deficiency and ultimately to iron deficiency anemia. Whenever we suspect IRIDA, the first step is to exclude an acquired cause of iron malabsorption, and iron malabsorption can be due, for example, in pediatric patients to especially to celiac disease, but also to autoimmune gastritis or to Helicobacter pylori gastritis. And we have several biochemical tests that can be used for screening for this condition, especially the serology for celiac disease. In adult patients, acquired IRIDA can also be due to bariatric surgery. And it is important anyway to consider that in acquired anemia with refractoriness to oral iron, there is an iron malabsorption, but hepcidin levels are suppressed at variance with IRIDA. And these are the classical hematological hallmarks of IRIDA. As I mentioned before, there is very, very low transferrin saturation, lower than 10 to 5%, and the refractoriness to oral iron is generally defined by an hemoglobin increase of less than 1 gram per deciliter after 4 weeks of oral iron supplementation. And the diagnostic clue for genetically determined IRIDA is represented by the finding of high hepcidin levels despite severe systemic iron deficiency. It is important to note that hepcidin assay are different, and the gold standard for measuring hepcidin in the circulation is represented by mass spectrometry that is able to differentiate the different hepcidin isoforms, especially the bioactive hepcidin 25 to non-bioactive hepcidin isoforms like hepcidin 20 and hepcidin 22. And this is very sensitive, but mass spectrometry is costly, requires specialized staff, and also is characterized by a very low throughput. So for screening for genetically determined IRIDA, we can also use immunological methods like ELISA, which are less precise as compared to mass spectrometry. because they are unable to differentiate the different hepcidin isoforms, but can be anyway useful for screening of this condition. And this slide represents a practical algorithm for the diagnosis of IRIDA. We suspect IRIDA in pediatric patients whenever we have microcytic hypopharemic anemia with very low transferrin saturation that is not responsible to oral iron supplementation or only partially responsive to iron supplementation. And after the exclusion of other causes of iron malabsorption, for example, through the serology of celiac disease by determining the levels of immunoglobulin A anti-transglutaminase, if these tests are negative and if there is no inflammation, IRIDA can be suspected and confirmed by the measurement of hepcidin, which is typically elevated in patients with IRIDA, and the final confirmation of the diagnosis is obtained with the search for mutation on the TMPRSS6 gene. It is important to note that the majority of IRIDA is due to mutation in TMPRSS6, but it has been recently described a phenotype of genetically determined IRIDA due to mutation in the target of TMPRSS6, that is the membrane protein immunojuvelin, that is important for the regulation of the BMP SMAD signaling that regulates hepcidin synthesis. And these mutations in the hemojuvelin N-terminal alpha helix can lead to overactivation of the BMP SMAD signaling, finally resulting in increased hepcidin levels exactly in the same way of mutation in TMPRSS6. Whenever we suspect iron deficiency, iron refractory anemia, we can try to treat the patients with oral iron, and sometimes we observe a partial response in patients with certain TMPRSS6 mutation that do not alter in a significant way the function of the protein, but generally, by definition, IRIDA is refractory to oral iron, and this is due to the fact that loss of function mutation in TMPRSS6 finally leads to increased hepcidin and decreased oral iron absorption. So the mainstay of iron treatment in IRIDA is the intravenous iron that is able to correct this defect. It is important to recognize that intravenous iron bypasses the intestinal hepcidin reporting block, and also macrophages also have a higher overall ferroportin expression than enterocytes. So when they are loaded with iron nanoparticles, for example, ferric carboxymaltose, these iron loading in macrophages are able to upregulate ferroportin via the cellular iron regulatory proteins pathway, and this leads to the partial, at least partial, utilization of intravenous iron for erythropoiesis. It is important to remember that the response in patients with IRIDA is variable. It depends on the genotype, on the different types of mutation in TMPRSS6. Another important point to be remembered is that patients with genetically determined IRIDA needs repeated infusion of iron, especially when we use ferric carboxymaltose. We have to remember that this compound can produce an increase of intact FGF23, that is a phosphaturic hormone, and this hormone leads to hypophosphatemia that is relatively frequent with ferric carboxymaltose as compared with other intravenous iron preparation, for example, iron derisomaltose, that can also determine hypophosphatemia, but with a lower frequency as compared to ferric carboxymaltose. And chronic hypophosphatemia in patients with IRIDA treated with repeated iron carboxymaltose can lead to osteomalacia and fractures. So it is very important to monitor the serum level of phosphate in these patients. Here you see a final algorithm that suggests whenever we have the suspicion of IRIDA to refer the patient to a specialized center able to perform the genetic test on TMPRSS6 by next generation sequencing, and also to measure hepcidin in the circulation. And from a therapeutic point of view, in children with mild to moderate anemia, we can do a trial with oral iron, even if in most cases this oral therapy may be ineffective. Whenever at presentation anemia is severe, that is hemoglobin levels less than 7 grams per deciliter, we have to directly use intravenous iron supplementation, and we have to monitor not only phosphate level but also ferritin levels, and we have to avoid to increase ferritin higher than 700 micrograms per deciliter. And we have to consider that generally transferrin saturation remains stable and low in these patients. Now we are entering the era of pharmacological manipulation of hepcidin. So in a near future, we could use in IRIDA some drugs that are able to inhibit hepcidin and to correct the maldistribution of iron in these patients. So these are my concluding remarks. With the characteristics of IRIDA, it is an autosomal recessive disorder characterized by microcytic hypochromic anemia with very low transferrin saturation, minimal or no response to oral iron therapy, and only partial response to intravenous iron therapy, and from a laboratory point of view, at variance with the iron, classical iron deficiency anemia, ferritin levels are normal to high. Why? It is very characteristic to see a very low transferrin saturation, and whenever possible, if we measure hepcidin, the transferrin saturation to hepcidin ratio is diagnostic of genetically determined IRIDA. And here you see the recommendation for IRIDA treatment. We have to initiate intravenous iron therapy if oral therapy fails. And the goal of the therapy is not exactly to normalize hemoglobin, but to reach hemoglobin levels that support a quality of life. And we have to avoid excess use of iron. We have to avoid ferritin levels higher than 700 microgram per liter when use intravenous iron. And thank you very much for your attention. And I wish you a wonderful Congress.
Thank you so much, Professor Guerrilli, for the excellent presentation. I mean, there is one question for Professor Guerrilli, but since he's not with us, we will email your question to him and come back to you tomorrow, inshallah, with the answer. Okay. I mean, there's one question for Dr. Zainab. Does the plasma transfusion requires cross match?
So for plasma transfusion, so we don't do cross-matching, but definitely we give the patient compatible plasma according to his blood group. Yeah, so that's my
Okay.
answer.
Thank you so much. Now we'll break for prayer and lunch, and we rejoin 12:30, but I prefer that you join maybe 10 minutes before that so that we can start. We have we have a busy schedule, and we have very interesting presentations ahead. Thank you, and see you later. Okay. Welcome back. We'll start our second session. Our next speaker is Professor Flora Vivandi, Professor of Internal Medicine, University of Milan, Italy, Director Angelo Bianchi, Binomo Hemophilia and Thrombosis Center, Milan. Professor Flora Vivandi is a preeminent global authority in hemostasis, thrombosis, and rare bleeding disorders. As director of the Angelo Bianchi Bonomi Hemophilia and Thrombosis Center, she leads one of the world's most prestigious institutions in coagulation medicine. Her pioneering research has fundamentally reshaped the molecular understanding of inherited coagulation disorders and microvascular dysfunction, driving the development of novel diagnostic and therapeutic strategies that have transformed patient care. A visionary leader, Professor Bivandi holds the rare distinction of having served as president of both the ICH and IHAD. She currently advises the European Medicine Agency, EMA, and the Italian Ministry of Health, leveraging her extensive global expertise to advance clinical practice and international health policy. So this is a recorded presentation.
Good afternoon. I'm Dr. Peibandi, Professor of Internal Medicine and Director of Hemophilia and Thrombosis Center at the University of Milan. And today I'm going to talk about the rare bleeding disorders. Bleeding disorders are a group of inherited disorders caused by deficiency or dysfunction of a single or combination of more coagulation protein that could have essential role in the coagulation cascade. And this dysfunction could cause defect in clot formation and consequent bleeding diathesis. The most common type of bleeding disorder are hemophilia A and B, with a prevalence of 1 case in 6,000 for hemophilia A and 1 in 26,000 for hemophilia B. And for von Willebrand disorders, the prevalence are much more frequent. However, the severe cases are much more rare. And the less frequent one are rare bleeding disorders like factor 1, factor 2, factor 5, 7, 10, 11, and 13 deficiency. And finally, the platelet disorders with the prevalence of 1 in 1 million. Here you can see the annual global survey of World Federation Hemophilia 2024 data collection from 135 countries, and all over about 500,000 of the population have been registered, and of those 50% are hemophilia, and you can see that the number of the patients with bleeding disorders are about 15%, and the number of people with factor 7 deficiency or factor 11 are the most prevalent within the rare bleeding disorders. And what is important, you can see that in the last 10 years, the number of registered patients have been increased significantly. And this is a very good news because of the better diagnosis tools and also awareness through the population and the physician about the rare bleeding disorder. However, if you look carefully about the data published by World Federation, you can see that there is no equivalence in the number reported in different regions of the world. And usually, rare bleeding disorders are transmitted as autosomal recessive disorder and should be much more frequent in those countries where consanguinity is higher, like some of Southern Indian, Middle East. But these numbers not necessarily are registered. And you can see that the number reported are much more in the United States and in Europe because of the facility of the diagnosis and also the registration. Therefore, I think it's very important for the low-income countries in the future to think about how to increase the awareness and better diagnosis. And also the recent data that we have published by our team with Omid Seidzadeh on the various types of the rare disorder, like type 3 von Willebrand disorder, Glanzmann, or also other type of rare disorders, the number reported on prevalence are completely different to what we are calculating based on the NOMAD data sequence analysis. And on the NOMAD database with exome and genome data, more than 1.5 million of alleles have been detected. And if you look on the gene mutation, which has been already reported to be associated with several disorders, the prevalence of all these rare disorders seems to be 10 to 12 times at least higher compared to what is in the literature. So that is showing us there is definitely underestimation on the number of the diagnosed patient, and this is much worse in those countries with a low income. So after understanding how important is the diagnosis and how we have to face up with awareness, we have to also understand how to make the clinical evaluation of these patients. The clinical symptoms in this patient are usually mucosal tract bleeding or excessive bleeding after the surgery. And sometimes you might not have the clinical manifestation at the early stage or do not have severe type of bleeding episode, but you can have it after the procedures like surgery, tooth extraction, or circumcision. So that's the reason I think it's very important not underestimating the risk of the bleeding in these patients. So you can see that clinical sign could be like CNS bleeding, umbilical cord bleeding, hematolosis, and soft tissue hematoma, which could be frequent in fibrinogen, factor 7, factor 10, and factor 13 deficiency, and GI bleeding, which is much more frequent in factor 10 deficiency, and spontaneous abortion is frequent in women with afibrinogenemia and factor 13 deficiency. So it means that you have a large heterogeneity on the type and severity of the bleeding, and is very specific to the type of the deficiency. Unfortunately, women with inherited bleeding disorders have a problem for all over the cycle of their life, from the very early stage on the maturation and menstruation with the menarche, and every month with menorrhagia, and then for pregnancy, and unfortunately sometimes during the delivery, and postpartum hemorrhage also has been reported. So adequate management and good education for women with bleeding disorder is extremely important, especially in those women that they have the experience with their mother and their grandma. They had always the same history of the bleeding, but they do not know really what means to be completely in normal situation with no problem of the bleeding. So I think, again, awareness and education is very, very important. Pregnancy and delivery pose a special clinical challenge, and some of the factors during the pregnancy is increasing, like fibrinogen factor 7, 8, 10, and von Willebrand factor. However, if you look for factor 2, factor 5, and factor 9, there is no increase, and you need to make sure that the level of these proteins are not less than 20%, I would say. So in developing countries, lots of women with rare bleeding disorder are facing complications during pregnancy, and you want to make sure that there is a good consultancy, and particular attention should be done with women with afibrinogenemia and severe factor 13 deficiency, because the risk of loss of the pregnancy and also the problem of abortion is very high, and only a small amount of the protein could solve this issue. And all these troubles, of course, for the women is reducing the quality of life of these women. How we have to make the diagnosis and laboratory diagnosis. PT and APTT test could be used for factor 1 fibrinogen, factor 2 518, 7, 10, and 11 deficiency. And they could be normal in some of the mild deficiency, especially in the case of fibrinogen and factor 2. You have to consider the level of PT and APTT is always normal in factor 13 deficiency. And you need to make a mixing study after the prolongation of the PT and APTT and understanding whether the abnormality is due to the deficiency of the factor or to the presence of anti-clotting factor antibodies. And thrombin time is also important for the fibrinogen deficiency. However, you need also the specific type of the assays. For example, for fibrinogen deficiency Klaus method is very important. You cannot anymore use the clot solubility assay for factor 13, and it will be important to use a specific quantitative assay for detecting the minimum amount by also blanking strategy and to understanding what is the minimum level of plasma of your patient. Please remember for factor 2 and fibrinogen, a part of the clotting activity, you do have to measure also antigen level, because where there is a normal amount of protein or detectable amount of the protein and not functional, this condition, which is this prothrombemia or this fibrinogenemia, could be associated also with a thrombotic event. And that's have an important role in the decision of therapeutical concentrate and a strategy that need to be used. So you need absolutely to make sure this is happening. For the molecular characterization, you have to consider there are 3 classes of deficiency. Those that there is a gene encoding of the deficient factor with gene mutation, like afibrinogenemia factor 2, 5, 7, 10, 11, and 13. And the second group is where the secretion pathways are alterated due to the gene mutation on MCFT2 and LMAN, like factor 5 and 8 deficiency. And the third group is those genes that are encoding enzymes involved in post-translational modification of the vitamin K metabolism, like VKORC1 and GGCX. And this could bring to all those vitamin K dependent factor deficiency, like factor 2, 7, 9, 10, protein C and protein S. When you use the strategy of the Sanger sequencing, PCR and Sanger sequencing, you might come up with 90–95% of the gene mutation, but still there are 5 to 10% that they do not have the gene mutation causing this type of deficiency. And that's the reason why in the last years, the use of next-gen analysis with whole exome sequencing or whole genome sequencing, or recently with the introduction of the nanopore technique for the long read, there was a significant improvement on understanding the gene mutation causing the deficiencies. And also to make the interpretation of what this gene alteration could cause, mainly there were several software that have been used to understand the functional validation of this gene mutation. And I think the ACMG score is a standardized system right now for classifying the genetic variant based on the clinical and laboratory evidence that could be developed, that has been developed actually by the American College of Medical Genetics and Genomics. And that's what usually is used in my center for the prediction of pathogenicity of the variants. This paper a few years ago tried to bring 13 European centers from 11 countries with a data collection which has been done for 3 years on 489 patients. And over there, we tried to make a clinical severity classification with asymptomatic patient, where is no documented bleeding episode, grade 1 when the bleeding was occurred after trauma or any kind of anticoagulant, antiaggregant ingestion. Grade 2 spontaneous or minor bleeding like bruising, ecchymosis, or minor wound or oral cavity bleeding, epistaxis, or menorrhagia. And grade 3 was spontaneous major bleeding like hematoma, hemarthrosis, umbilical cord bleeding, or CNS. This slide, which is very busy, but I try to help you to understand, there was 3 groups of the deficiency. Those like factor 10, factor 13, and fibrinogen, there was a very good correlation between the level of the factor and the clinical manifestation of the patient. But if you look on factor 5 and factor 7, there was some association, but it was weak. But for factor 11 deficiency, we have found no association at all. And further analysis showed that in factor 13 deficiency, there is a reduced fibrinolytic resistance that might have a role also explaining why the bleeding manifestation in the patient could be so heterogeneous in factor 11 and not necessarily associated to the amount of the conserved factor 11 in plasma. Okay, now let's go to move on prophylaxis. Whether rare bleeding disorder do need prophylaxis as severe cases in hemophilia and in von Willebrand disorder. I think all severe cases, even in the rare disorder, need prophylaxis, but that depends on frequency of the bleeding of your patient, risk of severe spontaneous bleeding, and risk of long-term disability like CNS, GI, joint bleeding, and also in patients with significant history of the bleeding, there is no doubt, there is no difference in comparison to the previous bleeding situation like hemophilia or von Willebrand. So prophylaxis in that group is recommended. But the decision of to make the prophylaxis is not easy as it is for hemophilia because the amount of the products available are much lower. For example, if you look on fibrinogen, there are various plasma-derived products available for fibrinogen that you can do easily the management with once-a-week prophylaxis of 50 to 70 based on the level of the fibrinogen and decide how to manage it. But for factor 2, there is no specific product, and the complex of prothrombin might be associated with the thrombotic event, especially because you are adding all other factors. Factor 7, we have plasma-derived and recombinant product, but the half-life of the recombinant factor 7 is very short and it's very difficult to make a scheme, and usually you need to make a treatment once a day. For factor 10, we have plasma-derived specific products, and you make 2 infusions weekly of 20-30 international unit. And for factor 11, there is a plasma-derived concentrate not available everywhere and is sometimes associated to the thrombotic event, so you have to pay attention when you're using. And for factor 13, there is plasma-derived and recombinant factor 13, and it's very easy, once a month or every 3 weeks, and in pregnant women, maybe every 2 weeks could be a good scheme of treatment. We can use non-transfusional treatment like antifibrinolytic, fibrin glue, hormones, and DDAVP. And in low-income country, cryoprecipitate and FFP is used. However, this is not anymore used in Europe and is not recommended. Unfortunately, for factor 5, we do not have any concentrate right now available. It was produced by Kedrion, but we are still waiting for its arrival to the commercialization step. But look at on the half-life of this product, how is different. As I told you, this could be from factor 7 with few hours of half-life to factor 13 with 9 to 12 days. And also, if you look on the level of recommended for the prophylaxis, it seems we as a European network are proposing a higher level, over 20% usually, and for all the factors. For factor 10, maybe even a little bit more, because some of the heterozygous patients with factor 10 deficiency, they tend to have the problem of the bleeding. As I told you, the women, for example, with menorrhagia, they need to have a prophylaxis. But how are you going to do it? You have to make a distinction between the women who are in the age of reproduction, and those that they are not on the age of the reproduction, and then decide that a part of the age, overall, the health and medical history, and the cause of the menorrhagia, and her tolerance, for example, to pills, specific medication, procedures, and also the effect of the menorrhagia on the lifestyle of this person, and the personal preference and cultural differences should be considered, and adequate treatments, prophylaxis should be done for all of the women. During the pregnancy, we have seen that some of the factors could be increased, but some of the factors are not increased at all. And my recommendation would be during the pregnancy, keep the levels not lower, especially in the first 3 months, lower than 20%. And in the books that we are reading, the prophylaxis are usually recommended for fibrinogen deficiency and for factor 13 deficiency. And abortion, spontaneous abortion, is reported much more frequent for these two types. However, I think we need more data, more accurate data for all other types of the deficiency. Now, I want to bring something which is important to my opinion. Treating women with previous drugs using the concentrate, and most of the concentrate are plasma-derived product, once or twice a week, it wasn't really easy for the women. But if we have the novel drugs that has been used in hemophilia, and some of these drugs are bringing a concept of generation of thrombi and the different strategy that we're going to see, with much easier way of infusion, I think that is changing the quality of life of women. And we have to consider this strategy in the future, trying to avoid the excessive bleeding with menorrhagia, and also making the quality of life of our women also much higher compared to what was until now. So you can see in this balance, we have factors that are procoagulant and other ones are anticoagulant. What we want to have, we want to stay in a middle situation with the thrombin generation enough for not bleeding, but also not excessive thrombosis. And it's clear that if these products has been used for hemophilia and for von Willebrand in some cases, it might be used also for other type of disorders like coagulation disorders and for platelet alteration. I'm going to bring a little bit of information what we know. So there are 4 categories of the products. A part of emicizumab, which is bispecific antibodies that could be used in von Willebrand, for example, type 3, and is in clinical trial. But for other type of the rare disorder, there is products like fitusiran, and this is silencing serpin C1 mRNA with the reduction of transcription of antithrombin at liver site and with a long half-life. So if this product was used for hemophilia successfully, that means we might want to also use it in other type of the disorders. So it has been tested ex vivo, and it has been shown that it could restore the thrombin generation in factor 5-7 and factor deficiency. However, it has been shown it's better to have a minimum amount of the product for the full functionality of this molecule. There are two molecules that has been commercialized for the treatment of hemophilia with and without inhibitor, A and B, concizumab and marstacimab, and they are in making inhibition of TFPI with enhancing the extrinsic pathway. And again, these products have been approved by FDA and EMA. And I think we do not have yet any clinical trial data, but potentially could be used in factor 7 deficiency or in combined pathway defects in the future. Also, the easiness of the treatment is very important. However, these two molecules, we know them a little bit less because the knowledge on TFPI and the measure of the TFPI is less. And in both situations, the reduction of the concentration of the product brought less thrombogenicity. But I think it would be important to understand which is the amount of the product that could restore the generation of thrombi, for example, in rare disorders. The third one is a monoclonal antibody neutralizing protein S with reducing APC activity and increasing thrombin generation. And this strategy also has been used for von Willebrand disorder, is an ongoing clinical trial, and it might also help patients with factor 7, 11, and 13 deficiency in the future. And the HMB-001 is a bispecific antibody, could stabilize and binding, stabilizing factor 7A and increasing the half-life of this molecule. The preliminary results on Glassman was important, and this is a promising molecule in the future also for the patient with factor 7 deficiency. So all over, we can use bispecific products mimicking factor 8, and that could be done by emicizumab, Mim8, NXT007, which are a more powerful molecule compared to emicizumab, the next generation, and they can be used in von Willebrand factors where the generation of thrombin is important. And we have also several other molecules that I showed you with inhibition of antithrombin with small interference RNA, fitusiran, and also other strategy that could help us to reduce the anticoagulant activity as in plasma of our patients. For example, for anti-human protein S monoclonal antibody, we know that the preliminary results that has been shown during the ASH meeting with inhibition of protein S cofactor activity for TFP, alpha, and APC is restoring the thrombin generation in patients with hemophilia. And as I told you, it would be useful to think about in the future for patients with factor 7, factor 11, and 13. However, it might not be useful in factor 5 and factor 10 deficiency. And sutasimib for factor 7 deficiency, I think for prophylaxis is very important. And this is a phase 2 clinical trial ongoing. And I hope this molecule, which seems to be important in Glassman, it could be very important also for factor 7 and making the life of people who need the prophylaxis easier with a less infusion. What we have to consider in the future, I think, rare bleeding disorder all over are less severe compared to hemophilia. And we know that all these new molecules showed some thrombogenetic process and activity. Adoption and changing the dose of this molecule reduce the rate of the thrombosis. But I think it's very important in the future to find a good balance between the generation of thrombin and the anticoagulant effect and the reduction of anticoagulant effect and the condition of empowerness of thrombin in these patients, because I'm not sure the less amount or similar amount that has been used for hemophilia could be useful for rare bleeding disorder. Therefore, I think it would be nice to make also a basket type of clinical trial for all the rare disorder and understanding how this new molecule could improve the quality of life of our patient with reducing the number of the bleeding. And of course, other type of side effects also we have to keep an eye on that for the increase of ALT or any other type of the side effects, similarly also in the rare disorder. So all over, I would say, as a conclusion, rare bleeding disorder is a heterogeneous group of diseases, and we need to keep them separate and analyze them separately. But for these novel drugs, we might want to make a basket trial put together and understanding how they are working. So these novel drugs, they were really important in hemophilia, changed the quality of life of our patient, and now is a time also to think about the rare bleeding disorder, and especially our women with the rare bleeding disorder, where every month they are facing of the problem of menorrhagia, and also, as I shown, during the pregnancy and post-delivery. So I think it's a time to think about improvement and strategy and innovation in the treatment of rare bleeding disorder and improvement of the prophylaxis. And this was what I wanted to share with you, and thanks to the organizer for this program and for inviting me. Have a good day.
Thank you so much, Professor Peyvandi, for the excellent presentation of the rare bleeding disorder. Now we move to the next speaker. Our next speaker is Professor Megan Dilani, Chief Division of Pathology and Lab Medicine, George Washington University, Chair NIH Blood Safe Program. Professor Dilani is a pioneer leader in transfusion medicine and global health. Professor Dilani serves on the AABB Board of Directors and leads the NIH initiative to improve access of safe blood transfusion in sub-Saharan Africa. Please, Professor Dilani.
Good morning. Good morning, everyone. Can you hear me okay?
Yes.
Okay, thank you. And you can see my slides?
Yes, we do.
Okay, good morning. Well, good morning. I'm on the East Coast of the United States and it's early here. So I was asked to speak about fetal and neonatal alloimmune disorders. And I'm just going to dive in. As was mentioned, I'm at Children's National Hospital, and there I'm the Associate Chief Clinical Officer and the Head of Pathology and Laboratory Medicine and Transfusion Medicine. Here are my disclosures. So just to orient you to where I am, I'm at Children's National Hospital. So this is a 326 bed pediatric facility in Washington, D.C. We're a trauma center. We are a transplant center for organ and stem cell transplant. And we also do quite a bit of gene therapy. And we're one of the first in the U.S. to do sickle cell gene therapy and thalassemia gene therapy for children. We treated over 258,000 patients last year, and just some numbers. So just so you know where I come from. So we're a referral center. Patients, children with rare and common disease are referred to us from all over the region as well as all over the world. So the Zoom thing is in the way. Okay, so let's get started. So hemolytic disease of the fetus and newborn, and fetal and neonatal alloimmune thrombocytopenia, all very long names. I'm going to call them HDFN and FNATE. This slide is just to get us warmed up to talk about how they're similar and start to think about how they're different. So in both disorders, they are caused by maternal antibodies that cross the placenta. These antibodies attack fetal blood cells, but they attack different blood cells, and the manifestations of these diseases in the children differ. In HDFN, it's red blood cells. In FNATE, it's platelets. And some key things, but we're going to go through them in much more detail, is that for HDFN, there is standard screening for pregnant women, but not for FNAIT. And then the outcomes of these is very different, because one is the red cells, where you get anemia, in the worst case scenario, hydrops fetalis in stillbirth. And in FNAIT, the worst case scenario is to get an intracranial hemorrhage with resulting brain damage. So let's focus first on hemolytic disease of the fetus and newborn. So I'm not going to talk about this a lot, but I want to start with it. The most common cause of HDFN is actually ABO. So, and up to 20% of infants have ABO incompatibility with their mother. Because the ABO blood group system, which is shown here, you have the blood type at the top, and then the immune system makes the antithetical antibody for the blood type that you lack. And it's mostly an IgM phase antibody. And this antibody, that although you might have high levels of IgM antibody, of anti-A in your body, it doesn't cross the placenta because it's IgM. However, there is some component of IgG which is able to cross the placenta, and that tends to be the cause of ABO-HDFN. So this is more common in women who are group O, and something to always be thinking about when you're looking at a newborn who you suspect having HDFN. But I'm going to leave ABO and not really come back to it, because a lot of what we focus on and the most severe manifestations of HDFN are not ABO, but they are caused by minor blood group antigens. So this is sort of a picture showing the mechanism of HDFN, of maternal sensitization. So unless you are exposed to foreign red blood cells, you will not, the woman will not have foreign minor blood group antigens. And so this picture shows that sorry, let me go back, that if the mother has her first child, she's Rh negative, the fetus is Rh positive, she'll make anti-Rh antibodies. And then on her second pregnancy, those existing Rh antibodies may cross the placenta and harm that second pregnancy. This could also happen in the case of a mother who's transfused with Rh positive red cells if she's Rh negative. It's just a different way that she gets that initial sensitization event. And this is just showing this a different way, more schematically. So if you have a blood donor who donates group Rh positive red cells, and you give those red cells to an Rh negative person, they can make anti-D. If you make anti-D, you're fine as long as you don't need another transfusion. If you need another transfusion, then you can have a hemolytic reaction, because you now have preformed anti-D. This is now showing the HDFN version of this, is that if this is a woman who has a pregnancy, then that can cause hemolytic disease of the fetus and newborn. So in that way, hemolytic transfusion reactions and hemolytic disease of the fetus and newborn are somewhat similar in mechanism. However, blood groups are definitely much more complicated than just RHD. There are other blood group antigens that cause, the antibodies that cause HDFN. Now, before the advent of RHIG, or what we often call RhoGAM, anti-D was by far the leading cause. In a study that's kind of old now, but looking at maternal sera in a country in the Netherlands where many, many patients have access to RhoGAM, you can see here that the other red cell antigen specificities found in maternal sera vary. And you can still see, though, that D is still a major player, potentially because of failure of RhoGAM, not receiving RhoGAM, coming from a country that doesn't have access to the medicine. So how do we screen? I mentioned right at the top that for HDFN, we actually screen pregnancies for it. So it's very common. This is called this test has 5 names, but it's basically the antibody screen. The more technical name is the indirect Coombs test. And in this test, you take the mother's sera here that's on the left, and you, in the blood bank, you mix it with a donor blood sample that basically expresses antigen. And if that antibody is present, it will bind. And then by adding Coombs reagent, which is anti-IgG, you get agglutinants, because the Coombs reagent cross-links the patient's antibody that's already there with the reagent red cells that are basically the detector. And it shows you that you have a positive result. When you have a positive antibody screen, you then have to figure out what the actual antibody is. And that's the job of the blood bank. I'm not going into too much detail about that today. However, In the case of HDFN, a way that we grade the risk of that antibody to the fetus is through a couple of different lab tests, but one of the most important ones that we do is called an antibody titer. And this is really just a titer. You can see here at the top different wells, and you have the plasma 1-to-1 or neat, just pure plasma, and then it's in dilutions. And you do that same reaction in there with that maternal sera, and it will tell you when you look at the agglutination reaction, how sort of potent is the antibody in her serum. So it's a quantitative, a semi-quantitative way to assess this. The reason that this is important is that if as that antibody titer gets higher, there's an increasing risk to the fetus if the antigen is expressed by the fetus. Now, I haven't gotten to talk about that yet, but for example, these are the generally used critical titers for different antibodies. So you have a mother who has an antibody, she's currently pregnant. If the titer of D is 16, we consider that a quote unquote critical titer, and that means we need to go take action. And if it's in E or others, you can see these critical titers. The other way that we also look at it is that once we have a sensitized pregnancy, that every month that antibody titer is rechecked. And if you see a threefold increase, you know it's going up, and that denotes that there's a sensitization event happening, suggesting that the fetus is antigen positive. The trending is not useful if the previous pregnancy was impacted. So really the question that you want to know when there's a pregnant woman who has an antibody is, will that maternal antibody harm the fetus? I've been talking about it as if it might, but it really depends on if that fetus expresses the antigen. So I have a case in each topic here today just to sort of illustrate it. So in this case, this is a woman who is a G1P0. She has an anti-D titer of 64. She's serologically D negative, and the father of the baby is serologically D positive. We don't know where the anti-D came from. Not everyone remembers if they've been transfused, and sometimes there's unrecognized pregnancy or abortion. And so she has the anti-D, and we know that the dad is serologically D positive. So the question is, does that mean that the baby definitely, the fetus inside definitely expresses D or not? The answer is it's pretty tricky. Let's look at this. So the question is, here's possible answers. How do we figure out that if the fetus expresses D? So we could obtain fetal cells and amniocytes and do RHD gene testing. We could obtain fetal DNA from maternal sera for RHD gene testing. We could obtain paternal blood sample for RHD testing, or we could obtain fetal red cell sample by umbilical cord blood sampling. So some of these answers are right, some of these answers are wrong. Let's kind of go through it. So the blood groups on the red cell surface, which are in this kind of basic stylized picture here, are very, very complicated. And I always say that the surface of the red cell is like a jungle. There's all these different antigens being expressed, and the interaction of the immune system with these antigens is where we're focused. The Rh blood group system is the most complex, and it's here. And you can see it's a 12 transmembrane polypeptide, and there's actually two. There's one that's D, and there's one that's CE. So this is just some of the common blood groups, which you've probably heard of: the Rh system, the MNS system, the KEL system. And what I'm trying to point out here with this list is that with all of the blood groups that are listed here, which are the most common ones to be offenders of causing HDFN, there is an antithetical polypeptide blood group. So for instance, the KEL blood group system, you either express 2 copies of big K, 2 copies of little k, or one of each. You're heterozygous, okay? And that's similar for almost all of the blood groups, that we have what we call an antithetical allele, and we see that phenotypically on the red cell surface. The difference with D, which I've also told you is one of the most important causes of HDFN, is that you either have D or you don't. Everything is inherited in 2, but you can have 1 copy of D and be D positive, or you can have 2 gene copies of D and be D positive. And this matters when we're talking about paternal inheritance. So that's why my question about how do we figure this out when we know the mom has anti-D, we know the dad is D positive, but we don't know how many copies of the gene he carries. So here's a flow diagram to show this. So if the maternal antibody screen is positive and the red cell antibody is not anti-D, then you can phenotype the father for his zygosity. So if it was Kel, you could tell the blood bank, do a Kel phenotype of the father, and they're going to look at big K and little k, and then you can determine with the blood bank if that father is homozygous or heterozygous. If he's homozygous, the fetus is at risk. If he's heterozygous, then we don't know. It's a 50-50 chance, and we need to do fetal genetic testing to determine the fetal inheritance, okay? If it's anti-D, you can't do it in the blood bank as a standard blood group test. You actually have to do a genotype of the father to determine RHD zygosity. You're still going to end up with the same type of answers. Is he homozygous or heterozygous? But you cannot determine it with antisera. You have to determine it genetically because you have to look for the signature of the absence of the D gene in the DNA. So how do you determine if the fetus has the D gene or the Kel gene, if you want to do direct fetal determination, say you did an amniocentesis for another reason. So you can do it that way, using amniocentesis, culturing the fetal cells, and then doing a direct genotype on the fetal cells to determine their expressed red cell, what will be expressed. The other thing you can do, which is non-invasive and increasingly common, is that you can do cell-free DNA from the maternal plasma. So during pregnancy, the DNA from the fetus is sloughed through skin sloughing. It crosses the placenta in small amounts into the maternal circulation. So you can see the blue fetal DNA in the mother's blood, which is in the middle of the screen. And then you can send that to the lab that can probe and look for if the RHD gene is present, floating in the maternal blood. And if you find that, then you can say, okay, well, this baby that she's carrying is RHD positive. So what is the answer to our question? The answer is really all of those three, is that it's ideal if you can do zygosity testing for the paternal blood sample. But you also can do fetal DNA from maternal sera, or you could do amniocentesis. It just depends on the capability and the practice at your center. But I will say more and more and more, option B is what is chosen. And it's just the other ones are available as well. We don't do fetal red cell sampling from umbilical cord sampling for diagnosis. It's more likely that we would be doing such a thing if we're actually intervening and the fetus needs a transfusion. So let's talk about monitoring. So with all of that, I brought you to the point that now we have determined that the pregnancy is impacted. So the mother has an antibody. The antibody is expressed by the fetus's red cells. And so therefore, there's a danger that this fetus is going to be impacted by HDFN, which can have severe consequences, including death. So what happens next is they get put into a pathway that is usually always in the care of a high-risk maternal fetal medicine at a referral center. And what's going to be happening is there's going to be continuing of laboratory testing and fetal Doppler testing to look for signs of severe anemia in the fetus. So amniotic bilirubin is sort of an old test. I'm just telling you that used to happen. It doesn't really happen as much anymore. And then again, sometimes centers continue to do antibody titers, but the titers are usually used in the time as you're determining if you're going to put the woman into a high risk category. So the most besides delivery, the most severe, if you will, high-grade treatment that you would do for a fetus that's still in utero is to do intrauterine transfusion. And the standard way that this is through serial sonograms of the fetus. So usually what the high-risk MFM is doing is they're doing titers and they're doing this ultrasound sort of every few weeks. And so this ultrasound is actually looking, and you can sort of see this on the screen, at the fetal middle cerebral artery, and it's a Doppler, and it's looking at the speed of the blood through that vessel. And if it changes, and the way it changes is a statistical analysis, if it's 1.5 multiples of the mean of peak velocity, this predicts moderate to severe anemia. Now, it is a screening test, so it can overcall, but this is generally the way that the high-risk obstetrician is going to decide what to do next. And depending on the fetus's gestation, it might be delivery, or if it's a severely impacted pregnancy and you're early in the pregnancy, you can't deliver yet. So they're going to do an intrauterine transfusion. So for intrauterine transfusion, the blood bank needs to be involved because it is quite a very special transfusion, right? We're actually transfusing a fetus. And the product needs to be maternally cross-matched, irradiated. We use leukocyte reduced, HBs negative. And usually that product is made that it's quite higher hematocrit. Like we actually do often a calculated hematocrit. Different centers do it different ways. And then the doctor does either the approach is either intraperitoneal or intravascular, depending on the size of the fetus and the way that doctor decides to approach it. So once you're in this pathway of intrauterine transfusion, sometimes it requires multiple intrauterine transfusions to suppress fetal erythropoiesis until the fetus is of a gestational age that they can safely deliver. So what is the outcome of children with that have undergone intrauterine transfusion? So this is an interesting study done in Northern Europe, looking at 291 children that were now average age of 8.2 years. So they ranged in age from 2 to 17 years. And they were actually, it's really interesting, like they were looking at neurodevelopmental impairment in children who had been severely impacted by HDFN. And they found that 4.8% did have neurodevelopmental impairment. I mean, you can see these different types, cerebral palsy, developmental delay, bilateral deafness. And on the graph, what it's showing is that they graphed it by markers of high drops, so having severe fetal anemia, or sort of mild hemoglobin decline. And what it shows is that the patients that had high drops, so that's the red dots, the severe, had more risk of neurodevelopmental impairment than those that had mild disease, which makes sense. It correlates with that having severe fetal anemia in utero really is not good for the development of these children, and so really should be managed very aggressively. So once the baby is born, again, this is sort of showing the clinical spectrum of HDFN. It can be, almost no anemia with just a direct Coombs test, and that's sometimes what you see more commonly in ABO HDFN, all the way up to neonatal jaundice, that's an anemia, and then as I just mentioned, the most severe manifestations, hydrops fetalis and death. So once the baby is born, you think about the anemia of HDFN, and there's different levels of anemia. So just getting the baby through delivery is not the end. They need ongoing care by a pediatric hematologist. So at the beginning, you're really focused on that antibody-mediated hemolysis, and that's where you may need to do, if it's really severe, a neonatal exchange transfusion. But as the baby ages, there's a later hemolytic anemia if the antibody is still present. Some of the maternal antibodies really are hanging around in that child's system for a long time, and they need continued monitoring to make sure that they're developing, that they're feeding. And then the late hyporegenerative anemia is when there had been potentially like a KEL antibody, which can cause suppression of erythropoiesis, and that can be a longer lasting manifestation of HDFN in the infant. So this is just showing that again. I'm just going to keep moving into the other thing I want to talk about is the management. The initial management is, of course, phototherapy, because the bilirubin itself is toxic to the the neonatal brain. And so that's important to have a laboratory that can get your bilirubin test done quickly. And then you have the lights to help with the metabolism of the bilirubin, because the neonatal liver is not equipped to do that, is in that level of need. In terms of neonatal exchange transfusion, I mentioned this. This again is a very special blood product with all the processes here. Usually it's done with reconstituted whole blood. So the blood bank will mix for you red cells and plasma together. And then it's done with a few mils in and a few mils out. It's usually a 2 blood volume exchange. And that's really to do when usually done in the early stages of HDFN after the baby's born. So I also just want to talk a minute about primary prevention of maternal sensitization. So this is going back to transfusion. So if we think about moms that have risk of sensitization from the transfusion service side, is that we always reserve Rh negative blood for women who need emergent transfusion, such as trauma. That's primary prevention. Secondary prevention is giving RhoGAM to women who are RhD negative, which is incredibly important and incredibly effective. And then last is once a woman is sensitized, is to give extended red cell matching for intrauterine transfusion. So this is a study that I did. I just want to tell you about as my last item in HDFN. It's called the AMIGO study. We looked at 14 centers across North America and Europe, and we looked at women who had severe HDFN, and we tried to figure out why did they have it? Was it due to transfusion, previous pregnancy, or unable to determine? And what we found was that vast majority of severe HDFN is caused by previous pregnancy. So you can see here it's 83%. A small minority is definitively caused by blood transfusion, and that's usually given in emergent situations such as following a traumatic accident where they need uncross-matched blood. And then we weren't able to determine in about 14%, and that was people who had both transfusion and pregnancy before the case of HDFN. What we wanted to know is, does it make sense to provide sort of Kel negative or little c negative red cell transfusion to women of childbearing potential to see if that could prevent HDFN in the future? So we stratified our centers by if they matched in that way or not. And then we tried to see if they had a difference in having severe HDFN. So I can just show that the table makes it make more sense. So the UK, Sweden, the Netherlands, and Australia all do, if you're a woman less than 50, you get Kel negative blood in the UK. If you're in Sweden, besides ABO and D, and if you're in Sweden, you can see here, they're all a little different. And we compared those to the no-match centers, which were 7 centers in the US and Canada. And we wanted to find out, did these countries have different rates of HDFN? And essentially, of those 293 mothers, what we found, the match centers versus the no match centers, is that it's really, really small numbers. And what we were actually comparing was the people who received red cell transfusion and had previous pregnancy, and who received red cell transfusion and no previous pregnancy. And so we had to compare 31 and 2 and 11 and 6. So those are really small numbers, because you can see most women who have babies do not have previous transfusion. And that's because most women who have babies are healthy, and transfusion is associated with either pretty severe illness or trauma. So what we found is that that of the 50 women who received red cells before pregnancy, 17 were alloimmunized to Kel, 13 were at match centers, and 4 were at no match centers. And so of 12 of the 13 Kel sensitized women at match centers had partners who were Kel positive, suggesting that it wasn't transfusion, but it was actually the partner who sensitized them. And of the women who received red cells who had partners that were Kel negative, the number attributed to transfusion were too small to make conclusions. So essentially what we found is that we couldn't detect that matching caused a protection for HDFN, but we also found that many women came from other countries. And so they occurred in a region not covered by the Match Center's transfusion policy. So just interesting data. I still think that providing antigen negative blood for women of childbearing potential is a good idea, but it would be ideal if the whole world could do it. So now I'm going to quickly talk about fetal and neonatal alloimmune thrombocytopenia, and this will be a quicker part of the lecture. And just to tell you about where it comes from. So again, it's a sensitization event, and this is based on the father and the mother being discrepant in their human platelet antigen type. So the mother will be 1B, 1B, and the father is 1A, 1B. So that means the father expresses the 1A antigen and the mother is negative. And so in this situation of, this is sort of a version of what a Punnett square would look like, there's a 50% chance that the child of this pair will express the 1A antigen, and that the mother could be sensitized and make that antibody. So in this situation, the mother is 1B, 1B, and the baby's platelets enter the mother's bloodstream and are recognized as foreign. The mother makes the antibodies to HPA-1A, and that crosses the placenta to bind to the baby's platelets. And the baby has thrombocytopenia. What's very different with this compared to HDFN is that FNAIT can be caused in the first pregnancy, whereas our HDFN usually is not unless it's preceded by transfusion. So what happens? So when we have the mother, when the antibodies cross into the baby's HPA-1A positive platelets are destroyed, and the baby is at risk of bleeding. Okay, and the danger for bleeding is in the brain. So this is a sort of a complicated rubric, but it came from a really good article. I'm just calling attention to it. And it just sort of shows what I went through with HDFN, but it sort of more briefly. Again, we want to look at, is the father homozygous or heterozygous? And then is the fetus positive or negative? And so this is recommended to be done by fetal DNA from maternal plasma. And then you look at if you do have an at risk, which is over here, the father's homozygous, and the heterozygous, it's possible that the fetus is at risk. Once you're in the at risk pathway, then you want to know, did you have a previous pregnancy that was impacted or not? At 12 weeks, standardly, previously affected moms will get intravenous immunoglobulin, and at 20 weeks that may continue, and it may or may not add prednisone as well. At 28 or 32 weeks, there's continuing intravenous IVIG, and then delivery. Okay, so it's this is pretty evidence-based, these approaches here, and have been studied pretty extensively. I have a quick case, though, about a transfusion. So that's more about maternal management. But now we have the baby born. And so we're taking care of that baby now in our hospital, and that has affected by FNAIT. And we have a baby that's severely thrombocytopenic. The pediatrician has prescribed a platelet transfusion. So my question is, which platelet are we going to give? Do we call the blood supplier to collect HPA-1A negative platelets? Do we consult with the transfusion medicine to have the mother donate platelets because she herself is HPA-1A negative? Or should we use standard platelets off the shelf to provide platelet transfusion immediately? So I really want to make sure everybody knows that A and B are going to take a lot of time. And while in the red cell version of this disease, right, HDFN, we really do want to give antigen negative red cells to the baby. In this situation, what we have found is that the antibody is maybe avid, and you can get away with giving sort of standard off-the-shelf platelets to this baby, and you will still get a very nice increment. The problem with A and B, and so the answer is C, okay? And it's really important that everybody remembers that. The problem with A and B is they will take a long time. And the last thing we want is for that baby to be sitting there at a platelet count of 17 for any amount of time. We want them to get platelets immediately. So we use off-the-shelf platelets to provide platelet transfusion immediately. Okay, Almost done. So the last couple thoughts I have for you is just sort of where the treatment and screening of FNAIT is going. So there are thoughts to type mothers, to find mothers who are HPA-1A negative or HB1B. And if they are in that situation, to actually do an antibody screen. So there's thinking about doing that more broadly. As I said, there's now fetal DNA from maternal sera to determine the HPA type of the fetus during pregnancy. There's also work in progress to create an immunoglobulin-like RHIG for FNAIT prophylaxis. And maybe the most exciting is what's at the bottom, is there's a new medication called nipocalimab, and the mechanism of action is here. And what it is it's an antibody that is to the neonatal FC receptor. And so what this does is it preferentially decreases it when you give it to it decreases the basically the inciting antibody from crossing and getting to the receptors that then cause the high level in the fetus. So basically specifically lowers maternal blood IgG, and it blocks IgG transfer to the fetus. So this nipocalimab medication is really the first medication that's specifically targeted at this type of disease and is being used in that way. So in conclusion, HDFN and FNAIT are the detection and prevention vary by disease, and the diagnostic and approach to both of these diseases has multiple layers, and they're quite complicated. The management is important. That pregnancy and delivery, I recommend are really especially done and managed in partnership with referral centers, and should begin in pregnancy whenever possible. So this is why it's so important in early prenatal care to understand what the results of a red cell antibody screen mean, to understand if a woman has ever had a previous pregnancy by FNAIT. And the monitoring and intervention are critical, as well as infant monitoring and intervention. So I want to thank you very much for your time and for inviting me. And I'm happy to take any questions. Thank you.
Thank you so much, Professor Diliani, for the excellent presentation. I don't see any questions for you. So thanks so much for joining us. And we'll move to the next speaker. Bye.
Okay, thank you so much, everyone. Thank you for inviting me. Have a good day.
Thanks, same to you. Now, our next speaker is Ibrahim Al-Ghaiti, consultant pediatric hematologist oncologist, Royal Hospital, Oman, Canadian and US board certified with over 2 decades of leadership experience. Dr. Al-Ghaiti has spearheaded national initiatives in medical education, e-health strategy, and AI integration within the Oman Ministry of Health. Please, Dr. Ibrahim.
Assalamu alaikum and good afternoon, everyone. Let me do this. I'm trying to share my slides. Can you see my slide, Dr. Najat?
Yes, yes, Ibrahim. Yes, I do.
There we go. Perfect. So thank you, Dr. Najat, and thanks for the scientific committee and the organizer for the kind invitation. My task today is to present to you about neonatal polycythemia and hyperviscosity, and to focus when to intervene. I promise, it won't be longer like Prof. Daniel. So I have nothing to disclose. Over the next 20 minutes or so, we're gonna cover a few objectives. First, we will try to define the two concepts of polycythemia and hyperviscosity. Obviously, we'll go over the pathophysiology of both. We'll highlight the clinical manifestation and diagnostic approach. We try to interpret the hematocrit in the neonatal context. We will spend more time on management, trying to distinguish when and when not to intervene, and we will touch base on evidence for this approach. So at the beginning, why we are talking about neonatal polycythemia, why it is important. First, because it's quite common, up to 5% of newborn are affected by polycythemia. Second, most of these babies are asymptomatic at presentation. Third, there is quite significant variation in management of neonatal polycythemia across different international centers. So the challenge, the real challenge, that since most of these babies are asymptomatic, it's very hard for us as physicians to distinguish among them who will develop, symptoms or lately develop hyperviscosity syndrome. And the key question is when to intervene. Therefore, over the next few minutes and slides, we will try to, answer this question. We'll start to define the two concepts of neonatal polycythemia and hyperviscosity. When it comes to neonatal polycythemia, the definition is around the hematocrit and hemoglobin level, which should be above the upper normal level, which is more than 2 standard deviations for gestational age. But given that venous compared to capillary samples, there is a discrepancy between the two, where capillary may, give a higher level, up to 15% compared with the venous. The definition is based on the venous sample. Therefore, neonatal polycythemia is defined as a venous hematocrit of more than 65% or hemoglobin more than 22 grams per deciliter. And over the next, few slides, we're gonna understand from where this 65% comes. So as you have, on the other hand, the hyperviscosity is defined as increased resistance to blood flow due to elevated whole blood viscosity. So as you may see, the two concepts are not the same. The definition is different. And also, many of the polycythemia babies won't eventually develop clinical significant hyperviscosity. So yes, we have a difference in the definition of the two concepts, but also there is a difference in the measurement of how to confirm these entities. In polycythemia, the measurement is based in hematocrit, which is widely available, and in somewhat it guides the management. The other hand, hyperviscosity, you need a special test, viscometry, which is rarely available only in a research setting. Now we'll move to physiology and epidemiology. If you look to normal neonatal hematologic physiology, there is increased fetal erythropoiesis. This comes due to relative intrauterine hypoxia. This will lead to a high red cell mass at birth, and immediately the hematocrit will peak in the first 2 hours after birth, but due to placental infusion and fluid shift, but later on it will return to our code value around 18 hours. Due to this, relative hypoxia and high red cell mass, many of the term newborns may develop neonatal polycythemia with an incidence of up to 2% for those delivered at a sea level. And this incidence may go up to 5% for same-term newborns who are delivered at high altitude. So high altitude is one of the risk factors, as we're gonna see in the next few slides. Also, delayed cord clamping influence the incidence. But look into the incidence of hyperviscosity compared to neonatal polycythemia, the incidence is less common in all contexts. Now we'll talk about the pathophysiology of hyperviscosity, which is based around the increased RBC mass. This will lead to reduced microvascular flow, impaired tissue perfusion, and eventually may lead to multi-organ dysfunction. So yes, so eventually it leads to multi-organ dysfunction, which specifically to brain, kidney, and GI. Is somebody trying to ask a question? Okay, we'll continue. So this graph represents the relationship between hematocrit and viscosity. As you may see, below 60% of hematocrit, the relationship almost linear. But at the point of hematocrit of 65%, a minor change in hematocrit will lead to a major change in viscosity. And this is from where that 65% of hematocrit comes into the definition of neonatal polycythemia. So talking about causes of polycythemia, it is divided in two groups, one due to passive transfusion and the other is due to more active causes. So under the passive transfusion, we have delayed cord clamping, cord milking, twin-to-twin transfusion, obviously the recipient, and obviously maternal fetal transfusion. Under the more active causes, which will lead to increase in intrauterine erythropoiesis, as we have seen, the high altitude exposure, but also intrauterine hypoxia, IUGR, and preeclampsia, maternal diabetes, endocrine disorder like congenital hypothyroidism and adrenal hyperplasia, and also chromosomal abnormality like trisomies 13, 18, and 21. Look into the risk factor for neonatal polycythemia. They might be related, maternal related, or placenta related, or neonatal related. Under the maternal factor, we have maternal diabetes, either gestational or pre-existing, also preeclampsia or hypertension, smoking or substance abuse, and high altitude residence. Under the placental related factor, we have delayed cord clamping, cord milking, twin-to-twin transfusion, and maternal fetal transfusion. And the neonatal factors include small and large for gestation, post-term gestation, chromosomal anomalies, and intrauterine hypoxia. Now let's move to the clinical manifestation. As we have highlighted before, that most of babies who has neonatal polycythemia are asymptomatic. Therefore, clinical suspicion should be there for those with risk factors. But it is possible finding in these babies include plethora, poor feeding, vomiting, lethargy, and cyanosis and apnea. When they develop, symptom, usually these are organ-specific manifestation, and they are due to the hypoperfusion, due to the microvascular sludging, and possibly, hypoxia. So these baby might have, neurologic manifestation, including irritability, jitteriness, and seizures. Also might have cardiopulmonary symptoms like cyanosis and tachypnea. GI symptom may include feeding intolerance and abdominal distension. Renal symptom may include oliguria, hematuria, and acute kidney injury. And more commonly, the metabolic, obviously the hypoglycemia, hyperbilirubinemia, less likely the metabolic acidosis. And there is some possible hematological symptom, thrombosis, bleeding, and thrombocytopenia. So now we'll move to the diagnosis. Again, since majority of babies with neonatal polycythemia are asymptomatic, routine screening for the baby is not recommended, and instead, the recommendation is to do targeted testing for two groups: those with symptoms and those with high risk. We already highlighted these two groups in the previous slides. What I want to point out here is actually do not do a capillary hematocrit in the asymptomatic, low risk, neonates. Obviously, because the false positive results will lead to unnecessary workup and potential anxiety for the parents. We have highlighted the difference, between the capillary and venous hematocrit. That's why sample type is critically affect the measured hematocrit, because capillary sample consistently overestimate the venous value up to 15%, and that is because of the peripheral stasis and arterial enrichment. Therefore, if you do a capillary hematocrit and the result comes more than 65%, then you need to confirm that result with a venous sample. So just to summarize and highlight the simple diagnostic algorithm, the recommendation is to do target testing for two groups: the symptomatic and the babies with high risk. The recommendation to do a venous sample, and the confirmatory is the cutoff is a hematocrit more than 65% on a venous sample. But if eventually you do a capillary, if the result is more than 65%, then you have to confirm that sample with a venous sample. So again, to highlight that accurate diagnosis of polycythemia depend on the hematocrit measurement. There is three confounding factors around this. One is the sample type, which we already highlighted, that the difference and discrepancy between capillary and venous. The second one is age at sampling, as we highlighted before, that the hematocrit will peak in the first 2 hours immediately after birth, but it will decline toward the cord blood level by 18 hours. So you have to take in consideration at what time you do the sample. Third is the measurement method. Centrifuge sample yield higher value and better correlate with the blood viscosity compared with the automated cell counters. Finally, for those baby with confirmed neonatal polycythemia, you need to remember to do blood sugar and bilirubin because of the high risk of hypoglycemia and hyperbilirubinemia in these babies. Also, remember that polycythemia shares many features with other, serious neonatal condition. And therefore, it is very important to rule out other differential diagnoses, which include but not limited to sepsis, pneumonia, congenital heart disease, dehydration, stroke, and intracranial hemorrhage. Now we reach to the management. Over the next few slides, we try to differentiate to when and when not to intervene. Many of the recommendations I'm going to present is based on more of international expert opinion rather than evidence-based. But at the end, we will try to highlight some of the evidence, regarding the management. So again, given that most of neonatal polycythemia are asymptomatic, the recommendation for asymptomatic babies with a venous hematocrit between 65 to 70% is just to do observation, provide feeding support, hydration, and then repeat the hematocrit after 12 to 24 hours. During this time, to monitor, ins and out, daily weight, and also don't forget to monitor blood glucose and bilirubin level, as we indicated, because they are at a higher level of hypoglycemia and hyperbilirubinemia. So when to intervene? For those who develop symptoms, those who has risk of hypoglycemia, those with inadequate oral intake, and obviously those who develop progressive clinical symptoms. First line of intervention is simple intravenous hydration. Target is a minimal fluid intake around 100 ml per kg per day. Try to use dextrose infusion to prevent and treat hypoglycemia. And remember that the first 2 days are critical window for such intervention. The second line of treatment is the partial exchange transfusion, which should be reserved only for severe symptomatic polycythemia or when supportive measures alone are insufficient. Obviously, for those with significant cyanosis, recurrent apnea, severe hypoglycemia, and those with progressive symptoms. The goal of partial exchange transfusion should be to reduce hematocrit to approximately 55%, and that because at this level, the hyperviscosity related symptoms typically resolve without overcorrection. Recommendation is to use normal saline simply because it's readily available and well tolerated. As been highlighted in previous, presentation, there's 2 ways to do, exchange transfusion, including the partial exchange transfusion. We won't go in details, but simply the isovolumetric technique, where simultaneous withdrawal and infusion, which will maintain, stable blood volume throughout the procedure. The other technique is the serial aliquot techniques, where you do stepwise withdrawal and replacement in calculated aliquots. This is simpler to perform at the bedside. How we do calculate the exchange volume with the famous formula that observed minus the desired hematocrit multiplied by the blood volume and divided by the observed hematocrit. Now remember, the blood volume in the neonate is estimated around 80 to 90 ml per kg, and your desired hematocrit is 55%. So look into the benefit versus risk of partial exchange transfusion. There is some evidence that partial exchange transfusion may improve cerebral blood flow, may improve oxygen delivery, and may improve systemic perfusion. But definitely it has its own risk. So there is the umbilical venous catheter-related complication. There is some risk of thrombosis, GI injury, and necrotizing enterocolitis. Most importantly, remember, it's an invasive procedure, so it had to be done under aseptic technique, and you need to monitor these baby throughout the procedure. So in this slide, just to summarize and highlight the management to, when and when not to intervene. So as per the expert opinion, for those asymptomatic babies where their venous hematocrit between 65 to 70, the recommendation is just to do observation. On the other hand, for those babies who are asymptomatic or babies with symptoms and their hematocrit more than 70%, recommendation is to intervene. The first line of treatment is simple IV hydration. The second line is partial exchange transfusion. Now we will touch on what does the evidence show. So previously I had like 10 more slides about different studies, but just because of time, I thought to summarize everything in one slide. So looking to partial exchange transfusion, there is evidence of some evidence of short-term physiological improvement. So the partial exchange transfusion may reduce hematocrit and may improve acute symptom, but definitely there is no proven long-term neurodevelopmental benefit because so many studies have failed to provide high-quality evidence supporting improved developmental outcome. In addition, there is significant variation among centers, simply reflecting the absence of standardized guideline. What I'm trying to present to you here is a major controversy, but everyone agrees that the hematocrit value alone should never dictate management. So, in summary, the take-home message that you need to confirm your diagnosis with a venous samples. Remember, polycythemia is not exactly hyperviscosity. Remember that most infants with neonatal polycythemia are asymptomatic. And remember to monitor their glucose and bilirubin because of the high risk of hypoglycemia and hyperbilirubinemia. When to intervene, we have highlighted, but remember that exchange transfusion is reserved for selected cases, and the long-term benefit of partial exchange is unproven. And finally, treat the infant, not the numbers. With that, I reach the end of the presentation, so thank you.
Thank you so much, Dr. Brahim, for the excellent presentation. There are a few questions for you. The first one, how to measure viscosity plotted on the curve? I mean, the curve you've shown.
Again, please. How to
measure viscosity plotted on the curve? This was the question.
In clinical practice, we don't measure viscosity, as I highlighted that viscosity need a viscometry, which is only available in research setting. So we don't measure viscosity. We measure the hematocrit. So we try to diagnose clinically based on the venous sample of hematocrit, and we assess viscosity by the clinical feature and the clinical profile of the baby. So viscosity itself is not, or testing viscosity is not in clinical practice.
Okay, the second question for you, Ibrahim, is neonatal polycythemia, polycythemia, does it predispose to polycythemia vera in the future?
I'm not quite
sure. We don't know.
I'm not quite sure. I don't want to answer something I'm not sure about, Dr. Najat.
Okay, the second or third question. Third question, Ibrahim, any prophylaxis as anticonvulsant, for example, if the child is jetric or convulsing?
Obviously, if he has a convulsion, we have to manage that convulsion. We have to not only to prevent, to abort that convulsion. And you have to differentiate, is it related to polycythemia? Remember, many of these babies who have polycythemia, they actually might have underlying other conditions. So yes, but you have to diagnose, is it just polycythemia or something else?
Definitely, you need to treat, like if the baby is an infant of diabetic mother and has hypoglycemia, you need to treat the hypoglycemia, which is occurs in along with the polycythemia. So treating both the conditions, it will, it's the solution to prevent convulsions in the first place. And if it occurs, first you give, these are the primary things, and then maybe you need to consider anticonvulsant if it persists. Okay, thank you so much, Dr. Ibrahim, for the excellent presentation. We move to the next speaker. Our next speaker is Professor Suji Samarasinghe, consultant pediatric hematologist and oncologist, the Great Ormond Street Hospital for Children, London. a leading expert in bone marrow failure, aplastic anemia, and childhood leukemia at one of the world's most prestigious pediatric institutions. Professor Samara Singh is renowned for advancing treatment protocols for complex hematological conditions in children. Welcome, Professor Samara Singh.
Thank you so much for the invitation. I'll just share the slides. Oh, what's happened there? Is it on presenter view? Because I can't.
Yes, we do see your slides.
Oh, yeah.
Professor.
Is that okay?
It was better before. And just
It was better before.
Yeah.
Is that okay? Can you? Or is
Maybe
it
like this, bigger, little bigger.
bit bigger?
Just put slideshow, Prof.
Hang on a second. Is that helpful or not?
Duplicated slideshow.
Is it showing this? Is it showing the subsequent slides as well?
It's showing do you have a notes to read?
Yeah, you can see that. Can you see the subsequent slides as well? If not,
yes, we can. You're in presenter view, Prof. Sujit. So
okay. Should I start?
You need to come off presenter view.
Okay. Is that any better, or is
Perfect.
that perfect? Okay,
That's
thank
good.
you. Okay, so thank you so much for the invitation. So I'll be talking to you about inherited bone marrow failure syndromes and really about how to recognize these inherited bone marrow failure syndromes early, because that influences your transplant decisions and outcomes. Right. So what are the inherited bone marrow failure syndromes? Well, they're really rare. They're a group of rare inherited disorders. They're characterized by impaired hematopoiesis leading to bone marrow failure, but they're often associated with extra hematological features and cancer predispositions. So the classic examples, most common is Fanconi anemia. We get the telomere biology disorders such as dyskeratosis congenita, the ribosome disorders such as DBA and Schwachman-Diamond, and then there are other disorders which increase your risk of getting both bone marrow failure and leukemia, such as GATA2 deficiency. Why is recognition important? Well, it impacts your treatment. So your transplants and supportive care strategies really depend upon getting distinguished between inherited versus acquired aplastic anemia. Many of these conditions increase your risk of late cancers. I'll show you that. And so it's important for long-term surveillance. It's important for genetic counseling, family planning, and it's also, and I'll show you data for this, important for early and accurate diagnosis, reducing complications and improving long-term survival. So you need to consider inherited bone marrow failure if the features are atypical, early onset, or if there is a relevant family history. So looking at the different causes of inherited bone marrow failure, you've got your DNA repair disorders. That's such as Fanconi, where you've got a defect in your DNA repair pathway leading to chromosome instability, bone marrow failure, cancer predisposition. You've got your telomere biology disorders, where you've got defect in your telomere maintenance. You get accelerated shortening of telomeres, leading to stem cell dysfunction, organ failure, and marrow failure. And that classic is dyskeratosis congenita. You've got your defects in your ribosomes. And so that again leads to congenital abnormalities, impaired hematopoiesis. So that's DBA and Schwachman-Diamond. I won't talk to you because you've already been spoken, had a talk on this on congenital neutropenia syndromes. And then finally, it's the germline myeloid predisposition syndromes such as GATA2 and SAMD9. And you need to think about these disorders when you see any child with aplastic anemia. So when should we consider inherited bone marrow failure disorders? So if you have clinical clues, so such as short stature, thumb or radial abnormalities, if you've got abnormal pigmentation or nail dystrophy, recurrent infections, or organ disease. Hematological clues would be persistent macrocytosis, unexplained cytopenias, obviously hypocellular marrows, and particularly childhood myelodysplasia syndromes. It's a high incidence of inherited bone marrow failure disorders if you have that. Family clues would be any family history of blood disorders, early malignancies, other organ dysfunctions such as pulmonary or liver fibrosis, and unexplained early death. So you need to think about this when you're seeing children with cytopenias who have physical signs or unusual family history. So one of the difficulties that we face is if you've got your child with aplastic anemia, how do you distinguish between inherited versus acquired? Acquired has a different treatment pathway, different transplant conditioning, often requires immune suppression, whereas inherited is very different. And this is some data looking at the predictive value of a PNH clone and acquired 6p copy number loss of heterozygosity, and also got clonal TCR rearrangements. And you can see, so any child who comes to us who has, for example, a PNH clone, we know they're highly likely to have acquired aplastic anemia. There's a high specificity, high positive predictive value, but it's got a relatively low negative predictive value. So in other words, absence of a PNH clone doesn't mean that you haven't got acquired aplastic anemia. But if you have PNH clone and acquired 6p copy number loss of heterozygosity, that makes it much more likely that you've got an immune-mediated aplastic anemia rather than inherited aplastic anemia. So just to give you an idea how common it is, I'll talk to you about this paper that was published in Blood now 4 years ago, and they looked at 700 patients between 1989 and 2015, and they didn't do any testing for inherited aplastic anemia. They treated everybody with transplants, but they kept the DNA, and then they checked after the transplants about whether these patients had inherited bone marrow failure or not. And what they found was that 83% of patients didn't have a germline finding, 10% had a carrier in an inherited bone marrow failure disorder, and 7% had a previously unrecognized inherited bone marrow failure disorder. So 7% about of your patients, so 1 in 10 with aplastic, what you consider to be acquired aplastic anemia, probably will have an inherited bone marrow failure syndrome. And the kind of examples that were missed are things like Fanconi, telomere biology disorders, GATA2 ribosome disorders. So you need to think about this, particularly in younger patients or those with atypical history. And so why is it important? Well, they then looked at the outcomes post-transplant for patients in these different categories. So you've got survival. In red, you've got carriers, blue, no variant, and green with the unrecognized inherited bone marrow failure syndromes. And you can see clearly they did much worse. And you can see the same with they subdivided it with telomere biology disorders and those with, say, Fanconi anemia or other DNA damage disorders. You can see in green, if you had an particularly telomere biology disorder, DNA damage disorder, you did much worse than those patients who didn't have these disorders. So that's why it's so important. So the key message here is that if you miss it, they will result in low overall survival after transplant, earlier decline in survival. It really highlights the importance of genetic diagnosis before transplant because it impacts upon your donor selection, your conditioning, your counselling, and post-transplant surveillance. So what's our approach to aplastic anemia? So we confirmed aplastic anemia. Obviously, you've got to have a hypocellular marrow and the child's got pancytopenia. We check for secondary causes such as autoimmune disorders, drugs, infections. Then we check, obviously, the clinical history, clinical exam, family history. On every single patient, we do chromosome breakage disorder. We do telomere flow fish for everybody, and we do NGS panels. We do PNH screen, and we check for copy number loss of heterozygosity. Now, one of the most important things is how long does it take you to get these results? And time is of the essence. You don't want to be waiting months. So we have a next generations panel, which has nearly most of the bone marrow failure genes, and we can get results from the child who presents to us within 2 weeks. We get our Fanconi testing within about 4 weeks, our telomere lengths within 4 weeks. Rarely we can't make a diagnosis, and so we also are fortunate enough to have whole genome sequencing, but it takes about 2 to 3 months. But it's so important to be able to know, should you go down the acquired aplastic anemia route or the inherited, ideally by as early as possible. And for most patients, we can get that done within 2 to 4 weeks. So with regards to transplantation inherited bone marrow failure syndrome, you've got to screen related donors. Okay, because a sibling donor may be affected, so you've got to screen for them. Don't use obviously untested related donors. If you think you might not have a suitable related donor, then obviously you've got to do an unrelated donor search. You obviously have to modify the treatment conditioning because children with inherited aplastic such as DKC or Fanconi are more sensitive to radiation alkylation, and they will need reduced intensity conditioning treatment. They're also more sensitive with DNA repair disorders to radiation, so you need to avoid that where possible. And they need long-term malignancy surveillance, and I'll show you why that is. So what age do these disorders present at? So this is looking at Fanconi at the top left, disc keratosis congenita, DBA, and Schwartman-Diamond. Fanconi normally presents in young children, median age is about 6.5. DKC in teenagers, about 14. DBA much earlier, around about a few months of age. Schwartman-Diamond even younger, around about a few weeks of age. So I'll give you a clinical scenario. It's a 9-year-old girl who presented to our unit with severe aplastic anemia, presented with fatigue, bruising, infections, had pancytopenia. Everything else in her family history and past medical history is fine. She's really short. She has hyperpigmented patches on her neck, axillae. She has abnormal thumbs. The bone marrow investigations show a hypocellular marrow, but there's no evidence of myelodysplasia. She has a sibling donor. There's parents are healthy. There's no consanguinity. So would you go to a transplant with that sibling donor? So that's the question that we often have to face. And in this particular case, the child's testing came out with positive on the chromosomal testing for Fanconi anemia, for the DEB test. And we know, as I said to you, that they can't have the standard conditioning regimen, the high risk of toxicity, secondary malignancies. And you have to test a sibling. So in this case, we couldn't use it because we had to test, so we had to wait, and you had to check, obviously, the DEB test if required, if required, the genetics of this sibling as well. So you can't proceed to transplant until the donor status is known. As I said, it does affect your transplant implications and long-term surveillance. So not all aplastic anemia is required to look at the physical clues and do your testing is required before transplant. So what is Fanconi anemia? As I said, it's a disorder, it's an inherited disorder. Normally it's autosomal recessive, characterized by bone marrow failure, congenital abnormalities, and cancer predisposition. It's a disorder of your Fanconi DNA repair pathway. They get stem cell failure, genomic instability, classically bone marrow failure, but with thumb or radial abnormalities, cafe or low spots, short stature or other congenital abnormalities. They're really high risk of bone marrow failure, increased risk of MDS, AML, solid tumors, and as I said, they need long-term surveillance. Now, not all Fanconi anemia patients have clinical signs, but the majority do. So the commonest is cafe lay spots. After that, it's short stature, then low birth weight, microcephaly, and thumb abnormalities. They may often have many other abnormalities, so you do need to have a careful look. But the phenotype's often variable and incomplete. Now, this curve shows you the natural history of Fanconi anemia over time. So you've got time in years in the bottom and the incidence, and you've got hematological onset of bone marrow failure. And you can see at the top, most patients develop bone marrow failure within the first decade. 90% will develop it by the age of 40. Third will develop MDS or leukemia by the age of 40. A third, just under a third, was solid tumor, and 20% would develop squamous cell head and neck carcinoma head and neck or vulva. And you can see the overall mortality doesn't plateau. Is all Fanconi anemia the same? The answer is no. So in this Spanish study of 227 patients, they split patients based upon your chromosomal fragility into those who had low fragility versus high fragility. Low was in light purple, the dark purple is high fragility. And you can see that those who had low fragility had lower onset of hematologic impairment, lower incidence of having transplants, low incidence solid tumours. Then they looked at patients who had some FANC-A protein expression versus none. And none is here is in dark blue, light blue is some protein expression. Those who had some Fanconi anemia, FANC-A expression, had late onset hematological impairment, low incidence of allogeneic transplant, low incidence of MDS, and improved survival, you can see in light blue. So the fragility index and the mutation type can provide important prognostic information. So this is a case that I saw a couple of years ago of a 6-month referred by our oncology colleagues, because a child had bilateral WHIMs, had cytopenias, and we did the bone marrow aspect and had monosomy 7. As soon as we saw monosomy 7, we start thinking about inherited bone marrow failure, and we did a DEB test. It came out as Fanconi anemia. We did the genetics, had BRCA2. And this child, because we explained the prognosis, which is really poor, the parents decided to treat the child palliatively. And this looks at the cumulative incidence of malignancy. In dotted red is the BRCA2, in dark blue is non-BRCA2. You can see if you've got BRCA2, and this is in months, all children with BRCA2 will have a malignancy very early on. Often, most of them will have leukemias and other brain tumours or Wilms tumours, often within the first year or so, and it's very difficult to treat. But as I said to you, Fanconi anemia is a cancer predisposition syndrome. Most of it occurs in young adults in 20s to 30s, but they are 3.5 times now, 1,000-fold increased risk getting esophageal squamous cell carcinoma, 2,000-fold getting vulval cell carcinoma, 800-fold for head and neck squamous cell carcinoma, 300-fold for MDS leukemia, and the risk persists after transplant. So you've got to have your clinics designed to look for all of these things, and there are international guidelines to help look for all of this. So what about the natural history of Fanconi DKC, for example? So in red here, we've got DKC, green is Fanconi, blue is DBA, and purple Schwartzman-Diamond. And A is overall survival, B is cancer-free survival, and C is bone marrow failure-free survival. You can see Fanconi and DKC, so you can see they've got the worst survival. They have the highest risk of malignancy, and all patients with Fanconi will get malignancy, as you can see. And then bone marrow failure, again, you can see they do earlier and more progressive bone marrow failure, Schwartzman-Diamond DBA, less so. So the indications for transplant are progressive bone marrow failure, things like cytopenias, transfusion dependence, or clonal evolution. It does treat the bone marrow failure, and the overall survival outcomes are good, but it doesn't treat the risk of cancer in the non-hematological conditions. So long-term surveillance is essential. How do we manage them in clinics before they get to the bone marrow failure? Well, you can subdivide your patients into low risk and all the way up to high risk. If they're low risk, if they've got normal blood counts, no cytogenetic abnormalities, I do a full blood count every few months, but an annual bone marrow investigation. Those who've got mild cytopenias need more regular blood counts and bone marrows every 6 months. Once they start to get progressive cytopenias or emergent cytogenetic abnormalities, then they need blood counts every few weeks, bone marrows every 3 to 4 months. And once you start to get transfusion dependence or blast less than 10%, you really need to be heading towards transplant. And if they've got AML or high risk things like monosomy 7, etc., you need to give them chemotherapy followed by transplant. So Fanconi patients, in terms of their conditioning, as I said to you, they're extremely sensitive to alkylation and radiation. They get very high risk of toxicity to TRM with standard treatment conditioning, so they need a reduced intensity approach. So we give everybody fludarabine, but we give low dose cyclophosphamide, no more than 40 milligrams per kilo. That's to reduce the risk of toxicity such as mucositis. All our patients in the UK get alemtuzumab. They need serotherapy to reduce GVHD, and we try to avoid TBI. This is some data looking at outcomes, survival outcomes within red with fludarabine versus non-fludarabine regimens. So you can see fludarabine is actually essential to reduce conditioning with Fanconi anemia. This is an EBMT analysis of 813 patients with Fanconi anemia. And on the left, you've got survival with bone marrow failure in red versus MDS in blue. So you need to obviously your outcomes are much better with bone marrow failure. Then you've got donor type in the middle. You've got your red with matched family donor. Mud is very close by. It's not essentially similar outcomes to matched family donors, but then the bottom two are mismatched or haploidentical donors. And then the conditioning, the top one in red is flucyclone. That does much better than other conditioning regimens. We in Great Ormond Street, we do for mismatched donors, we use this regimen, which was developed by Cincinnati. So they looked at 45 patients, median age of 8, mainly 3/4 of patients with bone marrow failure. They used a flu low-dose cyclorabit ATG with targeted busulfan to lower end. They did a CD34 selected T-cell depleted graft. Most of these were either matched unrelated or mismatched unrelated. 1 year overall survival, 66%. But no severe GVHD. And the younger children under the age of 10, all those children survive with this regimen. So we use that for our haploidentical transplants. As I said to you, the transplants corrects marrow failure, but doesn't treat the underlying DNA repair. So they need long-term cancer surveillance. You need to keep an eye on their fertility. So they're often subfertile or infertile, so you need to keep an eye on their endocrinology. Then obviously you need to keep an eye on their complications of transplant. They have their alternatives. They haven't, things like blood counts. They are high risk for, as I said, squamous cell carcinoma, particularly if they get oral GVHD. And then there's all the psychosocial and transition to adult care. So it is a multidisciplinary approach. I just want to talk to you about new therapies in Fanconi, and there was this publication a couple of years ago by the Spanish group using gene therapy. The advantage of gene therapy is you don't require any cytotoxic treatment. Cytotoxic treatment is toxic. It has high risk of regimen toxicity in transplant, secondary malignancy, GVHD, etc. And not all patients have donors. So what they did is, you can see at the bottom here, it was for FANC-A, and before they got serious cytopenias, they took the stem cells, they corrected it with a FANC-A lentiviral gene transfer. They then infused it without any conditioning, and because these cells have a normal DNA repair pathway, they had survival advantage, so they could outgrow the Fanconi cells, and they engrafted. So they showed that these cells engrafted. They showed that you get hematologic improvement, reduction in chromosome breakage. And the outcomes were good after about 2 years. So this is obviously very preliminary, but does show that autologous gene therapy is an option in selected patients with Fanconi anemia, in this sense, FANC-A, which is the commonest genotype. Now, we know that L-Trompag is useful for idiopathic aplastomia, but what about for Fanconi or other inherited bone marrow failures? Well, you've got to be careful. In this study, they gave it for 8 patients. They gave it for 6 months, and they found about a third responded, but only about 12% maintained that response at a year. There was no serious toxicity, but they did need to have dose reductions because of some gut toxicity. And here's a caution: it did lead to an increase in RUNX1, so you can perhaps stimulate high-risk clones. You do need to be careful with that. You shouldn't really, I wouldn't advise giving things like L-Trompag. So the second case I want to talk to you about is another case we presented to our unit, initially presented with what we thought was ITP at the age of 2. We gave IVIG, had no response, but also had some other clinical features. They had developmental delay with retinal hemorrhages. They also, CT scan showed this intracerebral calcification. They subsequently developed bone marrow failure. We did a flow fish, and you can see here, this is looking at the different centiles, look at the length of the telomeres. In red is the less than 1 centile. You can see for all these different lineages, it was below the first centile, and an NGS panel confirmed those mutations in TIP2. Now, he had a sibling who had a normal blood count, but when you look here on the right, his flow fish, you can see the red dot there, was well below the first centile. So you couldn't use him, obviously, because he was obviously also had DKC, but wasn't showing any manifestation. So what is it? It's a disorder of your telomeres. The telomeres are the caps at the ends of your chromosomes, and they protect the chromosomal ends from DNA breaks. And in all of us, our telomeres decline with age, but in DKC, you get this accelerated telomere shortening, leading to stem cell exhaustion. But you also get bone marrow failure, organ fibrosis, both in the liver, but you also get pulmonary dysfunction. They classically present in teenagers with this reticular pigmentation, nail dystrophy, and oral leukoplakia. Inheritance is variable, but about over 50%, you often don't get a family history. So, but if you get a positive diagnosis, you've got to screen your family donors, avoid obviously at-risk sibling donors, use a reduced intensity condition and a high risk of getting pulmonary or hepatic toxicity from transplants because of the DKC. How do you treat it? Well, transplant is curative for the bone marrow failure. If you haven't got a good donor, you can consider androgens, and I'll show you some data on that. Support is really important. I had a DKC patient who we did the lymphocyte subsets, and he had profound lymphopenia, and they are at risk of getting PCP pneumonia, so they do often need PCP prophylaxis. So this is a paper from NIH where they gave 27 patients high doses of danazol. The indication criteria is you have to have a telomere length less than 1%. And you can see here's in light blue is danazol, and you can see the telomere lengths that they gave it. They managed to maintain the telomere lengths without, they projected if you didn't get the danazol, you could see here what it would have been without it. So things like androgens are an option both in Fanconi and in DKC. And in DKC, they might stabilize or elongate the telomeres. It's possible, but they have quite a few side effects: virilization, adenomas, muscle problems. So you need to be aware of that. Just to talk to you about some other type of conditioning regimens in DKC. This is a trial going. It's just finished in Boston. They didn't use any radiation, no cyclophosphamide, just gave fludarabine alemtuzumab. And the idea of alemtuzumab is that you prevent GVHD. And the idea that infusing, say, just using fludarabine alemtuzumab, so you minimize the liver and hepatic toxicity, mucosal toxicity, to reduce your TOM. So they published preliminary data, treated more patients than this, but it's 20 patients. There was unrelated or mismatch unrelated donors, and they had 95% engraftment, 90% overall survival. And so it was really very good outcomes using a very essentially minimal conditioning regimen. This is a case I saw now a few years ago of a child who's referred to me with severe neutropenia. And so on her growth chart, you see right at the very end, she was right at the bottom. So she had failure to thrive with severe neutropenia. And I asked the parents, what were her stools like? And they said, oh, it's really difficult to flush away. It's very oily. And of course, she had steatorrhea. So I checked her stool elastase, that was absent. We did the genetics, and she had bilateral SBDS mutations, so she had Schwachman-Diamond. So you need to think about this in any child who's got neutropenia and growth failure, and so you need to think about Schwachman-Diamond. So it's characterized by a pancreatic failure, and if you look at the CT here, you get this you get fatty replacement of the pancreas, you get neutropenia, infection, short stature, skeletal abnormalities, you get this flaying, as you can see on the right, the metaphyses, so you get this metaphyseal dysostosis. They often have low or absent elastase in the stool, they get cytopenias, etc. And it's at risk of both bone marrow failure and MDS. You treat it by giving them pancreatic enzyme replacement, and often that will improve both not just the growth, but often the neutropenia. And then where required, G-CSF, and then for those patients, transplants for severe marrow failure or MDS and AML. They are increased risk, Schwachman-Diamond, to go and get both MDS and AML, about 20 to 30%. You want, one of the late signs you can see is monosomy 7. So this is some data from Kiko Shimura from Boston. What they looked at was, can you predict which patients might get MDS and AML? And what they found is if you've got biallelic TP53 clones, you might be able to detect this many years before they get MDS or AML. If you get biallelic alterations in TP53, then you need to head towards transplant before they get chromosome 7 abnormalities or MDS AML, because then once they get that, the outcomes are really, really poor. Just last two cases I want to talk about. One's Diamond-Blackfan anemia. So last case I saw was a child with a few months of age who presented with they get a macrocytic anemia. They get a pure red cell plasia, so they don't have any reticulocytes, but normal neutrophils and platelets. They often have about 50% of patients at least congenital abnormalities, often like thumb abnormalities, like extra 3 phalangeals or radial abnormalities. They may all have craniofacial abnormalities, short stature. They have an elevated hemoglobin, might have a hemoglobin F or EADA. Classically, it's the bone marrow. You get this pure red cell aplasia with normal other lineages. And we did on our NGS panel, we were able to check ribosomal mutation RBS19, which is the commonest. I tend to avoid steroids in the first year, so they can grow, get their vaccinations, and then if required, give them steroids. And that works in about 60 to 80%. They might need iron chelation for for the iron overload, and in about 10% for those who don't respond to the steroids or steroid dependence and transfusion dependent, they'll need a transplant. The final cases I want to talk to you about something called SAMD9 and SAMD9 ligand. So it's autosomal dominant. It's a gain of function. It's located on chromosome 7q. And if you look on the right, they present with childhood MDS on monosomy 7. There's SAMD9, where you get what's called Mirage syndrome, growth restriction, gut problems, adrenal insufficiency. SAMD9, you get neurological problems such as ataxia. But what's so unique about this, as I mentioned to you earlier before about with Schwachman-Diamond, Fanconi, you can get monosomy 7. That's really bad news when you get it. Here, what happens here is that because it's in the chromosomal 7, you might actually get monosomy 7 or loss of 7q, and that can remove the mutant allele. The other thing that can often happen is that the wild type might duplicate that. It's called, so you get uniparental disomy of chromosome 7q. And so you can actually, the mutant allele can be replaced by the wild type copy, and you get somatic rescue here. So this is quite unique, where monosomy 7 doesn't always necessarily mean that you need to go to transplant. So we had a child who was 3 years old, had IUGR, recurrent infections. We did our bone marrow, it's hypocellular. Then we find monosomy 7, we found the SAMD9 ligand variant. And if you look here, the blood counts at top from 3 years all the way to sort of where they are now, 3 years, 2 months, 2 years later. The neutrophil count is low, but then improves. And monosomy 7, funnily enough, actually decreased. And then they got better with the clinical status. And we, at the moment, have just watched them, and they don't need to necessarily have transplant. So in this situation, you've got adapted clonal sort of somatic changes here that monosomy 7 can regress with time and spontaneously improve. So they need careful longitudinal monitoring. So in summary, just to say, with inherited bone marrow failures, you need to recognize early, diagnose accurately, and transplant carefully, because think about the patients with congenital abnormalities, family clues, etc. Could this be inherited? This affects donor selection, conditioning, cancer surveillance, family outcomes, and long-term outcomes. Not all aplastic anemia is acquired. And on that, thank you. I'll stop.
Thank you so much, Professor Samar Singh, for the excellent presentation. There is one question for you. Why does telomere shortening correlate with aging?
I'm not an aging expert, but as you can think about that, if your telomeres get shorter, it's almost considered to be a biomarker, isn't it, of how healthy you are in a way. So I think you get increased sort of senescence, increased apoptosis, etc. So that's my simple answer to that. And that's why obviously in DKC you get this accelerated turnover and apoptosis classically in your bone marrow.
Okay, the second question is, what are the ethical concerns of gene therapy?
I think from my point of view, obviously you don't know the long-term outcomes. We were a center at Great Ormond Street with that Spanish study, but one of the things that we never recruited anybody onto it because all our patients had donors, either sibling donors or unrelated donors. So we didn't go down that route because we don't have long-term outcomes. And I've showed you the outcomes with sibling and much unrelated donors with Fanconi, and they're really good. We don't know long-term. Could this make things worse? You have to also do it before the bone marrow becomes really hypocellular. You have to do it really early, so you have to identify the children, because you have to obtain the stem cells. So if you haven't got any stem cells, it's not feasible. So you have to do it normally in the first couple of years. So they're very young, and you don't know long term, they might have got bone marrow failure, if at all, later on. So if you're going to do it, you know, it's often in young children that you take their stem cells out, and so those are the ethical issues, I suppose.
Okay, thank you so much.
Thank you so much.
Professor Samara Singh.
It's a pleasure.
We
Thank
move
you.
to the, thank you so much. Now we move to the next speaker. Our next speaker is Professor Regis Bouffoudi Lahator. He's head Hematology and Bone Marrow Transplant Department, Hospital St. Louis, Paris, Director French National Reference Center for Aplastic Anemia and PNH, an internationally recognized expert in bone marrow failure and paroxysmal nocturnal hemoglobinuria, PNH. Following training at the Pasteur Institute and NIH, Professor Bouffoudi Lahator now leads France's premier Center for Rare Hematological and Immunological Disorders, and this is a recorded presentation.
Hi, everybody. I'm very pleased to present to you this talk on aplastic anemia. I'm Regis Bouffoudi-Lahator. I'm the head of the French Reference Center for Aplastic Anemia and PNH. And today I will speak about the genomic in aplastic anemia and precisely how we could make a decision between immunosuppression and transplant. So those are my disclosures. As you can see, there's many companies that are driving aplastic and PNH. And before beginning, I'd like to say some words on the disease itself. Basically, as you can see, we're discussing aplastic, which is basically at the crosstalks of inherited and acquired disorders. So it's the main aim of any single physician facing this disease is to distinguish between aplastics that are caused because of immune disorders, the acquired aplastic anemia, and on the other side, inherited disorder, which are mainly driven by genes like Fanconi anemia, dyskeratosis congenita, or Schwarzman syndrome. As you can see, all disease might evolve to MDS or ML. This is why we are following those patients very carefully at the marrow level. So basically, when you're facing a patient, even if we have now access to genetic precision, the presentation the same. It's an empty bone marrow. On the left side, you have bone marrow that is quite normal with stem cells that are populating bone marrow. And on the other side, you can see that the cells are outstandingly how the marrow there is fully empty, and the bone marrow has been replaced by adipocytes. So that's the same presentation if the patient is presenting an acquired disorder or inherited dysfunction. So what we're going to see is what we could do, not only on the gene side, but also on the clinical side, to distinguish between those two diseases and then to separate and indicate immunosuppression versus transplant. So that's basically what we're going to speak about. First of all, the diagnostic of aplastic anemia itself. As you can see, it's really something that is, I would say, common between inherited and acquired disorder. Then we'll see how to make a difference between both diseases. In other words, how to know how to distinguish patients who are presenting an acquired disorder versus those ones who are presenting an inherited disorder. Then when we should start a treatment. And finally, that's the most important, and mainly the aim of the talk, is to distinguish between immunosuppression and transplant. So the presentation I told you is exactly the same. The patient is presenting with pancytopenia. Microcytosis is very common. This is not something that makes the distinguish between inherited and acquired. Most bone marrow failure, I would say, disorders are presenting with macrocytosis. However, what we do know is that for acquired setting, the patients might present in a way, a normal lymphocyte count. And this is something that might make you think about. This is very strange. We have some pancytopenia, and on the other side, the lymphocytes are normal. So this is something that is in favor of an acquired disorder, because as you may imagine, the lymphocytes are responsible for the immune destruction of the bone marrow, justifying that they are preserved. Discussing about cytopenias, and I would say which one is beginning, most of the time thrombocytopenia is the first lineage that a acquired disorder setting got, while on the other side myelodysplastic syndrome are presenting early on with anemia. So if the patient is presenting an ITP, it may be exceptionally diagnosed afterwards with lymphocytopenia, because this is the main entry in that topic and disease. Obviously, you are doing marrow aspiration to distinguish between aplastics and MDS or EML, and there is no abnormal cells, whatever the cause, if it's inherited or acquired, and then doing the marrow biopsy, which is going to give the diagnosis showing an hypocellularity, as you can see, less than 30%. You might have some dyserythropoiesis, which is quite normal. You might have some red cells abnormalities lineage. This is not something that should worry on. And again, there is no way to distinguish inherited and acquired disorder through a bone marrow biopsy. Sometimes there are some, I would say, misleading diagnosis, because there is a mast cells infiltration or lymphoid hyperplasia, or plasma cells and macrophages in the marrow. And obviously, might make physicians think to another diagnosis. So be careful. This is quite normal, and this is totally possible with aplastic anemia. So now that you did the diagnosis of aplastic anemia, you eliminate MDS and AML, and you eliminate as well myelofibrosis by the bone marrow biopsy. Then you have a patient with an empty marrow, and what you do want to know is if it is inherited or acquired. So we are going to ask questions to the patients, and not only doing genes panel analysis. First of all, what we want to know if the patient has an acute phase or it's something that is, staying for years. So the typical presentation of an acquired immune-mediated disorder is very brutal. It's acute. The patient's got normal CBCs 2 years before and is doing very well. And at the time, the CBCs are dropping down very importantly and severely. That's really typical of an acquired aplastic anemia. On the other way around, when you have patients that have always been exposed to cytopenias, moderate ones, but you see that CBCs after CBCs, the patients was presenting abnormalities on the bone, on the CBCs, that's in favor of a inherited disorder. The other thing that you have to think about is to ask questions about the family and the personal history of the patients. Is there some growth retardation? Is there physical exam is normal? If there is, of course, retardation, it's in favor of inherited disorder. If physical exam is fine, then it's obviously something that is in favor of immune-mediated. You have to ask for family, especially hand and ankle. You have to look for other disease, possibly. Think about lung fibrosis or cirrhosis, because we know that telomeropathies might not only have a bone marrow involvement, they might have also some lung and liver dysfunction. So that's very important. And basically, when you look to this clinic, if you have a patient that is presenting an acute event without any personal medical history in a family where there is now even new, I would say, hematological disease or liver cirrhosis or lung fibrosis, then you're in favor of an immune disease. Now, looking for biology, I would say that the most important is a PNH clone. I mean, this is something that is really indicating an immune-mediated disease. As you can see here, this is very well documented. You have a normal marrow on the left, and you see that, first of all, you have a mutations. If you don't have any immune attack behind, you won't have any expansion of those cells. However, if you have an immunological attack, if you have an immune-mediated bone marrow failure, then the PNH cells will expand and will replace totally the normal marrow. Basically, what we do know is that for a reason that at the moment is not very well known, there is a selection by the immune system of the PNH cells. In other words, the immune system is going to destroy selectively the normal cells, making the PNH cells expanding and being completely alone in this empty marrow. So when you have an empty PNH clone, this is really in favor of an acquired disorder. Then obviously, you're looking for hemoglobin F or alpha-fetoprotein. You're going to do some dosage, and you're going to see that if this hemoglobin F is elevated or alpha-fetoprotein is elevated, this is clearly in favor of an inherited disorders. Dosage are difficult to do. They're not done the same on whole labs, but this is very informative to help, again, to make the difference between inherited and acquired disorder. And then we come to gene screening, because obviously he wants to know if the patients had an inherited disorder or not, especially Fanconi anemias, which is the first inherited disorder, or telomeropathies and others. So that's a study that has been published in Blood some years ago. It was done by Jean Soulier's team here in Saint Louis. And what we did is to look on patients who were referred to us because of Fanconi anemia suspicion. They have a strong predisposition for inherited disorders. So in other words, we have only families of bone marrow failures. So patients who are referred to us to eliminate the Fanconi anemia, but with strong arguments in favor of inherited disorder. And as you can see on this population, we find in 50% of the patients, 50% of the patients, we find a gene responsible of the disease. And you can see there was some hematopoiesis gene, GATA2, GATA1, RANKS1, ATV6, and so on. There's also telomeres gene, DNA damage response gene, ribosomes, obviously, SAMD9, SAMD9-HAL, that is now very well known, and other gene involved in immunity. And that was, I would say, a real very nice description of the numbers of genes that we can find in those patients. So this is a kind of summary of this first part, showing how we do the difference between acquired and inherited bone marrow failure disorders. So as you can see, the first aim is to do the diagnosis of aplastic anemia with the marrow sampling. Cytogenetic is normal, then you can eliminate AML, MDS, and you do a bone marrow biopsy to eliminate, obviously, fibrosis. And then how to discriminate between inherited and acquired. The first most important biological marker is PNH. If the patient is presenting a PNH clone more than 1%, and if the patient is adult, then basically we are considering him as an acquired immune disorder. If the patient has an aplastic anemia without PNH cells, then and is adult, then we're looking, as I told you, CBCs in the last 2 years before diagnosis. Is there any family history? What about hemoglobin F and alpha-fetoprotein? And what about physical exam? And if we have normal CBCs 2 years before, I would say, familial history without any troubles, especially in liver and lungs, and for sure in hematological side, if you have hemoglobin F and alpha-feto that is normal, and normal physical exam, then we are considering the patients to have a acquired bone marrow failure disorder. On the other side, for pediatric patients, then we are always doing an FA breakage test, because this is something very easy to do, very quick, that make the diagnostics of Fanconi anemia. But we are using a panel with all the genes. There's almost 180 genes that we are checking in those patients, because in the pediatric patients with bone marrow failure, the, I would say, statistical chance to have a gene responsible for what is going on is very high. So now there's a third part, very quick. When should we treat? Well, I would say if you have a severe or very severe aplastic anemia according to Kamita criteria, as you can see, 2 out of 3 of the counts that we are seeing, less than 500 neutrophiles, 20 per giga per liter platelets, so 20 giga per liter reticulocytes, then you need the treatment. Severe, very severe, you need the treatment. And on the other side, if you have a patient that has a moderate aplastic anemia, then we're looking for transfusion. If the patients need transfusion, it means that it's not, I would say, independent in terms of hematopoiesis support, then we're going to treat. If the patient does not need transfusions, then it means that it can continue to be just follow-up. So as you can see, there is 2 main messages here. First of all, we are not treating everybody. If a patient is doing well, is not transfused, is not infected, then we are doing the follow-up, I would say 4 times per year at the beginning with a CBC every 3 months, and we see how it's going on. And if the patient is stable, we're not doing more. If the patient's severity is increasing, then we are treating. First message. Second message is, as you can see, the type of treatment, immunosuppression or transplant, is not related to the severity of the disease. You might have some patients with moderate aplastic anemia who are going to be transfused once with a sibling donor and being transplanted. And on the other side, very severe aplastic anemia in a patient that don't have any siblings in the family or is old, I would say more than 40 years of age, because you know that in aplastic world, old age is quite young in the end. And then, of course, these patients will receive immunosuppression. So very severe and severe aplastic anemia or moderate transfused aplastic anemia. So let's now come to clinic and how deal between immunosuppression and transplantation with what I told you. So first of all, if there is any gene that has been identified, if it's an inherited disorder, obviously we're going to give transplant, but never immunosuppression. Immunosuppression has never been useful in the story of a inherited disorder. So this is a story of a 16-year-old male. As you can see, he has a severe aplastic anemia because the reticulocytes are more than 60,000, platelets more than 20,000. So I should have precise, now reticulocytes for severity is about 60 giga per liter, while before it was 20 giga per liter when we are looking at on a microscope. Now that there is no microscope anymore, we are considering the number of 60. As you can see, cytogenetic is normal, and there is an hypocellular bone marrow cellularity showing that it's a bone marrow failure. And it's an acquired one because we had some CBCs 10 years before, which was normal. There's no family history, normal physical exam, and there is a PNH clone. So we are in front of an acquired immune-mediated bone marrow failure disorder. These patients had a sibling, HLA match available donor. So what we're going to do, we're going to offer to him as quick as possible transplantation. We're going to use a conditioning regimen with cyclophosphamide, 200 milligram per key, and ATG, around 7.5 to 12.5 milligram per key, thymoglobulin. There is some variation according to countries and centers. This GVHD prophylaxis is definitely cyclosporin plus methotrexate. We have a phase 3 randomized trial for that. And the source of stem cell will be marrow to avoid graft-versus-host disease. Is a patient a sibling donor, is a severe, very severe aplastic anemia, or a moderate aplastic anemia, but he's transfused, then he has to be transplanted as quick as possible using marrow and this conditioning regimen. As you can see here, the results are outstanding. There is about 90% overall survival. And on the right side, you see that the late complications are very few. And basically in this group of patients, the 61 patients had no, I would say, higher rates of complications rather than an healthy control population. There was just one control complications that was higher. It was osteonecrosis because of the use of cyclosporin, steroids, and so on. As I told you, in aplastic anemia, age has a different mean. You see that patients' age is very important, and you see that after 40 years of age, the morbidity and the mortality from transplant is very high. This is the reason why we are usually using this age cut limit to proceed to sibling transplantation or to immunosuppression. If you have less than 40 years of age and a sibling donors, then we go for transplant. If you have more than 40 years of age, if you don't have any sibling donor, usually we go for immunosuppression. However, this is the same patient, no sibling, and a good probability of 10 out of 10 donor, and then there is a discussion if this patient should be transplanted first line. This is a, I would say, discussable point. There is some different opinions, even among experts. There is different opinion because, as you may imagine, transplant is curing the patient, but it might kill the patients. And everything came from that study, a UK study, I am sure you saw just before me, from Sujet Samaras, who published some years ago, it was a long time ago, about 10 years ago, those wonderful results of patients who were refractory to a first course of immunosuppression and who received a much unrelated donor transplantation. As you can see, there was a very high 95% failure-free survival. So that's the reason why they decided, the UK group, to proceed to first-line transplantation, and they reported on 29 patients a very good overall survival rates. However, we got one graft failure, one patient who had chronic GVHD, and one death of IPS. And that was patients who were transplanted with campus-based regimen and patients who were whole pediatric. And from that study, everybody was discussing the pros and cons of doing first-line match unrelated transplantation in patients with bone marrow failure, needing a treatment, and having good probabilities of 10 out of 10. As you can see, it can be curative, you're curing the patients, lower toxicity in young patients. However, obviously not everybody has a donor, and there is still few studies, not prospective, and there is an anti-based conditioning regimen. So that's the reason why we are still proceeding the way, looking for a match unrelated donor in this pediatric population. If there is a very good probability, we can go for transplant because we don't want to let the patients too long in cytopenias, and we don't want the patients eventually not being transplanted. So if there's a very good probability of match unrelated donor, we might go for transplant. If not, we are proceeding to immunosuppression and then transplanted in a second way. Let's now think about that patient. He has no siblings, no match unrelated donor, then there is absolutely no doubt you should go for immunosuppression. This immunosuppression was also ATG plus cyclosporine for decades. As you can see here, we tried to change drugs to higher dose, to combine different drugs. It was always a failure. We tried to increase immunosuppression by adding MMF or sirolimus at the top of both ATG plus cyclosporine. That was also a failure to improve the response rate or the long-term remission. And in Europe, we ran a randomized phase 3 trial who was adding GCSF at the top of both ATG plus cyclosporine, but again, was a failure. Then we came to that paper. It was basically following up from the NIH paper, who showed very interesting results using a trombopag, a TPO receptor agonist, first line at the top of ATG plus cyclosporine. And what we did is to randomize 1-to-1, as you can see, 101 patients, the standard treatment, also ATG 40 mg per kg for 4 days plus cyclosporine, and then standard and the experimental 96 patients at the platform. We added a trombopag 150 milligram per day for 3 to 6 months. There was a randomization 1-to-1. There was only severe or very severe patients. There was a stratification based on this disease severity on age and on center. The primary endpoint was the complete remission at 3 months, and we included almost 200 patients. So in terms of criteria for response, we considered complete remission for patients being more than 10 grams per deciliter hemoglobin level, more than 1 gigapoliter neutrophils, more than 100 gigapoliter platelets. And for patients who were, I would say, partial responders, they had to be transfusion independent, which is different from our US colleagues who might have some improvement in terms of severity of criteria of severe aplastic anemia and classifying partial response while patients are still transfused. Obviously, clonal evolution, standard definition, and the primary endpoint was to increase the complete remission from 7% to 21% in the experimental arm. Here is represented the 26 center on a 2 years follow-up, July 2015 to April 2019, and we included 205 patients naive to any treatment with severe or very severe aplastic anemia. This is a flow chart. You can see that there was some failure. First of all, there was also some misleading inclusion patients with moderate aplastics or MDS and AML. But at the end, we randomized 96 patients versus 101 patients. This is the overall, I would say, description of those patients, very equilibrated, very standard. Patients with severe and very severe, stratified according age, according severity. And as you can see here, this is a primary endpoint who was reached. We were able to significantly increase the rates of complete response at 3 months from basically 10%, 9.9 to 22%, 21.9. That was significant, and there was a 3 higher chance of response using electronopag. That was also turning to an advantage at 6 months with an overall response in that study of almost 45% standard arm versus 72% experimental arm. And if now we classify with the US colleagues, as I told you, classification, meaning complete remission, we all agreed, but partial remission patients are not obliged to be transfusion independent. They are just not following severe aplastic anemia criteria. You see that we have exactly the same results at NIH paper, 66% response rate at 6 months for patients who received a standard treatment versus 80% for patients who are treated with a thrombopag. So safety was outstanding, exactly the same as the standard arm, and the clonal evolution 2 in both arms, showing that this treatment was safe. We even look for mutations, and again, very equilibrated. There was the same number, same percentage, same type of mutations, baseline, 3 months, 6 months, and 24 months. The overall survival was the same, and the fatal case are shown here. So that's the reason why at the moment, if the patient is needed for immunosuppression, the standard treatment is ATG plus cyclosporine plus electronopag. If the patient is refractory at 6 months to this treatment, what should I do? First of all, you have to see if you did not mislead a diagnosis. So in other words, perhaps you missed a inherited disorder. So come back to the asking questions to the patients, come back to your clinical exam, come back to the gene panel to see if you did not miss an inherited disorder. The other things, as I told you, this population is exposed to clonal evolution, so it could be also a transformation in AML and MDS. What should I do? There is no good options. There is no good solutions. You will transplant young patients, obviously, until the age of 30 with anything, APLO, mismatch, because the toxicity of transplant is very less at that age. But then for the other patients, you have to think twice before going to transplant. This study has been done more than 10 years ago, before electronopag was available. You can see that the overall survival of patients who were refractory to immunosuppression using only transfusion and antibiotics was amazing. So sometimes in aplastic anemia, not doing nothing is not so bad. So as a conclusion, I would say we see how to make the difference, first of all, of aplastic anemia, then to differentiate between acquired and inherited disorder. Then we see what is in favor of an acquired with something that is quite brutal, acute, no family dysfunction, no personal history. And then we see what we are calling as I would say inherited with the panel gene and all the genes that we see. We show when we should treat, and then I guess the aim of the talk was to discriminate between immunosuppression and transplantation. And with that, I'd like to obviously thank very much all the people who are working with me at the national level or the international level. This is a great pleasure to collaborate with all those people. And I hope you enjoyed the talk. You can definitely send to me some questions. You will have my email easily by the organization. Thank you very much for your attention. Bye-bye.
Thank you so much, Professor Latour, for the excellent presentation. And we move now to next speaker. Our next speaker is Professor Antonio Piga, Professor of Pediatrics, University of Turin, Italy, renowned for establishing reference center for hemoglobinopathies in Piemonte, Italy. Professor Piga is a world authority on thalassemia, sickle cell disease, and iron metabolism. His research has been instrumental in advancing non-invasive iron quantification and the development of novel chelation therapy. Welcome, Professor Piga.
Thank you very much for your kind invitation and your kind introduction. So I will move directly to the presentation. Let me share my screen. Okay. So, how to cover this important topic, conflict of interest disclosure. And then I start with this simplified distribution, global distribution of thalassemia in the world, to say that this is the traditional distribution that all of us have in mind, but this distribution is changing. And the main factor for this is migration, because the migration trend is high and is rising up. And what is important is that the growth in international migration is rising a lot, and with putting a lot of very important challenges to the global humanity. But even if we look with the very at this problem with the very narrow angle of view that is thalassemia, most of the country of origin of the top migration we have and we will have is coming from countries where the prevalence of thalassemia is relatively high or very high. So the thalassemia as a problem is growing up worldwide, let's say, putting a lot of challenges also for the diagnosis. So for the diagnosis where we are, even if we go to the basic hematology, basic pediatrics, starting from clinical case with anemia or a couple to be screened for risk or not risk for this disease. And even if we look at the site with very poor resources, so looking just at the blood routine with some hemoglobin electrophoresis, the orientation of thalassemia for most of the thalassemia forms is very easy. Looking at the microcytic red blood cell, looking at the level of hemoglobin A2, high for beta and low as a trend for alpha thalassemia, but this is not enough. So going on. And even when the suspected cases are tested by DNA testing with the, let's say, old-fashioned tests that are like PCR, looking at the common variants in a country or in a site, this is not enough. Luckily, there is, unluckily, obviously for the genes involved in thalassemia are more than one. and the defects that has been associated with thalassemia are hundreds, more than 1,000. And so there is a need to go to more advanced DNA, and luckily there has been and there is a strong development of that technology in genes sequencing, that from, let's say, short read sequencing to long read sequencing, that are able to grab also deletion, large deletion, or complex alteration of the DNA in that region. And a very recent survey that has been done in centers worldwide that deals with this disease, with thalassemia, have quantified that there is a trend, an important trend of improvement in applying molecular methods for the diagnosis in hemoglobinopathy. So this part of the problem is improving. But even having perfect genotyping for each subject, that is not enough, as is exemplified by this very old example where you see 4 siblings. 3 of them do have exactly the same genotype, that is a form of thalassemia due to a combination of a beta tal mutation and the hemoglobin E, but you can appreciate from the picture that the phenotype of the 3 affected siblings is different or very different. So thalassemia is a monogenic disease? Basically, yes, but there are so many genetic factors and acquired factors that may influence deeply the genotype that having the specific genotype is not enough. So for right management, it's important to have obviously an accurate diagnosis with the phenotype to some follow-up. Also, if possible, to predict the severity and to set the optimal care where is possible. Obviously, in the daily routine, we try to simplify and we try to categorize the severity of thalassemias, looking at obviously the total hemoglobin, that is the degree of anemia, and having so thalassemia major for the most severe one, and thalassemia intermedia for something that is in the middle between very severe and asymptomatic carrier. But, and this is good, very recently, other 2 terms are generally used a lot, that is non-transfusion dependent thalassemia and transfusion-dependent thalassemia, that are, this definition is, I don't like so much because it's very clear, but it may confuse instead of helping. Also for clinical trials, and we have to categorize and to consider for inclusion-exclusion criteria non-transfusion dependent or transfusion dependent. That is right from a certain point of view, but in example for very important clinical trial, internationally led, we do have a patient in different countries that do have exactly the same genotype and phenotype, and in a country are categorized as transfusion dependent because the blood is safe and available, and in another country they are categorized as non-transfusion dependent because they can survive without transfusion. So, but I will not enter the topic because it will be covered very well soon after my talk. So, management. Where we are for management. Basically, I normally use for treatment option this again simplified scheme of erythropoiesis. And so management, its basic is to go to the anemia and to compensate the anemia, so to have transfusion and to have iron chelation. And for transfusion, obviously the optimal today is to have the blood at the best that is available, yes, but from 100% voluntary donation, safe from many points of view, starting from the infection and high quality, and then to set these for transfusion and to transfuse in patient like thalassemia with the best typing that is an extended phenotyping or genotyping ideally, and to use fresh blood that is ideally less than 7 days from donation, that in transfusion-dependent subject, any disease on long term is a very important point, very different from transfusion in general medicine, and then to use adequate preparation, that is, the translation is filtered, obviously, and an appropriate scheme that, again, to simplify, in severe form of thalassemia, is to use a mean pre-transfusion hemoglobin more than 9.5, and to keep this mean very regular, that is to have a narrow variation from each transfusional event. What is the limiting point? This one, that is, if we look at the globally at the blood donation for the population, having in mind that this is the threshold, the ideal threshold to cover the need for any population, we see that just a few countries, and not the countries that overlap the global distribution of thalassemia, a few countries do have this level of donation. Most of the countries with most of the thalassemia have a lower level of donation, and the trend of donation has some mild improvement globally, but not important as for the needs. That is very important for thalassemia. And then there is iron chelation, obviously, and we can say that globally there are 3 drugs that are approved and today well known: the ferroxamine, the ferriprone, and the ferazirox, that may be used as monotherapy and or to be combined to have more effectiveness. These the iron overload treatment requires strict specific monitoring, looking at the level of the iron load in organs like the liver and the heart, and possibly in other organs. And but the most important point to be underlined is that the clinical complication of thalassemia, most of the clinical complication of thalassemia that are the iron-related complication, are partially or totally irreversible. So we need to prevent these complications, not when they are clinical, but in the preclinical or very early phase. But it's very difficult to deal. Here is just an example, obviously from my center, saying, okay, adult patient with the severe form of thalassemia, ever on regular transfusion and ever on regular iron chelation, with the excellent result in terms of prevention of any complication. This is just an example because I am the speaker now and I can tell that, but in my experience, even when the resources are fully available, it's very difficult to achieve this type of result for many reasons. And so for iron chelation, the problem is that even the most recent and high-level guidelines are not covering fully the need for preventing the iron-related complications. So because we should rethink iron chelation in terms of prioritize the iron toxicity and not the iron overload, to start iron chelation earlier than suggested by the guidelines, to chelate daily. That is very easy to be prescribed and told to the patient, but very difficult to be achieved. So compliance is a main issues in most of the countries in the world, and then many other technical aspects. I don't have the time of entering in these details in this very general presentation. Again, the most important limiting factor is the coverage of the needs that is very low. This is my personal estimation based on my experience and traveling in many countries of the world for thalassemia, that is for caring, the coverage is less than 20% for blood, for iron chelation, and for expert monitoring. Then what's about the cure? Today we do have ways to cure this disease, and using the cartoon, we should go to the opposite side of erythropoiesis, so to go to the genetic defects, and then obviously since many years now we have the hematopoietic stem cell transplantation that may cure effectively a severe form of thalassemia. Obviously, the chances to do these are relatively high in children having the availability of a matched sibling, 100% matched sibling. And there are a limitation that are the opposite, that is the need to search for an unrelated donors or to use different approach to transplantation, and the risk-benefit ratio in adult patient is challenging, and then obviously the limitation due to chemotherapy and the other risks that are related to the procedure, even at the best. But again, the limiting factor is the activity of stem cell transplantation in the world. This is the last update that has been published and is available. We are waiting for the new one to see again the global distribution of the activity, having in mind that more than 50 is the magic number to fully cover the need for 10 million population. And you see again that the distribution of thalassemia is very far from this color global map. And then obviously we do have gene therapy. Gene therapy, again, I will not enter in details of gene therapy by gene addition using a viral vector to insert the normal gene, or by gene editing using at the moment the CRISPR-Cas9 approach, but with many other potential approach. But today we do have these, at least two approaches. One for gene addition is approved and available in US, in example, and by gene editing, there are today several countries in the world where this approach, the first one to be effective, fully effective, exa-cel, has been approved and so available. Obviously, there is a very strong evolution in research and clinical application to improve the gene editing approach from many different points of view. From my simple mind clinician point of view, the best and the ideal will be the gene editing in vivo. that will solve most of the problems and the limitation that today we have with this approach. Obviously, we need a while to have the practical application of gene editing in vivo. Well, here we are, cure. We do have a cure for thalassemia, but again, if you look at the coverage for stem cell transplantation, we have something like less than 10% of the patient needed it that may have a stem cell transplantation. Even if at this point that is stem cell transplantation availability in several countries where thalassemia is a very important problem, are improving. For gene therapy, obviously, we are less than 1% today, but we hope to have a fast change of these, obviously looking not just at the technological evolution, but also the way to reduce the cost of this approach. Well, there is something else. Yes, we do have something in the middle that is conservative treatment, transfusion and iron chelation, and curing or try to cure by transplant or gene therapy. We do have today at least two so-called disease-modifying approaches to thalassemia that are approved and used in some countries for a part of patients. The first has been luspatercept, that deal with the ineffective erythropoiesis because it's a synthetic form that act as a ligand trap. It may trap injected subcutaneous every 3 weeks, may trap most of the excess of ligands that are typical of ineffective erythropoiesis for thalassemia and a few other hematological diseases. And that has been approved and used and is able to modify the disease in terms of modifying of, on the average, 1.5 grams the total hemoglobin that is in a genetic chronic anemia is a very important point, or to lower significantly in a very variable way in different patients the transfusional burden. And these are the countries that do have available the luspatercept now. Again, is not the most important distribution of thalassemia worldwide, again, obviously. And this treatment is expensive, not so expensive as gene therapy, but in relative terms is even more expensive because it's not curing, it's just modifying significantly the disease. And then we do have a second approach that has been approved and today may be used in some countries, that is mitapivat, that is dealing with the red blood cell metabolism, and mitapivat is an activator of the specific red blood cell form of pyruvate kinases, and it's able to generate, let's say, ATP and even if in thalassemia there is no specific deficiency of this enzyme, it's to rise its activity is giving results that are really interesting. So strong clinical trials demonstrate that it may change in the same way, similar to luspatercept, to rise the total hemoglobin in non-transfusion dependent patients and to lower the transfusional burden in transfusion dependent patients. And these are the countries that do have approved mitapivat today. Again, not the most important countries for thalassemia. And again, the cost of this treatment, it's an oral drug to be taken every day. The cost of this treatment is relatively high or very high, depending on the point of view. And finally, in my talk, I have to mention two other drugs. One is hydroxyurea, that is very differently from sickle cell disease, is not used so much because it's working just in a few set of specific genotypes of thalassemia. Otherwise, hydroxyurea is poorly effective in thalassemia. The second and most recent used drug in thalassemia is thalidomide. That is very different because for thalidomide, you know better than me that thalidomide is an old drug that has been developed in the 50s as an effective hypnotic, used also during pregnancy, and after a few years has been banned worldwide due to the severe teratogenicity, and left for many years, and only recently has been reconsidered, and today has a full indication, at least in two conditions like multiple myeloma and leprosis, and many off-label indication. Why this? Because today in the controlled setting is easy to prevent the use during a pregnancy, and it may use his specific activity bound to the mechanism of action that is, let's say, a molecular glue degrader. What is, why it's working in thalassemia, we don't know at all. There are a few studies entered the topic, but we don't know. We know that the effect in thalassemia are very similar, if not better, to the ones that I mentioned for luspatercept and mitapivat. An important rise in the total hemoglobin, not so important rise in the fetal hemoglobin, but this is not important, obviously, or not so important from many points of view. And so where thalidomide is used, this is just an example of a recent study. Thalidomide is used widely in countries that do have a lot of load of severe form of thalassemia, and where the blood donation has a level that is incompatible with using importantly and with the transfusion-dependent patient. This is the point. So here we are. This is the treatment option for thalassemia, that is conventional treatment, curing, and disease modifying approach. And if we look at the unmet needs, obviously we are even today desperate because globally we have a coverage that is very low. It is very low also for prevention. Let's say the same, and so for the future, the translational medicine will be an answer, and this is an answer because it's giving a lot of answers, but in specific countries for specific patients, not for all, that is. And the cost, I'm sure that the cost of new approaches will lower, not so fast as ideal at the moment, but let's see. And but the access, the way to improve the access and reduce the inequity is the problem also for thalassemia. Thank you for your attention.
Thank you so much, Professor Piga, for the excellent presentation. I don't see any questions for you. No, let me see, wait. Do all patients achieve total? Okay, there's one question for you, Professor Piga. Do all patients achieve total transfusion independence after undergoing gene editing therapy?
Yes and no. It seems yes in the most recent data, in the most recent approach. And I guess that the next speaker will answer better than me to this. There are many other approaches of gene editing in other parts of the world that are used today, that are interesting, mainly in China, but also in other countries. What is the difference with, let's say, stem cell transplantation is that the degree by which the ineffective erythropoiesis and the iron metabolism are affected is different. In gene therapy, in stem cell transplantation, if you have a successful stem cell transplantation, you solve also totally ineffective erythropoiesis and iron metabolism. With gene therapy, even with a successful gene therapy, you don't fully achieve this point. At least the trend is this. But so for long-term result, this is a question mark that is very important, but it will be covered next by studies that are running today on this.
Okay, thank you so much, Professor Piga. We move to the next speaker. Our next speaker is Dr. Farooq Shah, consultant hematologist for Burj Medical City, Abu Dhabi, adjunct associate professor, Khalifa University, an internationally acclaimed authority in hemoglobinopathies and benign hematological disorders. Dr. Shah previously served as medical director for transfusion at NHS Blood and Transplant UK and led the hemoglobinopathy service at Whittington Hospital in Essex for nearly 2 decades. She now bridges clinical excellence and academic leadership in the UAE. Welcome, Dr. Shah.
Hello, everybody. My name is Dr. Farooq Shah. I'm a hematology consultant working at Burj Medical City, and I want to thank the organizers for inviting me to present on non-transfusion dependent thalassemia and to talk about key management challenges in this population of patients. These are my disclosures. There are really significant challenges in patients with non-transfusion dependent thalassemia patients. And I think the main challenge is about how we speak to families when a new child with non-transfusion dependent thalassemia is actually born. We often give them reassurance. We tell them not to worry. We say that, you know, your child's not going to need regular blood transfusions. There are clearly no obvious interventions initially. And unfortunately, before recent years, we used to just mainly ignore quite a lot of symptoms related to anemia because the patients were not on regular transfusions. And the mainstay of care was just to reassure patients that this was just part of the anemia. Quality of life is often much worse for thalassemia intermediate patients. And we know now from registry data and a lot of work done by the icons in the field, Dr. Khalid Musallam and Professor Alan Tahir, Dr. Nico Cappellini, Dr. Victor Praxit, that these patients develop significant age-related complications as time goes by. The optimal care study is a study that many patients from the Middle East were involved in. And what you can see is that as time goes by, patients are developing significant worsening quite often of their anemia, and older patients often have more significant anemia than younger patients. And also with the serum ferritin, we see that the serum ferritin increases as patients age with non-transfusion dependent thalassemia. The same optimal care study actually showed very, very clearly that patients, as they aged, got significant complications because of living with significant anemia. And you can see that the incidence of almost all complications increased in the older cohort of patients, particularly extramedullary hematopoiesis, leg ulcers, thrombotic complications, issues with gallstones, issues with osteoporosis. All of these complications were much more prevalent in the older population. There has been quite a bit of work done by Professor Musallam and Dr. Ali Tahir, really focusing on the relationship between anemia and iron overload and how this impacts on survival. And in particular, the International Health Repository data, which is a registry including patients from the US, Europe, Asia, and the MENA region, showed very clearly that if you had a good hemoglobin, so the green bar, a hemoglobin of above 10 and a well-controlled serum ferritin, your survival probability was very good. But if you were more anemic and either more anemic or you had a higher ferritin, the yellow bar, you were likely to have a poorer survival probability. And the worst cohort was the group that had both significant anemia and a significant increase in iron overload. When we look at this data set, I think what's really important to bear in mind is that the hemoglobin was not that bad. The mean hemoglobin in these patients was 9.2 grams per deciliter. And 339 patients had a hemoglobin which was just under 10 grams per deciliter. So the DELIGHT study has looked at lifetime anemia and iron control, and they've actually calculated a lifetime hemoglobin level, lifetime serum ferritin level score, a LACI score, and patients with non-transfusion dependent thalassemia who have got a optimal LACI score, so that's the green bars you can see here, they're likely to do better than those with suboptimal LACI scores. But interestingly, when you look at the thalassemia major patients, their prognosis and survival is looking way better than the non-transfusion dependent thalassemia patients. And the NTDT patients are mainly developing complications as a consequence of significant anemia. And here is the exact two same graphs, but just slightly more highlighted. And you can see that the probability and survival in thalassemia major patients, whether they've got a good or a poor LACI score, is actually really very good. I mean, the poor ones are mainly due to iron overload. But if you look at the non-transfusion dependent thalassemia patients, you can see that even those with optimal LACI scores have got a worsening survival in comparison to the TDT patients. And I think this is incredibly compelling data that tells us that having significantly anemic patients with non-transfusion dependent thalassemia is a major issue and will impact on lifetime survival clinical outcomes. So the complications that we know are linked directly to the anemia are, of course, extramedullary hematopoiesis and hepatosplenomegaly, which are associated with that, the presence of leg ulcers, the development of heart failure, osteoporosis, gallstones, the increased thrombotic risk in patients, and delayed puberty. And complications related directly as a consequence of iron are the development of endocrinopathies, abnormal liver function tests, and the development of cardiac complications. So how are we going to manage anemia? I'm not going to talk about the novel therapeutics, although I will mention them at the end, but I'm really going to focus on the evidence for maintaining a good hemoglobin and how we can try and do that. What we know is that chronic anemia is independently associated with a poorer quality of life and a poorer morbidity-free survival. And you can see this very clearly in both of these graphs. There is simple cutoff of a hemoglobin of above 10 versus a hemoglobin of less than 10 is associated with a significant reduction in morbidity-free survival in the non-transfusion dependent patients. This is one of my patients who is a non-transfusion dependent thalassemia patient. And this was a CT scan taken of her when she was in her 30s. And you can actually see really very significant extramedullary hematopoiesis. You can also see a extramedullary hemopoietic mass hair. And I will talk a little bit about her and extramedullary hematopoiesis a little bit later. So I think the impact of anemia has been proven to be a really serious issue in the non-transfusion dependent patients. And I think that the rules have changed. We have to, unless the disease is very mild, or there are major concerns about safety or availability of blood, we should be offering blood transfusion, particularly in high resource settings, for patients who have significant anemia. And the burden of proof, I think, is very much now on not withholding transfusion in these patients. And one of the reasons for that is the risk of alloimmunization is much less if you intervene earlier with blood transfusion. So what we should be offering to patients is we should definitely be offering them transfusion whenever there is a clear complication. So this is already standard of care. So if they've got evidence of extramedullary hemoptysis, leg ulcers, evidence of delayed puberty, obviously cardiac failure, or they've got poor performance score for any reason, or any evidence of failure to thrive. Intervention early is better than later because there are higher risks of alloimmunization in patients if transfusions are started later in life. So this is one of my thalassemia patients from the UK. She's Evita Thal. She presented to us aged 15. She had severe anemia with a hemoglobin of about 4.5 and had intermittently received transfusions in her home country. And she presented to the local hospital with jaundice. She didn't have any thalassemic facies, but was actually very small in both height and weight. Her mother had declined transfusions, and she'd basically said, there's lots of Evita in my family, and we don't need to do any blood transfusions. And this is her family tree for our patient. This is our patient. She's got Evita Thal. She doesn't have any alpha thalassemia deletions. Her brother does. And you can see very clearly that the peripheral blood film and the clinical behavior in the brother is very different to this patient's blood film and clinical behavior. So she eventually presents to us at the age of 15 in 2009 with a 5 centimeter liver, 12 centimeter spleen below the costal margin. Mother again declines transfusions, but the patient's got a hemoglobin that's running between 5.1 and 4.5. And we do get mum to agree to a trial of hydroxyurea, which she agrees to for a period of around about 9 months. And she also starts iron chelation because her iron burden is actually really very heavy. And what you can see is that, this is a 15-year-old girl with transfusions roughly every 3 months or so. And she's got a liver iron of 35 milligrams per gram dry weight when we initiate iron chelation for her. She starts hydroxyurea and does very well with hydroxyurea. And you can see that her hemoglobin goes up from about 4.5 just prior to initiation to around about 7. But she remains at Tanner stage 1 at the age of 15 and very, very pre-pubertal looking. From an iron perspective, over the next 2 years or so, our patient does really very well. Her ferritin comes down, her liver iron comes down very nicely. And this is despite her eventually going on to regular blood transfusions. We eventually get the mum to agree to regular blood transfusions, and this is mainly driven by the fact that her daughter insists on starting regular transfusions because she's feeling really bad and she's pretty fed up of looking like a 10-year-old in a group of friends who are all now physically developed. And what you can see here for her is a very dramatic improvement in both her height, her weight. She's mid-parental height now. She's actually significantly above the mid-parental height. And her BMI also improves significantly. She completes puberty on regular blood transfusions at the age of 18. We ask her if she wants to switch to hydroxyurea, and she declines, and she decides to continue with regular blood transfusions. And she's doing extremely well with regular blood transfusions and leading a very good quality of life. So today, what can we offer a similar child in this situation? The problem is that there's very limited choices. The only option really for children with delayed puberty with non-transfusion dependent thalassemia is to go in with blood transfusions. Newer agents are currently not licensed in children, and at best they produce a 1 to 2 gram rise in the hemoglobin on average. And currently there's no evidence that they would improve growth, as studies have simply not been done in this particular population. So even today, with the availability of luspatercept and mitapivat becoming available, we would still continue and recommend regular blood transfusion. So we're going to go back to my other patient with the extramedullary hematopoiesis. Now, this can develop at any age in both TDT and NTDT, and it is primarily driven by the anemia and hypoxia. And generally, the patients with TDT who are at risk are the ones who are on low-intensity transfusion regimes. And it can take just a few months of low hemoglobin in patients who are already on high-intensity regimes to develop significant extramedullary masses. Now, your warning signs are any new symptoms of bone pain, a new fracture, changes in facial structure, any symptoms of the compression of a nerve or a blood vessel. And my patient actually presented with a very bad cough. And when her CT scan was done, they actually thought that she had a lung carcinoma. But thankfully, she came and spoke to us, and we confirmed this was extramedullary hematopoiesis. She had a dramatic improvement with just initiation of blood transfusion, and in fact did very well on regular blood transfusion. So what you should do with extramedullary hematopoiesis is initiate or intensify the transfusion schedule depending on what type of transfusion regime your patient's receiving. You should be aiming for a post-transfusion hemoglobin of around about 13 and a pre-transfusion hemoglobin, which should really be no lower than 9.5 to 10. You should be looking to see whether you're doing adequate suppression of the erythropoietic drive, and you can do that by checking the erythropoietin levels to see that they're falling, checking the soluble transferrin receptors, and obviously tracking the reticulocyte count. Other supportive measures include the use of hydroxyurea, which I do feel that the majority of patients should be offered, and you should consider for sure radiotherapy, but these are selected patients, mainly those with cord compression or compression of a critical structure, such as in my patient, her bronchi were being compressed. So alloimmunization is, of course, a major concern in patients with non-transfusion dependent thalassemia. The frequency varies between 4 and 37%, and the age at first transfusion is a very important indicator in this population. There is also, of course, the heterogeneity between the donor and the recipient population and the extent of antigen matching, because in many centers, patients are only matched for the ABO blood group and RHD, and also the splenectomy status does affect the rate of alloimmunization. Patients who develop alloimmunization can also develop autoimmune red cell destruction. So this is a really important thing to bear in mind when you're considering initiation of transfusion programs. From an antigen matching point of view, everyone should be matched for the full Rh phenotype and KEL, and also should be matched for high frequency antigens depending on which country and which region. But clearly this is limited and restricted by resources and inventory. So if you're going to make a decision to start transfusion, ideally you should start before the age of 1, where the risk of alloimmunization is much lower. It's around 7%. The older a person is before starting transfusion, the bigger the risk of alloimmunization. And patients who start transfusions after the age of 3 have got a very high risk of developing alloimmunization. So I'm going to talk a little bit about serious complication that patients with non-transfusion dependent thalassemia may develop if they're transfused. And this is something that can just happen. It's not predictable. So this is a 36-year-old patient with non-transfusion dependent thalassemia. He'd only ever been transfused once in Egypt. And he told us that his when he's well, hemoglobin tends to run between 9 and 10. He presented to our hospital in Abu Dhabi with worsening fatigue, pain in his back and renal area, and a couple of weeks of just being non-specifically unwell. And when he presented, he had a hemoglobin of 6.6 grams per deciliter. And because of his symptoms, I decided to give him 2 units of blood. And we did a full RH and KEL match. We found that he had an anti-little c, and I initiated a workup to assess the severity of his underlying thalassemia and to sort of develop a long-term management plan. In the meantime, I did start him off on folic acid and hydroxyurea. So the workup in December showed that he did have a spleen of 18 centimeters with some hepatomegaly, and there were features suggestive of pulmonary hypertension, but that was based on an echo done with his hemoglobin at about 6.6. So the plan was to transfuse him and then consider a right heart catheter, but you can see that he's got significant extramedullary hematopoiesis. So my plan was to talk to him about going on to a regular transfusion program. So post-transfusion, his hemoglobin goes up to 7.8, but then he presents 2 days later with loin pain, complaining of hematuria, and he's sent to the emergency department. They do a CT-KUB. They say that he's got a ruptured renal cyst. He has a urology review, and then he's sent home. In the emergency department, his hemoglobin is 7.5, and he's got a creatinine of 148 from a baseline of 55. He then comes to clinic 4 days later after the transfusion. His hemoglobin's dropped further, but at that time we're thinking maybe he's just bleeding a lot from the renal cyst, and he's still complaining of hematuria. His creatinine's improved. At the time, his urine analysis actually only shows between 3 and 5 red cells per high power field. He then presents to clinic a week later in early January, and he walks in feeling terrible. His hemoglobin at the time is 4.8. So I admit him directly from the clinic for urgent assessment and blood transfusion. And at that time, we find that his Coombs test is weakly positive, but he's got a pan-agglutinin, and we can't match red blood cells for him. He's still got hematuria, and this sets off alarm bells. And I start thinking maybe this is hyperhemolysis. So we then send urgently for genotyping. We start the patient on pulsed methylprednisolone. He gets given IVIG at a high dose, as well as rituximab in preparation for the need of a potential transfusion. He has a febrile episode and actually grows salmonella on blood cultures. And over the next few days, his hemoglobin goes from 4.8 down to 4, and his renal function worsens over time with a creatinine of 179. It actually goes up to about nearly 300, and he does end up getting hemofiltration. His hemoglobin continues to fall, and when his hemoglobin is 3.4, we decide to start him off on tocilizumab because he's got an underlying infection, and because we know that he's hemolyzing. We know that if you use tocilizumab, this can help reduce the inflammatory cytokine-mediated red cell destruction. So we decide to go with tocilizumab first before eculizumab. What you can see here is a schema of what was given to him over time. So that's blood, IVIG, rituximab, eculizumab. The bright yellow is cyclophosphamide, and tocilizumab, pegcitalopram, and other interventions. So this is when he's admitted. And these are the IVIG and the rituximab, followed by a blood transfusion, some more IVIG, rituximab, and then followed almost immediately by eculizumab. And this is where he's already received the tocilizumab. You can see the hemoglobin continues to fall. He does get a bit of an improvement with the hemoglobin. It goes up to about 4 with the use of eculizumab. And we also start splenic irradiation mainly for symptom control because he's complaining persistently of left abdominal pain, which is affecting his ability to breathe well. And clearly he's on the intensive care unit at the time. He gets a further blood transfusion when his hemoglobin goes down to about 3, and further doses of both IVIG and further dose of rituximab. And at this point, I'm getting very worried because his hemoglobin is continuing to fall despite optimal standard of care management for hyperhemolysis, and because he's got spleen pain. So I am worried about extravascular complement-mediated hemolysis, particularly along the C3 pathway. And I managed to get the company to provide us with some pegcitalopram, and he receives this. This results in a very small improvement in his hemoglobin, and he gets a further dose of eculizumab with the aim to block the whole pathway from C3 down to C9. Unfortunately, it has very little effect on his hemoglobin, and he continues to drop his hemoglobin, and the spleen continues to be very tender. The spleen is increasing in size, so I then proceed with a splenic embolization. Unfortunately, the splenic embolization doesn't have much of an impact on the hemoglobin, but we're in a very challenged time at this point, and we probably haven't given enough time for the embolization to really have a benefit, but we have managed to embolize about 70% of his spleen at this point. His hemoglobin goes down to 1.7, and as you can imagine, there is immense anxiety about what's going to happen next for this patient. His spleen has gone from 18 centimeters at diagnosis to 28 centimeters. I'm worried about splenic sequestration and extravascular hemolysis in the spleen, explaining the massive splenomegaly. And our surgeons very bravely go in with a hemoglobin of 1.7 and perform a splenectomy. He obviously has a massive transfusion at the time. He gets given a lot of blood and comes out of theatre alive, thankfully, with a hemoglobin of 5.7. And then he proceeds to hemolyze all of that blood down as expected. What then happens is that we find that his platelet count hasn't gone up very much post-splenectomy, and we decide at that point to do plasma exchange. And there's some evidence on the use of plasma exchange in hyperhemolysis as a very useful adjunct for patients. So we proceed with that, along with the rituximab fourth dose. And we also give him 500 milligrams of cyclophosphamide because there's been a case report on a patient receiving cyclophosphamide for hyperhemolysis and getting a response. So the course of events is exactly as I've described. He does have a bone marrow before the cyclophosphamide, which just shows massive erythroid hyperplasia and increased megakaryocytes. The splenectomy is done, and the spleen histology actually does confirm extramedullary hematopoiesis and splenic sequestration. So the hemoglobin not improving was being driven by splenic sequestration. This is his platelet count. It does improve, but it just takes quite a while. We also obviously are continuing with supportive management. So he's had the high dose steroids. He's then on 60 milligrams of prednisolone daily. He's receiving darbepoetin weekly, B12 folic acid, and he gets a very short course of hydroxyurea, which we stopped because of the platelets. He slowly, post-splenectomy with a nadir of 1.7 roughly, at that point, we decide we're not going to give him any blood, and his reticulocyte count starts to improve. His hemolytic markers start to improve, and his hemoglobin starts to improve. And when his hemoglobin is 2.1, we're confident that he's going to survive. And over the course of the next week, his hemoglobin goes up to around about 5, which is where it is when we discharge him. He's now back in Egypt. Before Eid, he sent me his blood count. His hemoglobin's 8.6, platelets are around about 1,000, white cell count 23, and he started hydroxyurea to bring the counts into control. So a serious complication in patients following blood transfusion can arise in non-transfusion dependent patients. So iron overload is obviously the other major challenge in patients with non-transfusion dependent thalassemia, and we know that iron overload is a very major issue. We know the ferritin is underestimating the extent and the severity of the iron overload from clinical trials. We also know that a high serum ferritin is associated with a worsening mortality in these patients, and we know that a high liver iron is associated with more complications in the non-transfusion dependent thalassemia patients. And guidelines from the Thalassemia International Federation, from the UKTS, from BSH, all recommend that iron chelation is offered to patients when the ferritin is above 800 persistently, or the liver iron is above 5 milligrams per gram dry weight. Cumulative iron overload happens over time, and what you can see from the ORIENT study and from this bar plot is that patients develop significant and worsening iron overload as they age, with increasing levels of serum ferritin and iron burden. The only trial that's been conducted on iron chelation in non-transfusion dependent setting is the THALASSA study looking at deferocyrox in patients. And this was a placebo-controlled randomized clinical trial which showed a very significant improvement in the iron stores in these patients in comparison to placebo, and an improvement in the serum ferritin and the liver iron in this population of patients. We also know from cohort data, looking at longitudinal cohort data, that patients who are receiving iron chelation are less likely to develop liver dysfunction in comparison to those who are not receiving iron chelation. So getting good control of liver iron is incredibly important in preventing complications and improving survival in the non-transfusion dependent patients. The TIF guidelines and the BCSH guidelines all recommend that you should be offering deferocyrox when a ferritin is above 800 persistently, or the liver iron is above 5. And you can chelate them with either desferal or deferiprone if they do not have access to deferocyrox. So regardless of which iron chelation therapy the patient is taking, you should be aiming to control the iron burden in patients. So in conclusion, non-transfusion dependent thalassemia is associated with significant complications and a poorer prognosis compared to well-treated transfusion-dependent thalassemia patients. Optimization of hemoglobin is really important in reducing complications and improving clinical outcomes. It's very important to remember that patients are at risk of antibody formation and development of transfusion-related complications, and care needs to be taken to ensure that you are optimally matching your patients. Iron overload should be managed in all patients with the optimal screening approaches, and that means monitoring the serum ferritin at regular intervals and undertaking MRI assessments as and when required. And there is a big hope now that the novel therapeutic agents, which will be discussed later on in this meeting, will help to improve patients' hemoglobin levels and reduce the risk of complications in this population of patients. So I just want to thank the organizers for inviting me to speak at this meeting, and for such a fabulous program, which I think has been really great. I want to thank the patients that I both look after here and the patients I've looked after in the UK. They are at the heart of everything that I do. And I want to thank my teams, both old and new, for supporting my ability to present. So I just want to say thank you very much, and I'm happy to answer any questions.
Thank you so much, Dr. Shah, for the excellent presentation. I think there's one question. Is all NTDT genotype are the same in complication, or certain genotype is more prone to severer complications?
Thank you, Dr. Najat. I think that's a very good question. I think we don't have so much data specifically around the genotypes, but what we do know is that the phenotype of the patients does make a massive difference. So patients who are more anemic or who are more likely to iron overload are the ones where the prognosis and the health outcomes are worse. What we do know is that the E-beta thalassemia, if you're talking specifically about a subgroup genotype, the E-beta thalassemia patients do tend to tolerate their anemia clinically better. But in my own experience, the E-beta thalassemias actually get pretty terrible iron overload. Overall, I think the most important thing with this cohort is to monitor the phenotype and react proactively based on how they're behaving clinically.
Okay, thank you so much, Dr. Shah.
Thank you very much.
We move now to the next speaker. Our next speaker is Professor Haider Prangul, Director, Pediatric Stem Cell Transplant Program, Sierra Canyon Transplant and Cellular Therapy Network, Nashville. Professor Prangul is a pioneer in curative therapies for non-malignant diseases. Professor Prangul was the lead investigator in the landmark CRISPR-Cas9 gene editing trials for sickle cell disease and thalassemia. He has authored over 160 peer-reviewed manuscripts and holds key leadership roles in global oncology consortia. Welcome, Professor Prangul.
Well, thank you so much for having me. Can you guys hear me and see my slides? I just want to make sure.
Yes.
Okay, thank you so much. Well, thank you for the opportunity and the invitation to present. Hopefully this will be helpful. I'm going to present data on curative therapies that away from allogeneic transplantation, and we're going to talk about the available gene editing therapy to treat transfusion-dependent beta thalassemia. So I'm not going to belabor this. I know a lot of speakers here are all experts in beta thalassemia, but there are 40,000 affected infants that are born each year, with half of them classified as transfusion-dependent. And unlike sickle cell disease and beta thalassemia, there are many, many different mutations. And beta plus donating mild mutation that cause relative reduction in beta globin chain, beta zero, refer to mutations that can lead to complete absence of beta globin chain production. And patients with TDT require red blood cell transfusions every 2 to 5 weeks, and it's a lifelong frequent transfusion is required to maintain a normal or close to normal hemoglobin. As many of you have already discussed, and again, I'm not going to go into this in major details, the main complications of thalassemia are really multi-organ dysfunction. It's endocrine dysfunction, thrombosis in patients with history of splenectomy. You can get osteoporosis, fractures, arthropathy, lung ulcers. So it's really a multi-system disease. And as the previous speaker eloquently discussed, these complications can happen even in those who are not transfusion dependent, who have low hemoglobin. So it's quite debilitating disease over time. So what can we do to treat beta thalassemia? I know many people, again, talked about these therapies. It includes red blood cell transfusion and doing a extended antigen typing to minimize alloimmunization, like the case recently presented with the prior speaker, monitoring iron overload using liver and cardiac MRI, iron chelation therapy, and luspatercept, which has been approved and seems to improve the hemoglobin in those with non-beta zero, beta zero genotype. Now, allogeneic transplant remained the only curative therapy from an HLA identical sibling, although, as you all know, the chance of finding a matched sibling that's not affected to transplant somebody with transfusion-dependent beta thalassemia is in the order of around 20%. And the outcome with unrelated donor transplant is really not ideal, which I'm going to talk about next. So if you look at, this is a paper published in 2019 in Blood Advances. This is a registry trial in an international survey looking at the survival with different types of transplantation. So the table here on the left shows that with HLA matched sibling, if the patient is less than 6 years of age, the event-free survival, meaning being alive with no graft rejection, is 88%, and with those who receive an unrelated donor transplant is relatively similar, and it is lower with those receiving mismatched unrelated donor transplant. Now, the data is quite different when you look at older patients, those who are 7 to 15, and clearly I did not talk about it here, but even those who are older than 15, it looks significantly worse. So, for example, the HLA matched relative, if you are between 7 and 15 years of age, the event-free survival is 80%, which is not ideal. And that actually gets worse when you end up with a mismatched unrelated donor transplant. So that's why I think gene therapy is really very appealing, because it does not cause any graft versus host disease. It does not cause any graft rejection, and it basically allows using autologous cells to perform these gene therapies. There are currently 2 approaches to gene therapy in beta thalassemia. One is a gene addition using a lentiviral vector to put a functional beta globin gene into the hematopoietic stem cells. And there is the gene editing approach, which is approved worldwide now, to treat patients by inducing fetal hemoglobin to normalize the total hemoglobin and correct the ineffective erythropoiesis. These approaches are relatively similar in the patient journey. The patient journey, patients undergo peripheral blood stem cell mobilization, and then one approach uses a lentiviral vector to infect the cells. Another approach is to use electroporation to cause gene editing, which we are going to talk about here in just a minute. So just as a background, as you all know, the main type of hemoglobin in early life is fetal hemoglobin, made of 2 alphas and 2 gammas. And a few months after birth, hemoglobin F is replaced with hemoglobin A. Clearly, those with beta thalassemia do not make enough hemoglobin A or don't make any hemoglobin A. So they end up in trouble, requiring chronic transfusion. So the graph here shows that the fetal hemoglobin drops, and by 6 months, it's very low. And that's when we see the manifestation of the severe genotype beta thalassemia happening, when the fetal hemoglobin disappear and they cannot make hemoglobin A. So we know also that there are some individuals out there that have persistent fetal hemoglobin throughout adulthood, and those individuals actually with hereditary persistence of fetal hemoglobin have experienced reduced complications and sometimes can become transfusion independent if they have high enough fetal hemoglobin. So we know that CRISPR-Cas9 mediated editing of the BCL11A increased hemoglobin F. So this was actually found in around 15 years ago. It was discovered that BCL11A can suppress the production of gamma globin. So somehow knocking BCL11A can potentially activate gamma globin production and increase fetal hemoglobin production. And we know that naturally occurring genetic polymorphisms in the BCL11A are associated with elevated fetal hemoglobin. And unfortunately, when this discovery happened 15, 20 years ago, there was no way to manipulate the genome to suppress BCL11A. And now we actually have the technology with CRISPR-Cas9, as I was going to explain here in a minute. But we know that BCL11A suppresses the expression of fetal hemoglobin by suppressing gamma globin production. So editing the BCL11A results in reactivation of the gamma globin expression in the mouse model. And we know that CTX001, which is now currently approved as Casgevy, is produced using ex vivo editing of the erythroid enhancer region of the BCL11A gene in the hematopoietic cells. And that can result in increasing gamma globin production and thus increasing fetal hemoglobin. So again, when you look at it in a cartoon, this was by Marty Steinberg in New England Journal of Medicine. You perform peripheral blood collection using G-CSF and plerixafor, and then the cells are then electroporated. Basically, they're electrocuted, and then there is a CRISPR-Cas9 with a guide RNA that basically does a double-stranded break and deactivate the BCL11A and the erythroid enhancer region that will result in elevation of gamma globin production and thus making the cells make more fetal hemoglobin. So we know that exa-cel is approved in many countries in the United States, Europe, and the Middle East to treat patients ages 12 and older with transfusion-dependent beta thalassemia. I'm going to talk today about the most recent, longest follow-up for individuals receiving this therapy. And exa-cel, again, is produced using a non-viral mechanism by using CRISPR-Cas9 to reduce the erythroid-specific expression of BCL11A, and it reactivates fetal hemoglobin, and that results in reduced morbidity and mortality in patients with hemoglobin disorders. And what I'm going to talk about today is, again, the long-term data looking at durable clinical benefit and correction of ineffective erythropoiesis using this approach. So the pivotal trial was a global multi-center trial. To be eligible, you needed to be 12 to 35 years of age with transfusion-dependent beta thalassemia, defined as at least 10 units of blood given per year in the last 2 years, or for those smaller patients, more than 100 mLs per kilogram per year. And the primary endpoint was the proportion of participants who are transfusion independent for more than 12 consecutive months. And there were multiple secondary endpoints, and including the duration of transfusion independent, fetal hemoglobin, allelic editing in the bone marrow and peripheral blood. And again, I think it's very important because I think a lot of speakers before me talked about how ineffective erythropoiesis can happen and can cause a lot of morbidity, even if you have relatively close to normal hemoglobin. So looking at ineffective erythropoiesis was a very important secondary endpoint in our trial. And then this trial was 2 years, and all the patients rolled into a long-term follow-up for a total follow-up of 15 years. So if you look at the patient characteristic, there were 56 patients that were treated. A third of the patients were adolescent, ages 12 to 18, and close to 50% of the patients, a little bit over 50% of the patient had a severe genotype, either beta 0, beta 0, or beta 0, beta 0 like. And all the patients had some degree of iron overload with a liver iron content of 1.2 to 14.8. So if you had a LIC more than 15, you were not eligible unless you have a liver biopsy that showed no fibrosis. And the median number of transfusions was 36 per year. And the number of mobilizations required, and again, patients undergo mobilization using G-CSF and plerixafor, was 1.3. The majority of the patients underwent 1 cycle of mobilization. And all patients engrafted neutrophils and platelets. The neutrophil engraftment was at a median of 29 days, and platelet engraftment was a median of 43 days. Of note, those with an intact spleen had a slightly longer time to platelet engraftment as compared to those without a spleen. The time in the hospital was 39 days, and the duration of follow-up close to 50 months. So this is a swimmer's plot. Again, to orient you here to this is the area with the gray to the left represent the 2 years prior to the exa-cel infusion, and each diamond here is a red blood cell transfusion. The area in red is the red blood cell transfusion following exa-cel infusion, and the dark gray bars are the 60-day washout. So the clock for efficacy starts 60 days after the last transfusion. And now this is the latest data that we presented at ASH in 2025. And now 98% of The patients are transfusion independent. This is 55 out of 56 patients. As you can see, the one patient that did not meet the TI-12 or transfusion independent for 12 consecutive months has been actually transfusion independent for 1.5 years. But because we defined transfusion independent as a hemoglobin greater than 9, and this patient is ranging between 8 and 9, still transfusion independent, did not meet the primary endpoint. But clearly now every single patient on this trial is not receiving any transfusions. When we look at the total and fetal hemoglobin, the dark line represent the total hemoglobin in patients, and the light blue light is the fetal hemoglobin in grams per deciliter. And the patients, you really have a very stable total hemoglobin, either near or at normal range, with the majority of it being contributed by fetal hemoglobin. When you look at the allelic editing, so when we first started this trial, there was a lot of concern by many people that the allelically edited the stem cells that we are infusing are not going to last for a prolonged period of time. And now we have a 5-year follow-up, and you can see that the bone marrow allelic editing is very stable in the bone marrow and peripheral blood over time, indicating that we actually edited primitive hematopoietic stem cells that are lasting in the bone marrow and peripheral blood. The most common adverse event, again, because every patient here received myeloablative busulfan chemotherapy, most of the complications are truly related to busulfan chemotherapy, which we are all aware of: alopecia, mucositis, fever, neutropenia, and pancytopenia. None of the patients here on this particular trial, ages 12 to 35, experienced any death or malignancy. So 100% survival and 98% transfusion independence, which in my mind is actually better than any allogeneic transplant, even that in matched sibling transplant. So the SAEs here are primarily related to the fact that the patients received myeloablative busulfan. When you look at iron removal therapy, every patient after this therapy underwent some form of iron removal therapy, with 30% receiving chelation alone, 30% receiving phlebotomy alone, and 35% receiving a combination of both. In my site in Nashville, we use phlebotomy only as our approach, and around 4 months post-transplant, when the hemoglobin is over 11 grams per deciliter, we initiate monthly phlebotomy. And the median time to starting chelation or phlebotomy was 6 to 9 months. And 69% of the patients have actually discontinued any form of iron removal therapy and have at least 6 months of follow-up. So this is looking at the serum ferritin here. Again, early post-transplant, it's an acute phase reactant. So you see a very high increase in ferritin, which actually I think is artificial. And then with iron removal therapy, the ferritin falls down to normal and normal range. We recommended in the trial that phlebotomy or iron chelation is maintained until the LIC is less than 5 and the ferritin is less than 500. And as you can see from this slide here, this dark lines represent those who underwent iron removal therapy, then discontinued it. And as you can see, the serum ferritin and the LIC is stable. Now we have patients up to 3 years out from stopping iron removal therapy with no reaccumulation of iron in the liver, indicating that this approach is actually potentially correcting the ineffective erythropoiesis in the marrow. When you look at other markers of ineffective erythropoiesis, which I know some other speakers alluded to, like erythroferrone, and those levels actually are approaching normal levels, and they are not showing evidence that ineffective erythropoiesis is happening after discontinuation of the iron removal therapy. Hepcidin levels are not suppressed, consistent with the absence of iron reaccumulation over time. Basically, every indication we have now with the follow-up we have that iron is not reaccumulating after this therapy and after discontinuation of iron removal therapy. Looking at data I just presented at ASH, this is hot off the press in 2025. This is children 5 to 11. Now, clearly, we do not have approval yet to treat patients 5 to 11 commercially, but I wanted to show you and the data we presented at ASH. There were 13 children, ages 5 to 11, that were treated on a clinical trial. And currently, the FDA is reviewing our application to get approval for this therapy for children less than 12 years of age. And the age of screening was a median of 7.4 years. And again, around half the patients or close to half the patients had beta 0, beta 0, or beta 0, beta 0 like. And again, the number of transfusions were a volume of around 232 mLs per kilogram per year. And when you look at the ages here, the TDT patients, now I'm comparing adolescent to pediatric. I combined all the pediatric data here to give you a flavor of what the 5 to 11 look like compared to the 12 to 18. And as you can look at the mobilization cycles, 100% of the patients mobilized in 1 or 2 cycles, which is very similar to what we have seen in the adolescent cohort. And the peripheral blood CD34 count with cycle 1 was higher actually in the younger patient. And the cell dose was comparable between the two at around 9 million CD34 per kilogram. But the interesting part is the majority of the patients collected in 1 or 2 cycles, with 90% of the patients collecting in 1 or 2 cycles, even in the adult side. When you look at the data here, the busulfan exposure was 79.9. The time to neutrophil and platelet engraftment was very similar to what we have seen in the older patients, with neutrophil engraftment at around 30 days, and time to platelet engraftment was at 52 days. Now, it's important to realize that the majority of patients that were younger, between ages 5 and 11, were actually having intact spleen. So the longer time to platelet engraftment was consistent to what we have seen in older patients with intact spleen. The average time in the hospital was 37 days, again, compared to 39 days in the other trial. Now, when you look at the data, again, now I'm going to orient you. The top panel is our adolescent patient, ages 12 to 17, and the bottom is patients 5 to 11. In the 5 to 11 cohort, 6 out of 6 evaluable patients achieved transfusion independence, and actually every single patient that has long enough follow-up as age 5 to 11 achieve transfusion independence and remain transfusion independent throughout follow-up, which is very encouraging, meaning 100% of the patients remain transfusion independent. And here, the adolescent patient we discussed earlier, who went a year and a half without transfusion, maintaining a hemoglobin between 8 and 9, but not consistently over 9, so could not be counted as transfusion independent. So the pediatric cohort, the 5 to 11, did very well. If you look at the total hemoglobin was increased, and again, the majority of it is fetal hemoglobin. And when you look at age adjusted, because these are children, so a normal hemoglobin for a 5-year-old is 11.5. So when you look at the hemoglobin, it was normal for age, and it was pancellularly distributed with more than 99% of the red blood cells containing fetal hemoglobin. When you look at the adverse events, there was actually 2 cases of veno-occlusive disease of the liver, with 1 unfortunately resulting in a death. That was 1 pediatric patient that died secondary to veno-occlusive disease of the liver, which is a known complication of busulfan chemotherapy. The incidence of VOD in the other trial, the adolescent and young adult, was 12.5%. Developed VOD, but we did not have any fatality in the older patients. But unfortunately, a young patient died from VOD related to busulfan. And in that particular patient, he received Q24-hour dosing of busulfan. And since we have changed the administration of busulfan to Q6, and I can tell you that none of the Q6 patients actually died from VOD related to busulfan. And the incidence of VOD in those receiving Q6 dosing is extremely low. There was only 1 patient that developed VOD in the Q6, and all the other patients that developed VOD received Q24 hours busulfan. So it's clearly related to busulfan toxicity related to the way it was administered. So now we recommend that busulfan is administered every 6 hours. So I'm going to present also some data that we just recently published in New England Journal of Medicine in April of this year using CRISPR-Cas12. This is a different technology. And instead of targeting the BCL11 enhancer region, erythroid enhancer region, we actually targeted the binding site for BCL11A at the HBG1 and HBG2 gene. And I reported on this in New England Journal of Medicine on 9 patients that were treated. The patient demographics are listed on the left, very similar to what I have showed you in the prior trials. And what you can see here is that every single patient here in this trial became transfusion independent with normal hemoglobin, and the majority of the hemoglobin is made of fetal hemoglobin. You can look at this here. This is individual patients, and you can see by 6 months, the total hemoglobin was 12.5 with 11.5 grams being fetal, and more than 99% of the red blood cells contained fetal hemoglobin. And this is a picture here showing transfusion independence. Again, every single patient out of those 9 patients became transfusion independent with normal or very near normal hemoglobin levels. The adverse events here were again related to busulfan as pancytopenia, mucositis, hair loss. There were no cases of veno-occlusive disease of the liver and no cases of fatality or malignancy related to this therapy. Again, these are very encouraging data, again suggesting that activation of fetal hemoglobin using a different mechanism can also result in transfusion independence. So in conclusion, exa-cel is the first and only approved CRISPR-Cas9 gene editing. The other approach I just discussed is not really approved. The long-term follow-up up to 5 years, all TDT patients had durable clinical benefits, and 98% became transfusion independent. And there is evidence that we are correcting ineffective erythropoiesis, and all the side effects actually are related to myeloablative conditioning. And the data in children 5 to 11 years of age is very encouraging. Hopefully will result in approval by the regulatory authorities to allow us to treat patients who are younger. So what are the advantages? Again, you don't need a donor. There is no risk of acute or chronic GVHD. There is faster recovery. My patients who get treated with this therapy go back to work or school at 2 months after transplant. The disadvantages, there is short follow-up as compared to allogeneic transplant. The potential risk for secondary malignancy, although we haven't seen it, it's still a theoretical risk. There is a risk for, there is a cost associated with this. As you guys know, it's expensive to do these therapies. So what in my mind is the role of allogeneic transplant? I think where gene therapy is available and when finances is not an issue, I think allogeneic transplant really should not be considered anymore for TDT. In my center, even if you have a matched sibling, we are offering gene therapy as an alternative to matched sibling transplant because, again, the results are extremely encouraging. I would like to thank our team. This is from 3 years ago when we infused our 40 patients. Now we are above 60 infused patients with gene-modified therapy. This therapy would not have been possible without the patients, the team that I have here in Nashville that have been instrumental in making this work. And I would like to thank the organizers for this meeting. And I am happy to take any questions.
Thank you so much, Professor Frangul, for this excellent presentation and very impressive results. There are 2 questions for you. What are the absolute contraindications for gene therapy in TDT? Okay, and then I will mention the second question.
Yes. So to answer your question, the absolute contraindication for gene therapy at the moment is if you have liver dysfunction or organ dysfunction preventing you from receiving busulfan. Now, I'm glad to report that there are multiple people looking at non-busulfan conditioning, which I think hopefully will be coming to the clinic in the next few years. And hopefully that will be able to allow us to eliminate chemotherapy altogether. But currently, if you have liver fibrosis, for example, stage 3 or 4 liver fibrosis or cirrhosis in the liver, I think gene therapy is very risky because it can cause complications. So anybody that cannot get busulfan is basically contraindicated to this therapy at this point because we don't have a good alternative to busulfan chemotherapy.
Okay, the second question for severe TD alpha thalassemia, any curative treatment approved? Alpha
So you're
thalassemia,
talking about alpha thalassemia,
severe
not
alpha
beta
thalassemia.
thalassemia.
No, this question, no, the second question they are asking about is the gene editing an option for alpha thalassemia as well, or just for the beta?
At the moment, it's only for beta thalassemia because the gene therapy approach we have currently is to introduce fetal hemoglobin, which is gamma globin. So we need a functional alpha globin. So somebody with 4 gene deletion or 3 gene deletion alpha globin deletions if we elevate gamma, they cannot make fetal hemoglobin. So at the moment, there is really no option for alpha thalassemia. Now, having said this, if you have a beta thalassemia patient that have 1 or 2 alpha gene deletion, they are a candidate for gene therapy because we have had patients with 1 or 2 alpha gene deletion and severe beta thalassemia, and those patients are eligible and they do well. But 3 and 4 alpha gene deletion, you cannot do that.
Thank you so much, Professor Frangel, for your this excellent presentation. We move now to the next speaker. Our next speaker is Dr. Sharif Badawi, Associate Professor, Pediatric Hematology, Oncology, and Stem Cell Transplant, Lurie Children's Hospital of Chicago, Director, Comprehensive Sickle Cell Program, Director, Comprehensive Thalassemia Program, and Robert Lurie Children's Hospital of Chicago. Associate Professor, Hematology Oncology, Northwestern University Feinberg School of Medicine, attending physician Anne and Robert Lurie Children's Hospital. A pioneer in digital health and outcomes research, Dr. Badawi's work, funded by NIH and FDA, and focuses on mobile health, patient-reported outcomes, and medication adherence, driving the shift towards patient-centered care in hemoglobinopathies. Welcome, Dr. Sharif.
Thank you so much, Dr. Najat, and hello, everyone. Thanks for the invitation, and nice to talk to you all today, and really a pleasure to be at the conference.
Your voice is, can you raise your voice, please?
Is it better now? Can you hear me better now?
Yeah.
Okay, perfect. So I will speak up a little bit. But again, thank you so much for the kind invitation and excited to be with you today. Again, my name is Sharif Badawi, and I focus predominantly on sickle cell and thalassemia. And today we'll talk about the changing landscape in sickle cell care, going from like symptoms and disease management all the way to really touching on curative therapy, but not in much detail as Dr. Frangel already done for thalassemia, because I felt we have kind of a lot to cover here today. So thanks again for the invitation and excited to talk to you all today. These are my disclosures. Leave it for a second. And our objectives for today are to talk about pathophysiology, complication, disease burden, and quality of life in sickle cell disease, discuss and review the disease-modifying therapies that we have, and just brief review of the curative options, maybe with focus more on gene therapy, stem cell transplant as well, and then some of the pipeline therapies that are coming for sickle cell disease. So when I started really in sickle cell and thalassemia, one of the things that really drove my passion is the psychosocial burden in addition to the medical burden that patients have, especially when they are at home, outside the healthcare setting, and considering, you know, what else can we do to help them with that? Because I felt that there was a gap. When we talk to them in the clinic, you know, things seems to be kind of clear and straightforward, and they already know what they're gonna do, how they're gonna take their medication, when they need to come back, when they're gonna do their lab workup for follow-up and so on. But then when they go home, right, there is like a struggle with many other things. You know, they have to live a normal life like other kids, you know, or adolescents or young adults their age. They struggle with many things, right? They are trying to fit into society. There may be some stigma around their disease. So I felt that the burden from the quality of life standpoint was significant, and maybe there is something that we can do about it. And that's why, you know, I really started to focus more on patient-reported outcomes, quality of life, and maybe mobile health, as Dr. Najat said, or digital tools to try to bridge that gap between the home setting and the hospital setting as well. So thinking about the pathophysiology and complication and quality of life, this is a very simplified, really cartoon of what we know about sickle cell disease. We know it's common in Blacks or patients of African descent, Asia and Southeast Asia, Middle East as well, but definitely in the US, predominantly in African Americans. And it affects about 100 to 120,000 Americans in the US. And about 1 in 350 African American would be actually carrier as well. We think about it as, very simplified way, the oxygenated hemoglobin become deoxygenated, and that really what lead to the sickling in different ways. Flow of the blood vessels, of the red blood cells can really change, as we know that this is how normally it should be, but when the sickling happen, of course, there is going to be the vaso-occlusion, there's going to be the hypoxia, the block of the blood flow in different body parts. And as I said, this is really a very simplified version because we know now, like the vaso-occlusion and the pathophysiology is so complex, right? And for me, when I look at that figure, always it's like a puzzle, right? Like there are so many things that can affect vaso-occlusion in different ways, right? Like cell adhesion. There could be the nitric oxide, process. There could be within the red blood cell itself, right? Like different things. Immune system. Now we have some medication going to be targeting immune system and immune dysregulation, and all of them, I think, at the end lead to some impact, and effect on patients' complications and disease pathophysiology overall. So it really is an interplay of so many parts. And I think that's why, as we will talk about some of the therapies we use right now, it's a hit or miss sometimes because you try to target one piece of the puzzle, but maybe that will have downstream effect to improve other aspects of the pathophysiology. And sometimes that's not. Or if you are multimodal, maybe you have better chance of efficacy, as we saw with hydroxyurea. But it's definitely complex. It's not that simple as we thought back in the day it is. But I think that deeper understanding is really giving us the opportunity to better develop therapies that work for patients. So overall, again, sickle cell disease is a devastating chronic illness, and many of you or all of your hematologists already know that. Common complications, of course, are VOE or pain crises, whether it's acute or chronic, acute chest syndrome, pulmonary hypertension, and cardiopulmonary disease, stroke, whether it's overt stroke or silent stroke, and end organ damage in so many ways, kidney damage, liver damage. And we know all of these complications can definitely culminate into significantly poor or impairment quality of life over the lifespan of patient. This is a schematic kind of graph of different acute and chronic complications that you can think of. So we always consider sickle cell as a multi-system disease because there's so many things that can happen, right? Sickle nephropathy, sickle pulmonopathy, and this is again, the acute chest or pulmonary hypertension, but also I have some patients who have restrictive lung disease or diastolic dysfunction, and all of that can actually lead to even sudden death, right? We know about avascular necrosis in different bony parts, especially the femur or the humerus. We know there can be some endocrinopathies, there can be some kidney damage, especially as patients get older and older. Gallstones, hepatic sequestrations, and of course, autosplenectomy or functional asplenia, in addition to anemia and hemolysis. So there are so many complications that really patients can be at risk for, and we didn't even talk as much about like retinopathy and vena thrombosis, ischemic strokes, and of course, cognitive function and cognitive impairment that can happen as a result of that as well. What we also know is that, these complications build up over time, right? So for the younger age groups, younger than 6 years old, we can see a lot of pneumonia, acute chest, fever, and of course, avascular necrosis. And then as they get older, we can see more and more of some of these complications, especially avascular necrosis that kind of peaks around 18 to 29, and as they get older continues. and definitely kidney disease. Once they are in their late teens, early 20s, we start to see that continue to increase all the way to almost 40% of patients, if not even 45, might have risk of chronic kidney disease or renal failure. So over time, these complications build up, don't happen overnight, but at the same time, it just highlights really the burden of the disease for these patients. And of course, as you can imagine, with all these complications, patients definitely have increased healthcare utilization to manage these complications and address them. And that's why always prevention is best. And there have been some studies looking at, what are the predictors for that? And some of them were comorbidities, or you're living in a remote area, maybe where you don't have close access to a sickle cell disease center of excellence, that definitely can affect overall maybe or increased risk of overutilization. And I like this graph a lot from Julie Panapinto's work when she actually compared quality of life across different chronic conditions. And this is just an example of physical functioning, where you have children with sickle cell disease have scores of physical function that as maybe bad as cancer patients on chemotherapy. So you can see both of them around like the 65. And in that physical functioning scale, like higher is better, lower is worse. And of course, both of them are 20 points lower than healthy children, as an example here, just the state of California in the US. But you can see how significantly impaired physical functioning is among patients with sickle cell disease and similar to thalassemia, but really kind of as bad as cancer patients on chemotherapy. And sometimes we underestimate the significant burden these patients actually have. And that was the pediatric data, but if you look in the adult space, also kind of in a similar way, patients with sickle cell disease have actually kind of comparable, if not even worse, by 5 points compared to cancer patients with worse quality of life. Again, worse than the population, but also worse than thalassemia or cancer patients. And again, all of that usually comes as a result of all the complications that patients experience in their lifespan. So why should we care and why does it matter? Because one, it's a reflection of the disease burden, right? And it can help us really understand the challenges that patients face at home. It can help us to predict some of the outcomes and there may be risk of developing further complications later on. It's an opportunity for shared decision-making where we can talk to patients about, maybe what has been working so far, what can we change? I'm doing okay. I'm not really sure that's a reasonable answer. I want to make sure I understand better. What do they do at home in everyday life? Are they physically active? Do they exercise? Do they go out with their friends? Because I think we're trying to normalize life for them as much as possible and try to optimize the management to achieve that goal. Intervention effectiveness for sure, as we talk about different therapies later, some have been helpful and some are not in improving quality of life. So that can be, part of the shared decision making when we are choosing across different treatment modalities. And of course, some emerging, issues in sickle cell is neurocognitive deficit, as now we are more and more recognizing silent strokes and the impact that it have on patients with cognitive impairment in the long term, but also the comorbidities, and chronic illness is just difficult, and sickle cell disease is just really one of them. So anxiety, depression, social isolation, all of these are definitely key aspects of our management for sickle cell disease. It really shouldn't be just hematology, like just sickle cell, hemoglobin. We really should do more of a holistic approach, more comprehensive to optimize patients' well-being. So what do we know about, disease-modifying therapies, curative therapies in sickle cell? We always think of it like three big buckets, right? So preventive strategies, disease-modifying therapies, and curative approaches. Preventive, of course, the penicillin prophylaxis at the time of diagnosis, from newborn screening until at least 5 years of age, where there is the highest risk of pneumococcal infection, encapsulated organisms, H influenza as well. and make sure they get the right vaccines, pneumococcal, H flu, and meningococcal later as well. Transcranial Doppler screening, at between 2 to 16 years of age to kind of look for increased risk of stroke. So trying to really do primary prevention or secondary prevention. So preventing that first stroke from ever happening for any patient, but also secondary prevention, preventing a second stroke, which unfortunately can happen for some patients. In addition to education about when to call for fever, when you have to come to the hospital, pain management, dactylitis at the younger infants. So a lot of education really has to happen, and all of that will be kind of in the preventive category. Disease-modifying therapies, hydroxyurea is really the standard of care. We'll talk about it in detail. L-glutamine is another option. Voxelotor used to be, now off, and we'll talk about that just like for historical perspective, but also because there is a small chance it might come back to the market. So just you to know what we know about it from the HOPE trial. And then crizolizumab, which is a p-selectin inhibitor, and we'll also talk about the data for that. And then curative therapies, stem cell transplant and gene therapy. We'll focus more today on gene therapy data, also briefly, but not really much stem cell transplant. But definitely it is an option, and we'll talk about it as well, but again, just briefly. So how does hydroxyurea work? It really kind of so many ways, and I think that's why this kind of multimodal approach is one of the reasons why hydroxyurea is the standard of care in sickle cell disease, and we have about maybe closer to 60% of our patients now are on hydroxyurea, and we try to use an opt-out approach where everybody is initiated on hydroxyurea when they are around 1 to 2 years of age. I think there's definitely more benefit than risk, and you have to still counsel patients. But really how it works is, again, it increases the erythroid progenitors. It kind of decreases the myeloid precursor, so it kind of decreases that kind of stickiness, with the white blood cells and the red blood cells. It decreases the neutrophil, so it has some, kind of suppression here, and also reduces the reticulocyte count along with the erythrocyte. And then also it can release the nitric oxide, so that release from the endothelial cells help to have that kind of vasodilation effect and protect against vaso-occlusion. And I think really kind of the fact that it works in different ways, and of course it increases fetal hemoglobin production as part of the erythroid progenitor kind of effect. And that's really where we see a lot of the clinical benefits from hydroxyurea. So again, thinking specifically about its effect on the complications, because it's really multimodal, and we know that the F cells and having higher fetal hemoglobin level can be protective in sickle cell, especially when you really reach that 20% or higher. There have been some older data looking at 5%. Is that enough? 10%? Is that enough? 15%? Is that enough? And I think the most recent data from St. Jude longitudinal cohort studies showed that really 20 is what we are seeing. And I think as you saw Dr. Frangiola about like a lot of that in gene therapy, we're looking at like 40, 50%. And of course, that's very protective and prevent a lot of these complications. So we can try to prevent pain, maybe decrease risk of nephropathy, leg ulcers, osteonecrosis, priapism, acute chest, stroke, and pulmonary hypertension. But I would say the level of evidence across all these benefits vary, meaning that we are more confident about the benefits for pain. We are more confident about the benefits for acute chest. Stroke with like a caveat that you have to do chronic transfusion first for a year for somebody with abnormal TCD, and then transition them to hydroxyurea later on. So it can be helpful in some of these other complications, but the level of evidence is relatively low. So it's kind of a weak evidence, but again, likely better than not doing anything at all for this end organ damage that might eventually happen. And of course, it has been studied for so many years now, almost 3 decades, and we know it is safe for all the studies, phase 1, 2, the multi-site hydroxyurea trial, the baby hug trial, all of them listed here. So really kind of have been studied extensively. But you still have to counsel, of course, patients about the side effects that we know of, right? Between GI, a little bit irritation of the liver that could happen. The biggest one we see here, that especially for teenagers, is really one, darkening of the skin, darkening of the nail beds, and thinning of the hair, because that's kind of, especially for teenage girls, you can imagine that that's kind of a big problem for them, for like their psychosocial well-being, self-confidence, self-image. Like there are just like so many other things that can affect, and that's why we really need other alternatives for those patients too. So indications, as I said, we use an opt-out, but overall the recommendation from the NHLBI is for frequent pain or acute chest or others. There are definitely benefits again for morbidity, mortality, better quality of life, lower healthcare utilization. But unfortunately, adherence is still suboptimal because those reasons. If people experiencing side effects, they are not going to be taking it the way they're supposed to. And it's still about 50%. So some people are superstars, some take it a couple of days a week, and some are in between. Why people are not taking hydroxyurea, and I think that applies to many other medications. Forgetfulness continue to be the most common reason. Worries about side effects. Not sure it's working for them. We always have to remind them it takes 3 to 4 months, up to 5 months to really start to kick in, and you make that switch from hemoglobin S to hemoglobin F. And then again, just busy with other things, you need to come more often for monitoring, lack of understanding and lack of access. But really forgetfulness and side effects, I would say, are the two most common that I see in clinic. And then the other problem is like perceptions, right? Some people have, good perception of it, so that reinforce their adherence behavior over time, and they continue to take the medication because if they see that as a valuable one, then it helps them be more active, missing fewer days of school, less pain. But some other patients, and we see that on the opt-out approach often, they just are not willing to accept the risk of hydroxyurea because they feel like they have milder disease, don't really have as much. And I think that can become problematic a little bit if they perceive their disease being kind of milder overall. So if we switch from like hydroxyurea to other therapies, right? So L-glutamine or Endori in the US, this is kind of from the pivotal trial for its approval and comparing its efficacy compared to placebo. And what you can see here is comparing, again, the red line is placebo and the blue is L-glutamine, and on the y-axis, the cumulative event rate, and then these are the days to sickle cell crisis. This is day to first, and this is days to second. And you can see that, L-glutamine have kind of significant benefit and significant reduction when you look at the cumulative event rate for both the first and the second pain crises. Yeah, the main side effects is really kind of GI, I would say, that's kind of 25%. I would say even we see in practice a little bit higher sometimes. Diarrhea, there are other ones, tachycardia, fatigue. I mean, although it is approved by the FDA, I would say our utilization is really low, and I think we had few patients on it, but then ended up stopping because of the bloating and the GI side effect. So in our cohort, which we have about 500 patients, I think we have maybe 1 patient on L-glutamine or 2, but not really more than that. But again, it was FDA approved based on the efficacy data, but again, safety, well tolerated, but the GI is a huge problem for us. And then crizanlizumab, it's a P-selectin inhibitor, as I mentioned earlier. It is IV medication, I should say. L-glutamine is oral twice a day. Criz is once every 4 weeks as a P-selectin inhibitor. It also showed, on these, the cumulative kind of event rate, again, time to first and time to second pain crisis also significantly better when, especially you have the higher dose of crizanlizumab was significantly better overall. And these are kind of months until that kind of event happened. So you can see, and that was phase 2 data for 16 years and older. I think, since then, we haven't really had a lot of success from the clinical trial perspective. The phase 3 was negative. The pediatric study was negative. The other molecule from GBT, Pfizer, inclacumab, was a P-selectin also every 12 weeks, was also negative. So I feel like the P-selectin as a category is kind of dying, I guess, but we still use P-selectin, or CRIS for a few patients who really don't want to do L-glutamine, can't tolerate it, don't want to do hydroxyurea, and not ready for gene therapy yet. So we still use it if they are willing to come to the hospital every 4 weeks. Side effects, are definitely kind of more fever, pain that can happen at the time of the infusion reaction. But I would say in general, it is very well tolerated, compared to even L-glutamine, just as an example. And then voxelotor, these were the earlier data that we had from the HOPE trial. And that really looking at the hemoglobin change, and you can see the average, with the dose of 1500 milligram was about 1 gram, and that was sustained for 24 weeks compared to placebo or compared to the lower dose. And the HOPE study is really what led to the initial, I guess, FDA approval of voxelotor. We saw the same results for pediatric patient also among around 1 gram overall, and that's up to 24 weeks. And then some of the side effects were kind of GI, but last year we had, or a couple of years ago now, we had the FDA, we had the just announcement that Pfizer withdrawal like oxybryta from the market because of concern related to safety and VOE, and there have been some data continue to come out, but there is maybe like a talk out there that maybe it might come back to the market. I don't think we know for sure, but right now there is definitely even lawsuits against for the drug just because of the complication that some patients had. And then if we switch to curative options, again, I said I skipped stem cell transplant, but really kind of, for stem cell transplant, it's matched sibling donor is still the standard of care. And alternatively, you can, if you don't have a matched sibling donor, you can move on to gene editing or gene therapy. And in that context, Casgevy or CRISPR-Cas9 with gene editing, I think Haider did an awesome job kind of explaining the science behind the process for gene editing with CRISPR-Cas9. But as you can see here, we're talking about like 93%, 94% really resolution of VOE, and of course, normalization or near normalization of the hemoglobin levels, markers of hemolysis. And this is what we call a swimmer plot, where you can see on the left side, patients having all these kind of VOE event as represented by the dots. They got the infusion, got support after, but then the green lines are really kind of more clear. And we had several of our patients who have participated in the trial or have received the product commercially. And again, it definitely has been life-changing for many of them. And then the same with Bluebird Bio with like lentiviral vector, also in a similar way. We see about like 90% response rate. The biggest downside for both of them, as Haider talked about it, is busulfan and myeloablation conditioning regimen. And I think, having them commercially for patients has been a blessing. And I think it's important to highlight the benefits that patients have long-term and short-term. What about pipeline therapies? There are really kind of a bunch, I would say, like pyruvate kinase activators. There are 2 of them, etavopivat, mitapivat. And then there is one from Fulcrum for hemoglobin F induction, other F inducers from Novo, BMS, and others. And then the 601 from GBT, Pfizer. But maybe we'll just talk about the 2 that recently had some data. So the first one was mitapivat, and that's the Rise Up trial from Agios, and they met part of the primary endpoint, which was the hemoglobin response. So about 4 out of 10 patients, or 40%, had achieved this 1 gram increase of hemoglobin. They have, better hemolysis marker with lower bilirubin and reticulocyte count. They had trend toward fewer pain crises, but was not statistically significant. However, when you really look at those 40% that had the hemoglobin response, these ones had actually clinically meaningful benefits or reduction in their pain crises and better fatigue scores. So I think, from that standpoint, can be a good option for some patients. More recently, we had data from the Hibiscus trial for etavopivat, which is again another pyruvate kinase activator, and it showed further reduction in VOE or VOCs by 27%. So, and that was actually statistically significant. And they were also able to extend the time to first VOE or VOC from 20 weeks, almost double, to 38 weeks. The data are really very limited. It was just a press release. They also met the primary endpoint for hemoglobin. So half of the patients had this kind of 1 gram increase. And it's oral once a day. Mitapivat is oral twice a day. So both of them are convenient, and overall, both of them were very well tolerated. And again, and the last one is BEAM 101, which again, base editing and also focus on increasing fetal hemoglobin, and also have shown some really good data for patients, with almost everybody now kind of responding, because it's more precise approach. And I think, we have seen some recent data at ASH and EHA, and I'm sure we'll see some more later this year. And again, you can see that, the fetal hemoglobin was almost like 65%. And again, the hemoglobin S is only 34. So really more becoming a sickle cell trait patients, again, similar to what we have seen in Vertex, but just a very different approach overall here, maybe a little bit higher F for sure. And in general, when we are talking about patient, it's important to kind of engage stakeholders in all ways, from research to education activities with like online or like in maybe running events with patients, and really partnering with advocacy groups and professional societies to increase awareness for sickle cell and the treatment options coming in the pipeline. So in conclusion, sickle cell disease patients experience many complications across their lifespan. All of these complications lead to significant impairment in their quality of life. Hydroxyurea is the standard of care and really first-line DMT for sickle cell. Novel therapies such as L-glutamine and CRIS are effective but have their own limitations. Emerging ones are really promising, and hopefully in the next few years, we're going to have more options for patients so they can really choose what works best for them. And again, curative options, as I always tell my patients, it's kind of high risk, high reward, right? So you have high reward with higher response rate, like 90-95%. Don't have to deal with sickle cell disease anymore, but it's a little high risk, right? Because you have busulfan, myeloablation, fertility, risk of secondary malignancy. So definitely not for everyone, and everybody's risk tolerance is different. I would like to thank you all for your attention, and like to thank patients, families, my mentors, mentees, and funding agencies for believing in our work, and be happy to take questions. Thank you so much.
Thank you so much, Dr. Badawi, for the excellent presentation. I think there's one question. A question for you, Dr. Badawi. Impact of universal newborn screening on sickle cell disease landscape.
Yeah, of course, newborn screening, I think, has been so important for all of us here, because that's kind of a way of making sure we know about patients when they are born, right? So we can initiate penicillin prophylaxis early on, and we know that this has been very effective in preventing, sepsis and early mortality in patients when they are infant. So, and the way we do it here with the newborn screening is, if somebody is flagged on the testing as positive or potentially having sickle cell disease, a letter or a report would go to the patient or the family. A letter will go, to the Department of Public Health. A letter will go to us as the referral center for sickle cell in the state of Illinois. So, and one go to the pediatrician. So really kind of more like everybody will get the same notification to make sure that no patient is missed. And of course, it kind of improved survival outcomes and improved health outcomes, short and long term, for patients.
Thank you so much, Dr. Badawi. We move now to the next speaker. Our next speaker is Dr. Charles Azar, Medical Director, Comprehensive Sickle Cell Disease Treatment Center, Massachusetts General Hospital. Robert Kraft Chair of Diversity, Equity, and Inclusion, Harvard Medical School. A transformative leader dedicated to health equity, Dr. Azar focuses on restructuring care models to build true medical homes for patients with sickle cell disease, combining clinical excellence with vigorous political advocacy to combat systemic healthcare disparities. Welcome, Dr. Azar.
Thank you so much, Dr. Ahmadi, for the invitation, and thank you all for having me here today. I'm hoping to just be able to pick up right where Dr. Badawi left us, because he alluded to some of the work that we are doing in gene therapy, and I'm hoping to be able to expand a little bit on the transformative therapies landscape for patients living with sickle cell disease over the course of the next few minutes. But first, let me start with the patient story, because I think this story really summarizes what it's like to take care of patients living with sickle cell disease. And I think Dr. Badawi did a beautiful job of laying out some of the really important psychosocial stressors that our patients face, and how absolutely integral it is to consider those factors as we are treating our patients. I raise all of these concerns again because as we're talking about gene therapy and allotransplant, all of these factors are really amplified tenfold as we're taking care of our patients. So this is the story of a young man, a very real patient of mine named Jeff, who is 30. Jeff has SS disease, or sickle cell anemia, and really the disease has touched nearly every organ in his body. He had his first stroke when he was 3 years old. He suffered severe osteonecrosis that led to bilateral joint replacements before he was even 20 years old. He's had multiple blood clots that have required him to be on lifelong anticoagulation, and he suffered severe hyperhemolysis syndrome, which makes it very challenging for us to be able to transfuse him when he has severe complications of his disease. But really, this is just one thread in the story, because he has suffered with this disease his entire life. He has significant depression from multiple hospitalizations across multiple states. He has suffered significant PTSD and severe anxiety related to his symptoms and medications as well. But really, also, that is just one thread in his story. From all of these components, he struggles with trust. He's had multiple hospitalizations across multiple states. He's been accused of being a drug seeker. He's had his pain medications removed from him without any conversations about exactly how to better manage his pain. And these threads together have led to him having significant challenges in holding down a relationship, being unable to keep a job, and being unable to complete school. Together, all of these threads form this big tangled knot that we call sickle cell pain, what I prefer to refer to as sickle cell suffering. And we attempt to try to treat this entire thing with IV morphine or IV Dilaudid, and it doesn't work. So we're going to come back to Jeff's story at the end of my talk as well, but it's quite illustrative of the way by which we manage our patients living with this disease. As Dr. Badawi and our colleagues previous to us have mentioned, sickle cell, as you all know, is the most widespread inherited life-threatening blood disorder in the world. Here in the United States, it's said to impact about 100,000 people. We are so far behind in our understanding of this disease that we actually have not moved the needle on even understanding how many people actually live with the disease in this country alone. That 100,000 number doesn't make any sense when you consider the fact that 1 in every 14 Black babies born in the US has sickle cell trait, and 1 in every 365 Black Americans has the disease. And when you extrapolate that across the Black and brown population here in the US, you can very quickly understand how that 100,000 number is a gross underestimate. I don't have to tell this audience that sickle cell touches nearly every organ in the body, and is illustrated in Jeff's story at the beginning. Really and truly, the patients can suffer complications from their bones to their kidneys to their brain, heart, lungs, and eyes. And that this further emphasizes what Dr. Badawi was talking about, the importance of having a multidisciplinary, comprehensive approach to the management of sickle cell disease, so that we can get at all of the complications that this disease can potentially give rise to. But the pain is the most common reason why our patients seek medical attention. And I emphasize this because this is the crux of what we know about what gene therapy can potentially help us with. The pain of sickle cell disease peaks right around the time that I, as an adult doctor, am inheriting these patients from my pediatric colleagues between the ages of 19 and 39. And while we know very little about what the end of life in sickle cell disease in adults looks like, one of the few things we do understand is that the more frequent these painful vaso-occlusive crises occur, the higher the mortality of the disease. And that in the final year of life, for most of our patients, that final year is often pockmarked by the most frequent episodes of pain crises over the course of their lifetime. Our director of our National Institutes of Health here referred to the pain as worse than that of childbirth or cancer or trauma, the worst pain known to humanity, he referred to it as. And our patients will oftentimes tell us that everything from psychosocial stressors to changes in the season and humidity can induce these crises, but oftentimes they cannot tell us at all what may have potentially brought on the current crisis that they are experiencing. What's really important to emphasize is that there is not a single lab test or imaging study that has accurately been able to demonstrate an uncomplicated, painful vaso-occlusive crisis. And this is as frustrating for us as data-driven medical providers as it is for our patients who have to prove to their doctors and nurses when they walk through the door that they're actually having pain. My patients have described this as the sensation of hot pokers being run through their body, to the feeling of all of my bones breaking from the inside. One of my patients describes it as the sensation of broken glass being poured through my veins. It is excruciating for me as a provider to watch my patients suffer with this disease. I cannot even imagine what it is like to be living in their skin. I will not belabor what Dr. Badawi has beautifully talked about in terms of the treatment landscape for sickle cell disease, but suffice it to say, hydroxyurea is what we have been left with for the last 3 decades. And as Dr. Badawi outlined, crizanlizumab, voxelotor, and L-glutamine have all been fraught with challenges. Ultimately, crizanlizumab being pulled in Europe, still available here in the United States, but we're not sure how much longer it will be available given the data that he shared with all of you. Voxelotor, as you all know, was pulled globally, and as Dr. Badawi alluded to, there's a possibility this drug may come back, but it's going to be very interesting to see in what capacity anyone will accept this therapy after the way that it left the market. And then L-glutamine is very limited in its efficacy and must be used with hydroxyurea to really bear out its full efficacy. Just like in his clinic, I very rarely use this in my practice here at Mass General of Boston. So let's talk a little bit about bone marrow transplant, because bone marrow transplant remains the only potentially curative option for sickle cell disease in the world. Despite what the media has said about gene therapy, it is not, in its current iteration, a cure for the disease. We are hopeful that that's what the data is going to ultimately show us, but thus far, the only curative option we truly have data to support is hematopoietic stem cell transplant. And as you can see on the screen, several studies around hematopoietic stem cell transplant have demonstrated a superb SCD-free 5-year survival and an overall survival. So with numbers like these, why is it that we are not just transplanting every baby born with sickle cell disease when they come into this world? Well, here in the United States, the American Society of Hematology, which has been our governing body, our North Star, really only released guidelines around the use of stem cell transplant in sickle cell disease 6 years ago. And those guidelines recommend that the optimal time to be able to do a transplant is before the age of 12. After that age, the complication rate can increase by as much as a fifth. You can imagine that having a conversation with a 10-year-old or an 11-year-old about whether or not they would want to potentially undergo what could be life-saving or life-changing treatment versus receiving chemotherapy and undergoing a transplant that could potentially rob them of their fertility or lead to lifelong complications or risks of secondary malignancy, that's a very, very difficult conversation to have with someone that young. The ASH guidelines also further recommended that a matched sibling donor is the best option to be able to do an allogeneic transplant. But as you all know, in a disease that can affect multiple members of the same family, trying to find a matched sibling donor who's not also affected by the disease can be challenging. And that then leaves us to have to go out to the national bone marrow registries. That's extra challenging here in the United States, where 80% of white people can find a match, but only 17% of Black Americans can find a match in the national registry. Furthermore, you need to be able to have access to a treatment center that has experience managing patients with sickle cell disease, which is much fewer and far between. There are, for reasons we don't fully understand, higher rates of graft failure and graft versus host disease in our patient population. And of course, the conditioning chemotherapy leads to hair loss and potential infertility, all of which can oftentimes be a non-starter when we're having these conversations with our patients about the disease. But to sort of help differentiate this for you from gene therapy, I just lay out here very graphically that the difference here is simple. Allogeneic transplant, which is, again, our only established cure, requires donor stem cells. Then the patients receive some sort of preparative conditioning chemotherapy. And then these patients will then get a restoration of their red blood cells through the receipt of the donor stem cells. So let's shift gears and talk a little bit about gene therapy. And I start this conversation with one of my favorite quotes. The time was fast approaching when the first should be last and the last should be first. This was written by Nat Turner here in the United States about 200 years ago. And even 200 years now after he wrote those words, we may be finally entering the era that he thought he was entering into in the 19th century. To differentiate gene therapy from an allogeneic transplant, here we are dealing with an autologous transplant. The patient's cells are edited, and then ultimately those same cells are what is being used to restore red blood cell health. The hope here, the promise of this intervention, the reason why it is on the horizon for us, is that it does not carry the same risks of graft versus host disease or graft failure that we see with allogeneic transplant at higher rates in patients with sickle cell disease. So when we talk about gene therapy, there are multiple approaches that are currently available, and Dr. Franjoul talked a little bit about this when he was talking about the landscape in thalassemia. Very similarly, we have those same options in sickle cell disease with lentiviral transfection approaches, the use of CRISPR-Cas9 technology, and now the newest kid on the block, base editing technology, which we'll talk about very briefly as well. But let's talk a little bit about the current approach, which is to target fetal hemoglobin or an analog of adult hemoglobin that can act very similarly to fetal hemoglobin. And as Dr. Franjoul, I think, very beautifully talked about in his discussion, the goal here is to try to take advantage of what we already know about the role that fetal hemoglobin plays in sickle cell disease. Hydroxyurea, we think, works by raising fetal hemoglobin levels. And we've come to understand over the years that in patients who have the hereditary persistence of fetal hemoglobin, the natural ability to continue to produce elevated levels of fetal hemoglobin, their risk of complications from sickle cell disease is markedly diminished compared to their colleagues who do not have the same ability. So it was thought that if we could target the fetal hemoglobin in this way, we could potentially help patients with sickle cell disease live very much akin to those patients with the hereditary persistence of fetal hemoglobin. And in doing that, we look at BCL11A, which Dr. Franjoul had spoken about and which I will not belabor again here in my talk. But ultimately, trying to replicate this in these patients became the crux of what is now commercially available gene therapy. But the current approach is long. The treatment journey for patients undergoing gene therapy, on average, from beginning to end, takes about a year. And it starts with the cell collection phase. This is a phase of the process that we are learning a lot about as we are sort of building the plane. Because a lot of information was not ultimately disclosed initially when these therapies came out onto the market. One of the very important things that we're learning is that age matters. In our patients over the age of 30, we are really struggling with the ability to collect enough cells using the two commercially available gene therapy products to be able to help them ultimately have enough to be able to go forward to treatment. There are things we are learning about how we can modify what we do in the management of those patients around the time of cell collection that involves both our apheresis machines and the way that we can optimize the nutritional status and hemoglobin levels in our patients going into that process. but it is more challenging, not impossible, but more challenging in our older patients. Ultimately, once they're able to collect those cells, and the studies suggested an average of 2 to 4 cell collections for the 2 commercially available products now, then those cells are then sent off to the manufacturer, and this is really the slowest part of the process. On average, the manufacturers are taking about 3 to 6 months to turn around a completed product, although they are expediting that, and that is becoming much faster now. Once those cells are available, once the gene-edited cells are finished, then the patient undergoes the lengthy hospitalization, the 30 to 45-day on average hospitalization, where they are receiving busulfan chemotherapy to condition them, to eliminate their existing bone marrow, and then receive their own cells back. And then they're then sitting in the hospital waiting for their new bone marrow to be able to grow up and allow them to have the immune function to be able to live outside of the hospital again. So let me just share with you some of the data around the 2 commercially available products. And Dr. Farjul had shared some data around Casgevy. Dr. Badawi also shared some of the data around both Lovocell and Exocell. And I'll just get into a little bit more detail and just go beyond a little bit what they shared with you. But this is Bluebird Bio or Genetics' product, Lovocell, one of the 2 FDA-approved products. This is the product that uses lentiviral transfection and aims to try to amplify a modified beta globin gene that blocks hemoglobin S polymerization. And as you can see on the screen and the data that Dr. Badawi had shared before me, patients who received this product ultimately had an 88.2% complete resolution of vaso-occlusive crises in the immediate follow-up period, which was really, really exciting. We're going to come back to some caveats to this here in just a few seconds. But if we then look at the next product, Exocell, this is Vertex Pharmaceuticals' product, and this is the product that uses CRISPR-Cas9 technology. Dr. Franjul talked about this product because it is what is also used to treat patients with transfusion-dependent thalassemia. And very similarly to what we saw with Lovocell, we can see a very significant complete resolution of vaso-occlusive events in patients who received this product. Again, some caveats, which I'm going to come back to here in just a second. But Dr. Badawi very briefly touched on the Beam 101 trial. This is the newest kit on the market that we're all very interested to sort of see what the data continues to show us. Beam's product is attempting to use base editing technology to target BCL11A in a very different way, and once again, raise the levels of fetal hemoglobin. And so far, with the information that we've seen, we're seeing a really great increase in fetal hemoglobin, a reduction in hemolytic markers, and what may put this product ahead of the others, if this continues to hold up, is that the collection times, the amount of cells needed, is substantially lower, and the median time to neutrophil engraftment once these patients receive their cell is also better. So this sort of poses already in very short order a really interesting new frontier direction for gene therapy to be able to take. But as both of the 2 gene therapy products, Lovocell and Exocell, are on the market, and now Beam is coming out onto the market shortly with their product, there are still a lot of unanswered questions around the use of gene therapy. Ultimately, the FDA has approved both Exocell and Lovocell here in the United States and in Western Europe and in other parts of the globe, in the Middle East. The products were approved for patients age 12 and older who have 4 or more vaso-occlusive crises over the course of a single calendar year. And that's really left up to the discretion of their physicians to be able to document those. Here in the United States, insurance coverage is variable. The cost of Casgevy, or Exocell, is $2.3 million here in the US. The cost of Lyfgenia, or Lovocell, is $3.2 million. This does not count the additional $1 million price tag on average associated with the bone marrow transplant that patients still have to be able to receive in order to get these products. There's enormous variability from state to state here in the US about what state healthcare, which so many of our sickle cell patients are dependent upon, will actually cover. And in several parts of the world, including our neighbors to the north here in the US and Canada, there are a lot of limitations on what insurance will actually cover or not cover for these patients. So ultimately, the questions that are left to us are, how do we ultimately maximize access for patients here in our country? And how do we scale this development for use across the entire globe, where the vast majority of patients with sickle cell disease are living? The other caveats that I was mentioning, that I was alluding to as I was talking about these products, are that the data demonstrated that patients who walk into these therapies with chronic pain have poorer outcomes in terms of the reduction in their pain crises after gene therapy. And it's not clear what that speaks to, whether there's a difficulty in being able to discern acute versus chronic pain, something we know is true in many of our adults with sickle cell disease, or whether there is something different about patients who have chronic pain going into these therapies. But I counsel my patients about that important caveat as we're talking about the gene therapy process. Here in the United States, these pharmaceutical companies have established a model of the authorized treatment center and creating a sort of spoke and hub model where there are centers available, and that ultimately other hospitals that do not share the same resources can send their patients to those authorized treatment centers to receive their treatment. Here in our country, the National Alliance of Sickle Cell Centers has set their own guidance for really what should define an appropriate center to deliver gene therapy. And the important thing here is that it must include a designated sickle cell team that can work hand in hand with the bone marrow transplant doctors. This should not be just done by bone marrow transplant doctors on their own. As Dr. Badawi alluded to, there are significant social barriers to care for our patients that are amplified tenfold when you're taking patients through a treatment that is requiring them to have to come back and forth to the hospital very frequently. So what we've done here at Mass General is created a model that very much resembles a liver transplant board or a kidney transplant board. Our coalition with our sickle cell team, our bone marrow transplant team, our apheresis team, and our palliative care team all gather with our nurses and social workers once a month. In fact, our meeting is actually happening later today, where we talk about all the potential candidates for gene therapy and allotransplant, and we walk through their potential candidacy, the risks, the adverse events that they could stand to potentially gain, looking at their renal function, liver function, and pulmonary function as we decide on their candidacy for the management of the disease with gene therapy or allotransplant. This is the extraordinary team that I get to work with every single day. We have a dedicated specialist for every organ that this disease touches. We have 7 primary care doctors embedded with us in clinic so that our patients can get specialty care and primary care at the exact same time. We also have an integrated pain and suffering management team and medical exercise program that our patients can tap into as well. But it takes all of these individuals to assure that our patients are optimized to be able to go through the transformative therapies journey. Ultimately, trying to break down these social determinants of health has been especially challenging. Here in the United States, the American Cancer Society provides lodging for patients who are undergoing bone marrow transplant for cancers. We do not have such resources for patients with sickle cell disease. So we have had to raise philanthropic funds at our center that allow us to be able to partner with housing organizations to provide transportation costs for our patients, to help them pay the rent if they are unable to because they've been in the hospital for so long. We can provide them with a cell phone bill. We can even provide them with educational and vocational training resources. But the hospital gives me none of this. All of this is philanthropically funded, and there is no national or global resource center by which to overcome these barriers for our patients living with the disease. At the same time, here at our center, we are building the first of its kind survivorship program as our patients are now living well into adulthood, bringing together palliative care, nursing, social work, and primary care to be able to help replicate what our oncology colleagues have done for so long in cancer, to be able to help our patients start to think about what their lives are going to look like as they're able to live into their 50s, 60s, 70s, maybe beyond for the very first time. And very important to our center is that we are carrying out true political advocacy work to try to change legislation here on the ground. One of the important things we're trying to push here in our state is to be able to get a bill through that would allow fertility preservation to be covered by state insurance so that patients don't have to make the choice between receiving transformative therapy and having a child. So I want to end here with this extraordinary picture of our patient, Alan, who was the very first patient in our state to get gene therapy. He had it here at our center. And this is him leaving the hospital after his about 28-day hospitalization, getting his cells. Just a few weeks ago, Alan graduated with his master's degree. He's from Uganda originally. For the first time this last holiday season, he was able to go and spend 30 days in Uganda with his family without being worried that a crisis was going to hit him and that he was going to have to fly back to the United States to be able to get ongoing care. Ultimately, there's enormous excitement around gene therapy and these transformative products. But at the same time, we have to think very long and hard about how we roll these treatments out so that we can make this accessible across the entire world. And we can assure that we're breaking down the barriers that would prevent patients from otherwise being able to access this treatment overall. And I'll stop there. I'm very happy to take any additional questions.
Thank you so much, Dr. Azar, for the excellent presentation. You're a real transformative leader dedicated to health equity. Now, there's one question for you. What is the upper age limit for gene therapy in patients with sickle cell disease?
That is an excellent question. So here in the United States, the FDA has not defined an upper age limit. And the National Alliance of Sickle Cell Centers has attempted to try to understand who the ideal candidate is for gene therapy. And we, in our conversations and our meetings every year, have talked in the last couple of years about what that upper limit should really be. Because we are finding so many challenges with patients mobilizing their cells over the age of 30, we are talking to patients in those older age groups about those potential challenges. I had one patient here who could not go forward with treatment because we simply could not collect enough of her cells, and she was 36 years old. It was very devastating for her, as you can imagine. So there is no upper age limit, but all of these things that we're learning as we're rolling out these therapies are factoring into our considerations.
I think there's another question for you. No, thank you so much, Dr. Azar, for the excellent presentation, and thank you so much for joining us today. Now we come to the distinguished colleagues and dear friends. As we conclude day 2, I would like to express my sincere appreciation for your continued engagement and thoughtful participation. Today's sessions have been marked by outstanding presentation and rich scientific exchange. The depth of expertise shared by our faculty and the quality of discussion among delegates have once again demonstrated the strength of this global community. I'm grateful to our distinguished speakers for their valuable contributions and for all participants for making this day both productive and inspiring. We look forward to welcoming you tomorrow for the final day of the conference. Thank you and good evening.